Looks like it's right at 9 o'clock.
Recording in progress.
All right. So I think, like we covered last time, this is not a committee, so we are not going to open or adjourn or call ourselves to order. But we are going to. I'm going to run through quick the names of the folks who are on the task force, and then we'll get started. We have Dr. Fred Therese and Jennifer Deegan, Olga Rodriguez, Kathy Thomas, Dr. Jason Valerio. Jackie Ward's not here today yet? No. Okay. So Dr. Zerwas will be off and on today online. He is online. And Cheryl Peterson and Jack Dwyer. So those are the task force members that we have present today. As you all will remember, we created three groups from the over 60 advisory committee members that were nominated to participate and selected to participate. And we defined three different topic areas. The first was expanding the pipeline. Second was modernizing the production model. And the third was expanding and enhancing clinical trials. Today we're going to hear a summary of the workshop that was conducted for those first two work groups. And they will give us a good idea of how those discussions went and the feedback that we got. We have learned that one of our co-chairs for work group 1 is stuck on I-35. God bless him, and we all hope that goes well for him, and we've all been there. So we are actually going to have to start today with work group 2. I do want to say, for those of you who wish to make recommendations to the task force, please submit those now. Submit those by email, or you can provide public testimony, public input today at the end of the hearing, even if you haven't signed up yet. There is a sheet in the back for everyone who is going to be giving public input today. You'll have 3 minutes to provide that, and I just made Sydney very happy down there. Just to let everybody know. So we're going to start the agenda. It is a very, very long agenda today, so we ask everyone, where possible, to provide us with a summary of your remarks as opposed to reading the slides. So work group 2, modernizing the production model, Dr. Cindy Weston and Dr. Deborah Jones. Dr. Cindy Weston is with University of North Texas Health Science Center, College of Nursing, and Dr. Jones is with UTMB School of Nursing. Thank you very much for being here today. And for those of us on the dais, you have to press the button, you have to talk into your mic, and the light on the button doesn't come on anymore, so you have to remember to turn it off.
I hope I pushed the button. Okay, great. I'm Dr. Cindy Weston. I'm the founding dean at the University of North Texas Health Science Center in Fort Worth, and we are the newest state-sponsored College of Nursing in North Texas and for the state. And I think it's fitting that I'm partnered with Dr. Deborah Jones, who is the dean at the University of Texas Medical Branch in Galveston, the oldest state nursing school in our state. So, and also where I received my BSN. We are honored, Madam Chair and distinguished members of the task force, to present a summary of what we found meeting as a work group for modernizing the production model. And you can see on the next slide, we were charged with reviewing the preparation of nurses specifically to the workforce, considering curriculum and clinical training, and determining whether competencies are best preparing our Texas students for the new and future realities of the healthcare workforce. And we had an incredible group that served on this advisory panel with us, and those members are on the next slide. It was a wide range of academic and healthcare organizational leaders as important stakeholders, and you'll find that on the next slide, please. You can see it's a representation also across our incredible state. I just want to preface any remarks today with why we're really here is about improving health and healthcare in our state of Texas. When we look at our state, our health outcomes are in the bottom quartile of the entire United States. And in many metrics, we rank last in accessibility and affordability of healthcare. And on healthcare scorecards, we're in the bottom. And we know that healthcare workforce is so important to address these health issues throughout our state. And we're honored to be a part of that solution. On the next slide, you'll see the stakeholders and presenters who presented specifically about nursing and nursing workforce and some interesting programs that are going on throughout our state. The Texas Nursing Workforce Studies with Pam Lauer presented to us. We had some wonderful presentations about innovations that are occurring in the pipeline, modernizing the pipeline production from TWU, Collin County.
I just want to tell you, that's the remote control for the slides.
Oh,
Yeah, sorry, that was my bad.
You
That was
don't
my
have
bad.
to advance them. I can. Thank you
That's
so
my
much.
bad, sorry.
Sitting right in front of me. Collin County was there, UT Arlington, UTMB in Galveston, Austin Community College all had wonderful presentations for us to consider that help frame the foundation of our discussion that day. And then we will together spotlight 3 of those programs for you to set the framework of policy discussion today. So our charge was specific to examining various models for the preparation for a nursing career with a focus on expanding those and creating pipelines and pathways to enter into the profession of nursing and considering whether high school preparation programs, dual credit programs, apprenticeships, and others were accessible and efficient throughout our state, and do current regulations are there barriers to entering those phases of preparation. This is so much better to hold this in my hand. And you have seen, and I really want to commend Dr. Jason Valerio, who put together a really nice document on how stackable credentials lead through pathways in nursing. And I know that there are others out there who are doing this, and as a new College of Nursing, this is something that we're very interested in crafting a college around this. But just as a quick reminder to this group and others that there are unlicensed opportunities to enter in and create a pathway and a pipeline toward nursing that involves certificates or certification, and that begins with a CNA or CMA or PCT, which stands for Patient Care Technician. Those are a lot of acronyms. CNA is a Certified Nursing Assistant. That's an unlicensed personnel, but a certificate that can be attained in high school. And they oftentimes work in skilled nursing facilities, long-term care facilities, and hospitals or healthcare organizations, community-based care, psychiatric care. CMA is a certified medical assistant, and they're typically educated around outpatient clinics, ambulatory care, and specialty clinics, so usually in an outpatient realm. And a patient care technician is not currently a certification at a standardized approach. These are curriculums that are often developed specific to a hospital or healthcare organization, and they are vital to the care delivered within hospitals and healthcare systems. So all of these roles, all 3 of these roles, are very important as pipelines and pathways into the nursing profession and also vital to healthcare delivery. The next is the licensed vocational nurse, and that is a licensed role in the state of Texas. And it's generally a 1-year training program, and it can be attained in high school. We actually have 6 programs in our state that we learned from our Board of Nursing that have excellent outcomes in preparing LVNs to serve in important roles throughout our state. And they serve across the entire continuum of care: skilled nursing facilities, long-term care facilities, facilities, outpatient clinics, as well as inpatient settings, and they're being used more and more in inpatient settings now. The next is the associate degreed registered nurse, and this is a licensed role. It's an entry into the registered nursing role, oftentimes delivered at community colleges. The next is the bachelor's degree in nursing, also an entry directly in as a licensed professional nurse, delivered at both community colleges as an RN to BSN or a traditional bachelor's degree in university settings. And then, although our charge was how do people enter into the nursing profession, there are individuals that enter at the master's level, and I think it's important to know that. We have some of those programs and degrees, but it is important to note that it's master's and doctoral prepared nurses that serve as the faculty, administrators, and the advanced practice registered nurses serving our state, both increasing access to care, increasing care delivery, and optimizing health outcomes in healthcare organizations. Without those master's and doctoral prepared nurses, we stop the pipeline of growth, and those are at university settings. I wanted to spotlight, and we had a great discussion of some important presentations that came to us of innovations that are occurring in this state. And one of those is at Baylor Scott and White in collaboration with Baylor Scott and White Health System in collaboration with Uplift Education. They call it a Scholars Experience. They received funding from Bloomberg Philanthropies to develop this public-private partnership. Baylor Scott and White, of course, is a very large healthcare organization within our state, one of the largest in Central Texas, expanding all the way up to North Texas. And Uplift Education has 45 schools throughout the U.S., 6 of which are in the DFW area, and they predominantly serve economically disadvantaged populations. As a high school or as a school system, they're actually ranked by U.S. News and World Reports amongst the top 21% of all high schools in the U.S., so they have excellent outcomes. And through this partnership, they have created a high school specific to the development of a healthcare workforce. So the students who will attend this will receive direct preparation toward the health disciplines. They actually have the ribbon cutting coming up in September, and they have 4 curricular pathways, one of which is specific to nursing. They expect 25 plus direct to workforce graduates by 2028. So this is an incredible innovation for our state, and their graduates will earn a CMA, Certified Medical Assistant, or PCT educational opportunity with dual credit options at the time of their graduation, their high school graduation, so propelling them on to nursing and other health careers. I wanted to also spotlight one additional presentation that was also incredibly innovative and also funded through the Bloomberg Philanthropies. They invested in 2 of these programs in Texas, and that is Hill High School in collaboration with Memorial Hermann Health System and Aldine ISD. HEAL stands for Health Education and Learning, and it's at Nimitz High School, which is part of the Aldine Independent School District, and direct collaboration with Memorial Hermann, who's having a substantial organizational investment into the preparation of these healthcare professionals. HEAL is looking specifically to prepare certified nursing assistants, CNAs, CMAs, and PCTs, as well as LVNs, along with other health disciplines like sterile processing, CT techs, surgical techs, and registered nurses. The graduates of this high school are expected to have 15 to 24 transferable college credits toward the Texas core and at least 1 industry certification by the time of their graduation. Memorial Hermann is also investing in a mentorship program that will begin in 9th grade for these high school students, with employment opportunities beginning in the 11th grade. So on to our policy findings and perhaps suggestions to this task force. First of all, I wanted to say that there was consensus amongst our advisory group that exposure and or preparation for nursing in high school is paramount to address the nursing workforce shortage in Texas, and an investment in that would serve our state well. The second was that dual credit programs are lower cost and they expedite the education into the nursing field. And the earlier education of these stackable credentials of really thinking about education differently with potential exit points so that they're serving in the workforce will benefit the state well. I showed the different pathways into nursing, but I did not emphasize that a gold standard, a goal for our state would be baccalaureate prepared registered nurses. That data has been in existence for 25 years, that hospitals and healthcare organizations that employ more baccalaureate prepared registered nurses have lower mortality rates, lower lengths of stay, lower healthcare cost, and better healthcare outcomes. So that should be a gold standard when we're talking about stackable credentials and where we need that licensed professional nurse practicing. And then, of course, we know we need those graduate prepared registered nurses to serve in other capacities within our state. So that upward trajectory on nursing education is essential. There was a large discussion about the expansion of paid apprenticeships, internships, and externships while these students are receiving their clinical education, where what I grew up in nursing as hearing as you're double dipping, you're earning money while you're getting clinical education is an old mindset. We have to reframe that students can engage in clinical opportunities while they're providing a benefit to a healthcare organization. But there was also discussion from the healthcare organizations that this may be transferring the cost of education over to them, because there is accreditation requirements that there would be qualified preceptors to serve in the role while you have a learner that is receiving clinical education while they're working in a healthcare facility. And there also are some implications with professional liability coverage if that learner is less than the age of 18. There's still some stigma across our state and maybe even within our professions of are high school students mature enough to serve in the complexities of the healthcare arena. And I think that what we heard from those who have engaged in high school activities with learners is that those who are selecting into these pathways in high school are your high achievers. But that is a concern throughout our state. And there have been some, as I mentioned, accreditation and perhaps certification barriers that need to be addressed. Some certification exams require an individual to be at age 18 to sit for a certification exam. There was a recommendation and just lots of discussion around a centralized nursing program application system for the state of Texas. That currently does not exist. There are about 29 schools in the state of Texas that use a centralized nursing CAS. It's a centralized application system. It's through our American Association of Colleges of Nursing. It's at no charge to the school, but it's a charge to the applicant for their application fee. They can apply to multiple schools through that one centralized application system, but there's no standard throughout our state, and many of our larger schools do not opt into this. And what we learned from the Texas Nursing Workforce Studies wonderful slide that Pam Lauer presented showed that we have unseated qualified applicants every single year in the state. But then we also have reported out and actually growing unfilled seats of those seats that are available. So if we could match those qualified applicants with the unfilled seats with our state, that would strengthen our pipeline for nursing education. And a centralized system would help do that. And that does exist, we know, in other health disciplines. There was a lot of discussion about a strong investment in high quality simulation throughout healthcare education. We've known this from the airline industry. You wouldn't want to get on a plane without a pilot that had so many hours of simulation. And we have seen, as we take a high fidelity evidence-based approach to quality simulation, that it actually can replace some of those direct care clinical hours. And at a time where the backlog in preparing a nursing workforce is a lack of nursing faculty, so a lack of those graduate prepared nurses to create the pipelines, and a lack of clinical sites of the direct care clinical training opportunities, simulation could be a wonderful opportunity to strengthen and reinforce that pipeline. It's been a decade ago that our National Council of State Boards of Nursing had a landmark study that showed that 50% of clinical hours could be done with high fidelity standardized simulation as a direct successful replacement for direct care hours. You notice I'm emphasizing evidence-based, high-quality simulation, but there's funding that needs to support programs to do that. It also came up that parents have become highly involved, particularly if we're backing up the pipeline to those less than the age of 18, of involving parents, particularly in some of the cumbersome mechanisms of applying for federal student assistance. And it was pretty much a consensus around the group that Texas could be a national leader by coming up with a standardized patient care technician curriculum and certification for this state. I'll move on to the final recommendations that came out is incentives. Incentives to prepare the nursing workforce would involve offsetting what is viewed as some of that cost that's transferred to our healthcare organizations through preceptorships and to the clinical settings that are investing in nursing education. And then an investment in incentives for taking these stackable approaches into education. I also wanted to bring up a lot of discussion around the Texas Education Association Health Science Career Clusters, which is that early education pathway. Right now, there's not necessarily standardization in the way that that is being accomplished. So some guidelines that would offer some standardization for those programs, and then increasing the availability of those programs, particularly in rural and medically underserved areas of our state. Quite honestly, the areas of our state that need these healthcare providers and nurses the most. And then finally, improving that access to dual credit and health-related pathways in the rural and underserved areas of our state. Dual credit is not always an option in some of the most austere areas of our state, and again, where we need to grow that healthcare workforce. And with that, I'm going to turn it over to my colleague, Dr. Jones, to address policy topic 2 and 3.
Thank you, Dr. Weston. Thank you, Task Force. And I definitely want to also echo what Dr. Weston said regarding the fact of how important this is, the work that we're doing. So I commend and thank the governor for commissioning the task force and you all for serving in that capacity. We're honored to serve as co-chairs for this work group. So I'll talk through the second 2 policy topics. Policy, so I now.
Yeah. Yes.
All right, we've learned. So policy topic 2 really focused on the curriculum in nursing education and how we are preparing our current students and whether or not they are getting the competencies that they need and the way that we're doing education, the innovative models that have come forward, are they the models that need to be continued in place, and can we expand those models and opportunities? We also looked at whether or not there were effectiveness in terms of the competencies. Are they preparing our nurses for the future? So I'll start with a little level setting as well regarding the curriculum, Texas nursing curriculum. We do have common courses that all of our students have to take before they enter into nursing school. And thank you to Dr. Hooper, who presented at the workforce group, who provided a lot of the information around this. So anatomy and physiology, microbiology, sociology, psychology, English, nutrition, human growth, and development. Those are the common courses that all students have to take before entering the nursing program. There also are mandated differential essential competencies that nursing students have to meet in Texas, in order to move through. And these competencies are pretty broad in terms of what the students have to meet. Those have been mandated since 1988, I believe it is, legislatively mandated. We also have 5 major content areas that all students have to do in didactic and clinical. So all of our students before they graduate have to have experience in adult medical surgical, geriatric, pediatric, maternity, mental health, and for the VN or vocational nurse, that's optional. And I'll talk a little bit about when we go through the recommendations about recommendations around some of these curriculum items. There are also different models in terms of how the curriculum can be delivered. They're structural and functional. So curriculum models can be delivered, and nursing schools have an option in terms of how they deliver the curriculum. It can be competency-based education that are based on specific competencies, knowledges and skills that students have to meet and master before they move forward. Concept-based curriculum, so specific concepts that the curriculum is set up around those specific concepts to move the students through. Block, where there is a certain topic area that's done in a shorter period of time, not the entire semester, and then students move to the next. Maybe there's pediatric, and then there's obstetrics. Integrated curriculum, where the didactic and the clinical and even some of the common courses are built in together, so anatomy and physiology, along with some clinical lab at the same time. Those are some of the integrated curriculum models. And then the medical model, which, as you know, is primarily disease-focused, specialty-focused. They have a residency period. They use a lot of problem-based learning. And so these are also models that can be used within the nursing curriculum. The way that it's delivered, face-to-face, hybrid, online, hands-on practice, simulation, skills lab, standardized patients, and computers and technology, most schools use a little bit of all of these to be able to deliver the curriculum, particularly because of the difficulty in getting clinical placements. So we have to use simulation, we have to do some skills lab, and to be able to provide all of the necessary hours that students need to move through the curriculum. So that was a recap of the topic area that we discussed. Looking at the consensus, what was really clear is that we do believe that our students are getting the competencies that are necessary for them to provide quality care, which is the outcome that we want our students to do. We believe that competencies that are within the DEX are broad enough that allow each of our schools to be able to meet them. We believe that some of the competencies that are across national standards also are broad enough and align where our schools are able to meet those competencies. We think that competency-based education can be an effective way to achieve essential skills and knowledges. And even though we think that our competencies are doing what they should do to prepare our students, there are opportunities in terms of how we deliver these and how the curriculum is set up. Concept-based education as well. It sets expectations, but it does still allow for individuality of our programs, which is absolutely necessary with so many programs and our ability to be able to move students through. Our clinical environments, they move quicker than academia. So even though we may recognize that there are things happening within the clinical setting where they can shift and provide those at the bedside and training to those nurses at the bedside, academia does have a set competencies, regulations, accreditations that we have to stick to. So being able to amend our curriculum to add things in and out isn't as easy or quick as we would want it to be. During the pandemic, we absolutely learned to do things a little bit different in terms of being a bit more nimble and being able to add things like emergency response, public health into our curriculum that wasn't there. And we learned to be able to deliver it in ways that we hadn't done before. So what we do know within academia is that we can be nimble and we can move a bit quicker than we have previously. It is just tradition-based when you think about the way that we do education. We also agree that there are innovations in nursing educations that are absolutely necessary. New clinical models are necessary. Integration of technology is necessary. Artificial intelligence and how we use that in education. Telehealth and simulation, and being able to use some of these things in terms of how we deliver our curriculum is something that we have to focus on. Those things will not go away. We have to embrace them. It is about figuring out how we can do them most efficiently. When it came to thinking about the way that we educate and what were some of the barriers, there were, if you think about competency-based or concept-based curriculum models, they are resource intensive. It does require a number of investment in training faculty and how to even do assessment, how to do evaluation, how to set up their courses and curriculum related to this. It requires technological infrastructure to be able to deliver some of this, to be able to provide some of the simulation or artificial intelligence. We have to have the infrastructure in place for our students to not be disenfranchised, as well as for the faculty. Robust assessment and evaluation, competency-based curriculum itself. Now, there's time series competency-based curriculum, and then there's competency-based curriculum that's not based on the time. So time series where students can take classes and once they get mastery, they move on to the next subject area. And it doesn't have to be a full semester, it doesn't have to be a block week, but as soon as those students have demonstrated mastery, they're able to move forward. And then those are the models that are competency-based that are still semester or block curriculum. And so in order to be able to switch our curriculum to a competency-based, it requires a lot of resource to be able to learn how to do this. It requires a number of faculty to be able to be ready to pick up those students when they're able to move forward to that next mastery level. Technological limitations, there are, particularly in rural and underserved areas, we're thinking about broadband and access to broadband and the ability to be able to have virtual training within those rural areas, not only for our students, but for our faculty. Clinical sites, which you've heard of quite a bit, that is, there's still a major lack of clinical sites, and particularly for some of the major content areas like pediatrics, maternal behavioral health, and maternity. And so there was conversation related to how can we do those, and can we do those differently than we have before. Typically, schools of nursing expect the same level of clinical hours and clinical training and the same types in these areas, but we talked about whether there were ways to specialize this in terms of maybe pediatrics. If you weren't going to directly into pediatrics, you did that through simulation only, or you had a smaller number of clinicals in that only, but you were exposed, but it was just more specialized to where the student was going to practice and not necessarily the generalist nurse. And time commitments and financial constraints. So investment. Our investment for this, some of the suggestions or recommendations is really to invest in models of academic practice partnerships that will work well. So those partnerships between the higher education, the schools of nursing, the colleges of nursing, and the healthcare settings. Partnerships that will allow joint appointments of faculty, partnerships that would allow sharing of resources, sharing of technology, partnerships that would allow more of the pipeline into the profession from the college or the school into the healthcare setting that allows us to seamlessly make sure that our students are getting the education and the training within that healthcare setting, and then also getting those jobs directly out of school into those programs. We talked about statewide clinical placement consortium. Because we do compete for clinical sites across the entire state, it would be helpful for us to have a consortium across the state that helps to place students everywhere. We would know where there are clinical sites that are available that we didn't know, and be able to move students easily across the state to have those clinical placements. If the consortium exists, it would just allow more collaboration around placing our students rather than the competition. We talked about universal affiliation agreements between academic and healthcare settings. So each school and each healthcare setting have affiliation agreements to be able to place our students within their clinical sites. And each of them have different regulations or requirements. Some may require certain vaccinations that others may not. Some may require certain checkoffs that others may not. And it is time consuming for both the schools and the healthcare facility for these affiliation agreements to be so differing. So if there were universal ones, that would ease our ability to place. We also recognize that there are some areas of our state who have clinical sites available and are able to take more students, some of the rural areas, but those of us who are not in those areas, we aren't sending our students 3 hours away to be placed. However, if our students were able to have housing that was paid for them, we could do those models. We could be able to provide or bus the students out for 2 weeks to do their clinicals in an area that had clinicals available if the student housing were free. database, we really look for having a statewide database that would help us in decision making. Database that would include where are our graduates going after they graduate? Are they staying in Texas? Where are they practicing in Texas? Are they moving around or moving out of the state? The application process. So a statewide database that would allow us to have information at our fingertips, the nursing deans, the academic leaders, to be able to look and make different decisions in real time related to our workforce. Tuition-free cohorts of students. Across the nation, many, you've probably seen many medical schools particularly have been getting funding for tuition-free cohorts of medical students. Tuition-free cohorts of nursing students, for those who would help fill these gaps, I think it would help to incentivize a lot of people who can't go to nursing school, who want to go to nursing school but don't have that ability to do so because of pay. And then the faculty pay equity or parity. So faculty, we talked about this in terms of, yes, a faculty role and a clinical role are different roles, so the pay would not be exactly the same. However, competitive enough where those who are in the clinical setting or those who are wanting to go into academia feel as though they can do so without having to downsize their entire life. We recently turned down, we were turned down an offer of a faculty position for a clinician because we could not make the pay cut. And then the third policy topic was around accreditation and regulations. So we looked at whether or not nursing preparation and education, how program accreditation standards, both state regulations, do they really help in terms or hinder how we're able to move nurses through the program? So we explored those topics and how can we adapt the needs for future students to make sure they have a quality education. So where there was consensus is that the frameworks that are in place within our state and those standards, as I said before, they cover a broad range of competencies and foundational knowledge that are needed to advance skills. We think that accreditation and the frameworks are necessary. They help to ensure that we meet quality standards for our students. It makes sure that we have the right faculty, we have the right curriculum, that our outcomes are being measured, and resources are in place. We think it promotes continuous improvement, and we think that clinical training is required and an essential component of education. However, when we think about the standards and the guidelines that exist, their interpretation of some of the standards and guidelines are different amongst different schools of nursing, which means that they may be implementing them differently, and the educational quality, the educational outcomes may differ and vary from different schools. Standards sometimes may be rigid or too rigid that could limit an ability of a program to be innovative or innovate really quickly or adapt to those emerging healthcare needs and advances. So having accreditation standards and frameworks in place may hinder in terms of our ability to quickly innovate. Resource intensive, and then securing the adequate clinical placements. So our recommendations related to accreditation, there was a lot of discussion and a lot of information about clinical hours, and I believe this came up in the first task force meeting as well, and whether or not there was a requirement for clinical hours. What we understand is that clinical hours vary and can vary across the state, and we have particularly RN programs that have clinical hours from 500 all up to 900 clinical hours, and so not even necessarily the average. And the thought is there may be, this may be hindering the ability, if there are 900 clinical hours, but best practices have shown that schools have done well with 500 clinical hours. Can we limit and standardize the amount of clinical hours so that it frees up some clinical spaces for other schools to be able to place students? We also talked about the fact that there are many nurses who have been out of practice for a while, but wanting to come back into practice. There are not a lot of avenues in place. There are a few schools within the state who do have programs to allow them to come in and get training competencies to reactivate their nursing licensure. We think if we could expand that ability and open that ability and access, that we would have more nurses who may return to the profession and return to the bedside and help to fill some of the workforce gaps. Increasing accessibility and availability of mental health programs, and that is not only within nursing schools, but within our nursing environments. really institutionalizing mental health programs, allowing them to be available to every nurse who is practicing, every nurse and faculty who are within our schools of nursing. And those are programs, peer support, counseling services, and those would be available to them free of charge. Support the nursing profession well-being. That includes flexible work schedules for nurses, child care, elder care, thinking of ways that we can incentivize our nurses to continue to practice and those to come into the practice. And then lastly, streamlining state, regional, national, and professional accreditation standards that would promote more efficiency while allowing individuality of our programs. So the standards exist, and as I said, there are different accreditation standards that schools have a choice in terms of which ones they use nationally. There are also the statewide regulations. If those standards and accreditations were aligned, we would be able to more quickly make sure that we are able to allow students to move through our programs, change our curriculum, and students to be able to go from program to program if necessary. And as Dr. Weston mentioned, we had a number of phenomenal speakers and examples of how things have worked very well in new programs and innovative models. And included with that was Project Arriba, which is in El Paso. And they had a wraparound services that they provided and they presented on. And this was amazing. It was phenomenal, and I think it's something that would be great if it could be expanded out. They looked at advanced retraining and redevelopment in the border areas. They had three distinct tenets to this program. It was intensive case management, where case managers helped to facilitate training and services for the students that were within their program. They provided counseling, they helped ensure accountability and help students move through the program. They had employment counseling, so mandatory weekly meetings with these students to help them develop skills that they're ready when they are finished with a certificate or a degree to go into practice. And then job placement. They placed these students, so it made sure that they were ready to take their tests and find employment upon completion of the program. It was absolutely a great example of a wraparound service that I think was very helpful in moving, could be very helpful to model. And with that, we will close for any questions.
I want to thank you both for all of the work that went into summarizing that, for participating on the panel, and all of our subject matter experts and advisory committee members who participated that day. It was a very intensive day, and you took all of that information and really condensed it in a way that I think is incredibly concise and powerful. So I thank you for that. I do know that I learned after our workforce that down in your region, Dr. Valerian, there is a project similar to Project Arriba. So there's more than one out there, and I think we definitely want to promote the growth of those programs. So thank you very much. Any questions from the panel? Go ahead.
I had one quick question related to simulation training and clinical hours. Do you anticipate there would be any pushback from the healthcare providers hiring and recruiting our nurses if those percentages changed one way or another with clinical simulation versus, direct kind of patient clinical rotations?
Okay, we're both like,
I know.
I'll start.
Go ahead.
So, so I think right now, there's a lot of data out there related to the ability to do simulation. Up to 50% of your curriculum you can do simulated experiences, and the quality does not change. With the discussion that happened within our groups, most of the Texas schools are nowhere near that 50%. And so there are some opportunities for us to increase it even to that level, the minimal level, without having any quality changes. And I think our healthcare providers recognize, and because they also use simulation in terms of re-educating and upskilling the nurses, I think they recognize that both things, that there is a need for clinical placements and we don't have enough to do so, as well as the fact that technology and the implementation of technology is something that we've learned how to do well. I don't know if you want to add to that.
I will add, and thank you for that question. And I have become a big believer in simulation over the course of I've been in full-time practice and full-time academics, and again, I preface all this with high-quality, evidence-based simulation. We know it works in the airline industry to prepare pilots, and when we take a model of high fidelity and apply that to the education of nurses and the healthcare workforce, that translation of building confidence and competence, where we validate their competence, the real learning and simulation occurs in a debriefing after the simulation has occurred, and running through an evidence-based approach where the learner is processing what did they do. What we discover is sometimes the learner did the right thing, but in debriefing you find out they did it for the wrong reason. And so you can help correct that mindset. And then of course the learners learn the most when they've done it wrong. And through that self-reflection and a guided debriefing, they realize, oh, I missed these cues. And what happens is that transferable skill now has come into the healthcare setting, and they don't miss it again because they've had a guided, safe, psychologically safe environment in which to learn that. The best simulations would be developed in partnership with our healthcare entities based off of what they're seeing as needs in that, and designing a simulation specifically around that. I'll give two examples. One is nursing students are not permitted to hang blood. And that is a high-risk intervention in a healthcare organization. A nursing student could run through a high-fidelity simulation and develop the competency and all of the checks and the safety mechanism for administering a transfusion in a simulated setting and be practice ready when they exit those nursing programs. You can put a student on a maternal child unit and they may never see a delivery. Those who do L&D know it's feast or famine. If they're there in a full moon, they might get a delivery, but they could be on that unit for several days and they never see a delivery. We can simulate a delivery in simulation so that every single nursing student has experienced what it's like to have a delivery, what it's like to have a postpartum hemorrhage, which is a low frequency but very high risk intervention that they need to know the steps to take. We can prepare them for that in high fidelity simulation. So thank you for that question.
I'll add one more thing to that, because there is a real world case study in 2020. Students were not able to do clinical practice for almost 2 years, and we know that the outcomes of that were that our students still went through and were able to pass the NCLEX with flying colors. Many of us saw no decrease in the NCLEX pass rate, and the state of Texas itself still were in the 91%. So I think we certainly have been able to show we had to do simulation, we had to do virtual clinicals and during that time period, and we were able to do it well and still provide some of the quality outcomes.
Just a quick question about the recommendation to certify the patient care technicians. Is the rationale for that to be able to track them or to standardize requirements, or can you expand on that a little bit?
That was exactly the discussion, is the standardization across, and to increase the opportunity of the pipeline and the pathway flow into that. Right now, for most entities, a patient care technician can enter into those roles with a GED or a high school diploma. And as we discussed, some of these new high schools are even backing that up into a preparation for that in high school. But the curriculums are different, basically tailored specifically to that healthcare organization's needs. If there was a standardized, a lower resourced healthcare entity could benefit from the proliferation of patient care technicians to aid in healthcare delivery in the healthcare workforce. Thanks.
I have a couple of questions. I'll do one at a time. So first, thank you for the presentation and some really great, very specific recommendations that seem like they could increase their efficiency and increase the numbers produced. The high school, the dual credit programs, and that pipeline program, which sounded incredibly impressive. My question about that is, if the pinch point is in clinical training sites and in faculty, do you envision sort of a phased approach, or are we creating new capacity with those programs where we increase the pipeline if we still are limited in the number of clinical sites overall that we can have access to? And I have another question, but I'll let you do that one first.
I see you looking at me. This is an innovation. It's a pilot test, I would say, in our state. So we need to track that. We need to learn what is going to be the long-term outcome of that, and what these two models that were presented to us were specific to healthcare organizations that co-invested in that model. So I think we'll learn from this as it rolls out. Having a centralized data tracking system, as was suggested, would give us some of this feedback as a state to see what is the cost benefit ratio on this for an organization to invest basically in a high school that's preparing their healthcare workforce. I would say we'll learn a lot from that. So I don't have a clear answer other than to say that I think that pinch point of the healthcare clinical site can possibly be filled with these clinical academic strong partnerships and looking at other care educational delivery models.
Dr. Cerise, I'm going to add to that just a little bit. Both of those programs are affiliated with a healthcare system, and those systems have made guarantees to those students that are on a clinical track that they will have a clinical placement. So in those two very specific cases, that's covered. I don't know that that's the case all across the state, especially at a CTE level. But in these very concentrated high schools, they've taken that into consideration. And not all the students are on a clinical track. They have a business track. They have an allied track. So the 4 tracks that they have. So they're not all of the students going into the nursing. So it's,
I love the idea.
Yeah.
My concern is, and I would even ask on that, or we replace or displacing other trainee slots for these newer slots with these new programs. And, are we overall increasing the capacity? Which actually, if I just go into my second question, because it's about the partnerships, and Deborah, you can sort of blend the answers. But because I love that you talk about tracking at a statewide level, looking at clinical training sites and trying to do that match, like I'm familiar with on the medical side, where you do a match and you try to fit trainees to slots. Those partnerships, did you guys get into much of, like, what's the incentive for the health systems? And I'm not talking about pay us to do partnerships, but are there expectations we can put on the health systems to participate there, since we're all benefiting from the graduates? And I think there are sort of ways that that are not necessarily financial, but expectations we could put on systems. But the first step would be tracking, trainees per beds, or who is participating and who's not.
Yeah, I definitely think so. Particularly health systems, to be able to, and I think a lot of them have that data. We don't necessarily ask for it or talk about it across academic and health system, but to know how many students they have in place, what's the availability, and if we were to expand or have some of these partnerships, how it would increase their ability to decrease costs for them, their ability to orient new nurses because if they have the pipeline and new nurses are being trained in their environment and then start working there, it'll decrease orientation costs. And I think there are a number of benefits that we could identify on the health system side that would entice them to go into some of these partnerships that were more than financial, because they're struggling in terms of workforce themselves. So being able to have that workforce, it is imperative for all of us to be thinking about this problem.
I just want to comment, because those things exist today. I'm wondering, if in some of the state payment programs there could be some expectations that you participate in some of these other things to be eligible for some of those supplemental programs.
Oh, that makes sense. Yeah, I certainly think so. And I do want to comment about or just make a quick comment about the first point about the displacement. I think that's why it's very important for us to recognize that this problem is there's not going to be one solution. It is multi-pronged, and we have to think about what the consequences are to just implementing one thing. And so some of the recommendations that we provided, which are, again, are not all inclusive, of course, of things that we should be thinking about, I think we have to think about them in concert in the overall picture and being able to provide support to do multiple pieces of this. I always, when I talk about workforce and the workforce shortage, we always talk about let's produce new nurses and get them in. But I think a lot of times we don't start with the fact that it's absolutely not possible if we don't have the faculty. It's absolutely not possible if we don't have the health system support. Now, even with clinical sites, we can think differently about our clinical placements. We think primarily about our acute care settings and putting them all in our acute care settings. We can think differently about that. We can look at different ways to do that as a nursing profession. And I think we have begun. It has not been globally spread yet, or we haven't systematized some of those things across. But so there are ways to do it, but we have to constantly think about the faculty, the fact that we need those, and then looking at all of this as a multi-pronged approach. But thank you so much for those comments because they absolutely get the wheels turning.
Mm-hmm.
Any other questions? Thank you both very, very much.
Thank you.
Really appreciate it, and excellent presentation. Okay, so Christopher made it. Yay! All right, so we now we're going to hear from Work Group 1, which was expanding the pipeline, and we have Christopher Metzgar, the Academic Success Health Sciences Dean from St. Philip's College down in San Antonio, and Mickey Hand, who is the Executive Director for Frontera Health. Thank you both for being here. And for the folks on the panel, please feel free. We have coffee and water in the back to get up and as you will. We also are not going to break for lunch, but there will be lunch brought back in at 11:30. So thank you all very much for being here.
Thank you for having us.
So we want to start by thanking you guys. We appreciate all the work that it's taken to set up these work groups, and it's so fruitful to see what Work Group 2 did, because what we did in Work Group 1 really kind of is feeding into Work Group 2 and setting that foundation. And so Dr. Weston talked about that entry level into the healthcare setting, and that's what we really focused on in Work Group 1. We had 58 virtual and in-person participants. And we really just focused on expanding that pipeline and looking at that entry level and how can we capitalize on that. And it's so interesting that in Workforce Group 2, some of those same thoughts and conversations were happening, very similar to what was happening in Workforce Group 1. So those are all the advisory members listed there. We had a great representation from across the state, different stakeholders, different universities, community colleges that are helping build this workforce currently. And then for our stakeholder presentations, there are some awesome programs happening in the state, and there's already some great work being done and some great programs in certain sectors of the state that we need to work on capitalizing and spreading across the state. So we heard from the Texas Hospital Association, the Texas Pharmacy Association, the Texas Healthcare Association, the Texas Association of Community Health Centers, Texas Association for Home Care and Hospice, the Texas Association of Business, Texas Workforce Commission, Workforce Solutions of West Central Texas, Health Professions Resource Council, North Central Texas College, and the College of Healthcare Professions. And just kind of building onto that last question, some of these are thinking differently. So community health centers, there's 74 in the state, and they're not necessarily acute care setting. And so how can we leverage these different partners to build that workforce and not overburden the systems that already have large student loads? So policy topic 1, given the expanding use of healthcare professions with certifications and technicians in every healthcare setting, how can the state better support this expanding need for allied health professions at these levels? This was just incredibly fruitful in topic 1. So we identified in-demand roles, which were pretty much across the board, needing CNAs, CMAs, surgical techs, radiographers. I think it got left off, but pharmacy techs too, and mental health technicians were some of the big ones that we were looking at. And interestingly, these are entry-level workforce that are really supporting nurses working at the top of their licensure. So when Dr. Weston was talking about the BSN level and making sure that we had good quality of care, these entry-level are taking some of that work burden off of the nurses so they can practice at the top of their licensure and also fill some of those gaps. One of the big overarching things is as we're looking to build this supportive workforce, we want to ensure that we maintain high standards for training and programs despite the high demand. We talked about enabling credentials to earn progressively, very much of what Dr. Valerio had already presented to Workforce Group 2. We feel like that is essential. So early exposure, that's key. Students need to know about healthcare professions. There are some great programs in the state where they're starting to expose kids as early as elementary, talking about healthcare. I mean, in rural and underserved settings where you don't get exposed to healthcare very much, they're not used to that as a potential career choice. And so really capitalizing and working early with children about these as potential solutions will be key in the state of Texas. Expanding P-TECH and providing TEA reimbursement for high school student certifications. So already there are CTE programs in the state, and there are some really cool things happening. We heard from Texas Workforce Solutions out in Abilene that's working with Region 14, and they were able to come up with a collaborative so that an RN is helping stand up CNA programs across entire Region 14, and they're graduating with those certifications. And so how could we expand that to other areas? Professional pathways in state data, we identified their state data gaps, just like Workforce Group 2. We need more information. How do we get these students interested in going into these career paths? Where are they going once they come in there? And developing extended clinical partnerships is going to be key in getting this done. I heard the concern from Workforce Group 2, so how do we do this? We've got to think outside the box, and we've got to do things that we haven't ever done before. So partnerships and funding, that's going to be key. Some of the entities that are already doing some of this work, it are non-traditional settings. So TEA is already focusing on CTEs. You've got Texas Workforce Commission, who's already focusing on pathways and getting folks into these types of programs. You've got outpatient settings that are working on building their own and setting up apprenticeships. And so trying to get those partnerships talking to each other and sharing in that funding and making sure that we're spreading those resources across the state are going to be key. Some big things that came out, very similar to Workforce Group 2, is a statewide repository for different resources, streamlining some of these workforce groups are going to be key. Training requirements and partnerships. So we want to reduce barriers to certification and testing. Some of the big trends that came here is teach them where they are. Community-based learning is key. So a lot of times in traditional-based learning, we're requiring students to travel. Sometimes travel is hard. Earn while they learn was also a theme that came out. So offering some sort of reimbursement, or they can be working and getting these certifications, and that's going to help get people interested in going into these entry-level positions, and then hopefully going on to further pathways. And then, how can we identify these folks early and getting them in there and doing some of these things at the school levels? And so just going back to those programs that are already in place. Funding, reimbursement, and support. So some of the trends that came out is, transportation is an issue, childcare is an issue. So how could we creatively look at these programs and break down some of those barriers with some support resources or funding towards those types of barriers? It was brought up to evaluate pay rates for Medicaid professionals, including Medicaid community attendant pay rate, which is $10.80 currently, and a possible reimbursement alignment there. And so we have these patient care techs, CNAs, CMAs that are doing some really great work keeping people healthy in the outpatient settings. How could we pay better for that or reimburse higher so that we could pay better for those positions so that we could grow that workforce? I'm going to turn it over to Christopher going into policy topic 2.
Thanks, Mickey. So under policy topic 2, we looked about what additional strategic planning or tools or support would be needed from a state or local level to ensure long-term effective healthcare and workforce planning. And again, these will echo a lot of the items that were talked about in policy 1 as well as in work group 2. You will see some consistent trends. Barriers that were identified as childcare access impacts both students and employees. Simplifying requirements for individuals to reskill or have career changes. If an individual has already earned a degree, they struggle oftentimes by returning to the community college because of financial aid and resources because they've already earned a degree, albeit they may be wanting to enter into healthcare. We have some burdensome regulations added by the state to certifications that are programmatically or nationally accredited or approved. So different bureaucracies or requirements that a program that is already demonstrated their standards and their peer approval from the accreditation process. We have limitations placed on the use of simulation in education, preparation, and training. There are some professions, as Work Group 2 stated, that we're maybe not using it to the true 50% from the study, the landmark NCSBN study that only looked at 50%. It didn't look at a higher percentage, but as our case study of COVID, we know that we have graduates that are practicing in all areas of healthcare, and some of those had 100% of simulation. So we want to make sure that we continue to evaluate sound educational norms. We want to look at international migration and portability of credentials to address shortages. So as we have individuals move across the United States, not all credentials move from state to state, as well as we continue to have international migration and individuals moving to the United States. How do we allow them or evaluate their education that they earned in their home country? Limitations on licensing or certification for those with select criminal charges. So looking at a criminal history and evaluating those, so it's maybe a little more tolerance in certain areas. We have areas in the home care services. There's certain pay and care deserts, especially as mentioned in the previous slide, where we're paying $10.80 an hour for some of our Medicaid workers. It's hard to recruit and or retain. The THECB requirement for a 60 credit hour associate degree has been a challenge, has maybe moved some courses from some programs. Also, as we look at expanding curriculums in certain disciplines, that's something potentially to look at. And then the compensation and funding gaps in academia, where we struggle to recruit and retain faculty in the education roles. Data, we need a consistent and accurate, accessible statewide data on workforce supply, demand, education and training programs, employment outcomes, placement and retention, really the whole life cycle of individuals. The data is in different pockets throughout state agencies, but it's difficult to assess. And you have to know which agency to go and obtain that through. Ensure that the sharing of data from agencies to inform decisions. Make sure that we're using common terminology and methods when looking at data and or when we're looking at employment and outcomes. We want to make sure, and when we look at pathways, we really want to develop clear career pathways and stackable credentials for health occupations. We really want to continue to emphasize to individuals that there's more than just nurses and physicians, but we have all of the wonderful allied health and health science fields where we need support in healthcare. As some of the professions are looking at going to an entry to practice at the baccalaureate level, looking at allowing community colleges to potentially offer additional baccalaureate degrees, specifically when we look at occupational therapy assistants, physical therapist assistants, and respiratory care. There's discussion within their professional organizations about looking at an entry-level baccalaureate degree for practice. Allowed for increased simulation in health sciences education. That comes up numerous times, and I won't continue to reiterate on that. Also consider increasing TA points for school districts that offer on-ramp courses into health sciences so that we're incentivizing our K through 12 partners. In regards to collaboration, ensuring that we're capitalizing on advisory committees and the collaboration that occurs when we have the right stakeholders at the table. Re-engage with Texas team and the Future of Nursing report from the AARP. We want to look at and target support and incentives for hard-to-staff specialties, specifically in geographic areas, and then assist with that placement. Leverage collaboration between our state agencies, educational institution, employers through our advisory boards and funding partnerships. There's a lot of great work that is occurring across the state. Sometimes we just don't share it or we're not aware of it. So we can, by groups like this, we can come together and allow that collaboration. Incentivize or compensate clinical training programs or preceptors to support capacity. Oftentimes having a preceptee or a student, there's no additional compensation. It's additional work for employees. Provide funding to hospitals or clinicals to support tuition reimbursement, to continue to support and earn while we learn. Conduct consistent efforts to promote those various healthcare careers. One of the terms that was shared was a lattice, and that it's not just a ladder, but that there's movement among different professions, and having consistent messaging and marking about career pathways using multiple mediums, so that we get individuals to realize that healthcare is an area that they can enter, that there's career mobility and career growth, and that they can stay in the location of the state where they were born and raised and reside, and continue to have a fruitful career. We want to increase lead time and communication around grant funding. Oftentimes we know that there's funding out there, but the turnaround time to set up a viable project or program is short to get a quality product. And oftentimes both educators, employers, and providers may miss out on that funding. And then more recognition of provider expectations to employer-based programs. This was specifically around the pharmacy tech programs. A lot of our larger pharmacies across the state provide in-house education, ensuring that we're allowing those individuals to obtain certification or recognition as a pharmacy technician. Our third group, we looked at key challenges and issues that affect the working conditions of the workforce, and looked at ways to retain nurses and other allied health professionals and reduce regulatory and administrative burdens. When we look at the work setting, realizing that working in healthcare, there's significant emotional and physical impacts and demands of the profession, ensuring that we are being transparent of that when we recruit students, and also as we educate individuals to prepare them with appropriate skill set and resources to deal with that. Needs for physical and psychological safety, as well as feeling valued. That's an area there as well that we can look at some of the statewide data, specifically around retention of employment, and do we see trends in certain areas or with certain employers where we have challenges for our retention, and how can we assist them? So yes, it's increasing the individuals in the workforce or that are entering, but how are we retaining them? Importance of work-life balance and flexibility in scheduling, healthcare of workers, appropriate staffing to avoid burnout and shortages, working with compliance and accountability. And then there were concerns, and it was addressed, about mandated staffing ratios in different disciplines and practices. Data, once again, we have a lack of that comprehensive data, maybe some missing demographics or terminology that's used. So we want to ensure that we have a great data set. Technology, utilizing new technologies, but only if it's adequately integrated. Artificial intelligence simulation. There's misalignment between reimbursement and technology adoption. As the previous group said, sometimes in academia we're slow to adapt or change, maybe because of our accrediting requirements, our educational requirements. Under regulations, we wanted to look at requirements for specific roles and make sure that they're truly beneficial for the role in which an individual is working, reevaluating some of those select criminal charges, concerns about excessive paperwork and productivity demands, and then looking at our wraparound services, on-site support services, childcare, mental health resources, transportation, tuition reimbursement, just how can we continue to support individuals that are entering into the healthcare profession. Under education, we want to make sure that we have individuals that are prepared. Lack of soft skills or essential skills, and ensuring that in the curriculum. I think that's where we can continue to not only evaluate critical thinking in simulation, but we also can look at those soft skills and through the use of evidence-based immersive simulation to better prepare those learners to enter the workforce. We have concerns around overloading preceptors. We do have established nurse residency programs that help with retention and help with the success of nurses, and we can continue to duplicate those in nursing, but also in other healthcare areas. Looking at simulation, create clear career development opportunities or trajectories, and then under communicating the value, strategies to better recognize and affirm the contributions of healthcare workers, changing perceptions around the value of the work in long-term care in our home care settings, realizing that our elderly individuals need quality care as well.
So, like I said, we heard from a number of stakeholders that we're doing some amazing things. Kind of one of the overarching things from stakeholders is everybody needs more funding, is kind of getting these programs up and going. So increasing funding for education and training programs, streamlining licensing and certification process, and creating state-sponsored interprofessional collaboration. So kind of just hearing some of the same things throughout the day from Workforce Group 2 and 1, and that was from the Texas Association of Care Association. So Texas Association of Community Health Centers, we're very thankful for the funding for the FQHC incubator program, and that is allowing some innovation with federally qualified health centers across the state, and would like to see that funding keep going there where they can continue their work in workforce development. The duplication of their workforce MA apprenticeship program, which I think you guys are going to hear a little bit more about that in a little bit, and that kind of goes back to the beginning of the policy question 1, being able to train people where they are so that they stay in rural and underserved areas will be key to helping Texas elevate its workforce. Texas Association for Home Care and Hospice, once again, providing funding around incentives, scholarships, loan forgiveness to help them with their workforce. Texas Association for Home Care and Hospice continued. The other big thing that we heard is just thinking outside of the box, streamlining regulatory and administrative processes to reduce burdens on nurses, to allow them to focus more on patient care, increase funding dedicated to home nursing and specialized private duty nursing education programs. So that's coming back to that Medicaid funding, and how could we leverage those that are keeping them healthy outside to have a better pay wage and maybe reimbursing for some of those services. The State Health Coordination Council encouraging use of healthcare teams that include different types of healthcare providers. So we talked about all the different allied health and entry level that could be adding to that team. Support increased reimbursement rates for behavioral health providers. Continue to support the investment in recruiting and retention of mental health and behavioral health workforce. Ensure that high school students are educated about the healthcare systems and the career opportunities. And just going back and tying that back into TEA, Texas Higher Education Board, and Texas Workforce Commission working together with some of their programs. College for Health Professionals, they just couldn't stress enough the importance of short-term and stackable. Just really the idea of, okay, you've got a long-term pathway, getting into a program where, okay, first I become a CNA and I get to start working, and then I'm going to become that LVN or associate RN, and I get to keep working. Or if I need to take a break to take care of my family, I still have that pathway I can come straight back to, get that BSN, get that advanced APRN degree, and just have that clear trajectory. And then I think it was on the earlier slide, and I apologize for not bringing that up, but very similar to Workforce Group 1 is having a very clear defined entry-level certification. So going back to those patient care technicians, if we could streamline that way it makes it easier for these colleges to make those stackable pathways, that would be something for the workforce task force to consider. Support flexible but structured environments. We talked about those that have childcare needs, transportation needs, the need for education where they're at, trying not to make them travel, let them do hours that aren't traditional learning hours, 8 to 5. So if they can do nights, weekends, evenings, those types of support flexible but structured working environments. And then the outside of the classroom opportunities. Workforce Solutions of West Central Texas. This was so impressive. Like, you guys, I hope y'all have a chance to go back and look at what they're doing. And it's a unique model because that workforce solution is actually tied to Region 14. So I think that probably feeds into why they are being so collaborative there. And what they've been able to stand up and do, utilizing the funds through Texas Workforce Commission and working with those local high schools. But I mean, they're doing it from a regional approach. And if we could translate that to other regions, I think that would be huge for the state of Texas. And so at the region center level, they've got an RN that is working as the preceptor. It's being funded by the Texas Workforce Solutions, and they've stood up CNA and CMA programs at their local high schools. They're utilizing outpatient learning, the local hospital, but also just thinking outside of the box. And I think that that's huge and something that would be a game changer if we were able to implement statewide. I think that is wrapping us up.
Thank you so much. Any questions from the panel? I want to thank you both because y'all are, I think this allied piece, this piece before they get the nursing degree is an important and missing piece in the process that this healthcare policy people haven't really spent a lot of time talking about. And so, I mean, Christopher, you're spending your time in all the programs at St. Philip's creating these folks, and you are hiring them over and over and over again. The number of individuals that you deal with on a daily basis in the healthcare system, just because they're wearing scrubs doesn't mean they're a nurse. The people with certifications who are testing various aspects of the examinations that you're getting at your healthcare provider's offices, running those diagnostic tests and providing that information, taking in your data and putting that into the system. We rely on these professionals significantly, and we don't have a handle on what they're doing and the impact they have in the system. So thank you for taking on this challenge. It's actually, I think, the hardest one because we don't know what we don't know in this area, and I think the state needs to know. So thank you very much for your input on this and for your help with Work Group 1.
Great, thank you.
Thank you.
All right, panel, we are going to move now to hearing from the state agencies that are all involved and engaged in this issue. And they are going to actually address some of the issues that were brought up in the work group. I asked them to tailor their presentations to some of those questions. So we're going to start with the Texas Workforce Commission. And we will hear from Carrie Ballast, Deputy Director of Workforce Education, Mariana Vega, who is in the data shop. She's a director, and Mary York, who is the Director of Workforce Development. Thank you all so much for being here today.
Thank you for having us. Very happy to be here. And so I'm going to start. Mariana Vega. I'm the Director for Labor Market Information at the Texas Workforce Commission. And hopefully we're providing some labor market information to hopefully answer some questions regarding healthcare occupations. I am providing a handout just because a lot of the data we're going to cover is aggregated. But those on the handout are the 46 occupations that we've identified as being healthcare occupations and are being used sort of as a focus group. That list was made up of the 49 occupations that were previously given to you all. The 11 that I discussed at the June 25th meeting, and then a few others that we identified that require less than a bachelor's degree for entry. So because there were some duplicated SOC codes, the Standard Occupation Classification Code, the total number does end up being 46 occupations. You have that handout, and we tried to include a lot of the pertinent data fields that we're going to cover. So I'll go ahead and just start with that first slide just to give an overview of the healthcare and social assistance, where these 46 occupations are mostly found. That's where the employment is. It is expected to add almost 300,000 in employment by 2032, so increasing the total industry employment to over 1.9 million. It is the two-digit industry that's projected to grow the most in Texas. Within this particular major industry, there are subsectors that are expected to add the most jobs. Those are it on the chart right there. Growth is being driven by offices of physicians, home health care services, as well as general medical and surgical hospitals. Currently, for the healthcare and social assistance industry, employment accounts for over 1.7 million in employment. It's the number one industry of employment. I think I mentioned that earlier, accounting for 13% of the total employment in Texas. So it's a very big industry. Just for comparison purposes, retail, trade, educational services, accommodation, and food services, which are large industries in Texas, each of those make up about 10% of the employment in Texas. So healthcare is very important for Texas. We wanted to provide an urban versus rural view of industry employment. So we are defining rural to be employment or counties that are not part of the metropolitan statistical areas. It is very similar to what we're seeing statewide. It's not very different. However, we thought it was important for you guys to see how employment is distributed among the counties. This industry does make up the biggest or largest share of employment in both urban and rural counties. For urban counties, the same three industries follow: retail, trade, accommodation, and food services, and educational services. For the rural counties, it's a little bit different. Manufacturing is a little bit more prevalent in those particular counties. So up until now, I've been talking about industry. We're going to move over to occupations. In this industry, you're going to have a whole range of occupations, everything from management to administrative. You can even find some construction trade type occupations in the healthcare industry. There's plumbers, electricians. It's a small portion. I will say that most of the occupation does come from two major occupational groups, and that's healthcare practitioners and technical occupations, as well as healthcare support occupations. Together, those two major occupational groups make up 79 healthcare occupations. There's only 46 on that handout. We left out those that provide like more direct care, like physicians, orthodontists, doctors, things like that, only because those typically require more of a education beyond a bachelor's degree. So we are trying to focus on those with shorter education requirements. Anyway, each of those major groups contribute over 500,000 in employment. Together, they contribute 1.3 million in employment, making up almost 10% of statewide employment across the industries. Again, we wanted to provide an urban versus rural view for occupations. Healthcare jobs in urban areas do make a larger share of employment. It mirrors what we're seeing statewide as well, because those major urban counties drive statewide employment. 1.2 million Texans were employed within those occupation groups, making up almost 10% of urban employment in Texas. In rural counties, that is slightly less. It's 9.1% of employment across all counties. So on this next slide, going forward, this is how we're going to focus on the 46 occupations that you have on your handout. So again, we're excluding healthcare practitioners, healthcare diagnosing and treating practitioners, because they typically require higher education. That said, here is the education breakout of those 46 occupations. 41 of those 46 occupations do require less than a bachelor's degree. For the most part, the training chart on the right, those mostly pertain to those occupations that require just a high school degree with on-the-job training. So here these charts are focusing on the concentration of healthcare employment by workforce development area compared to the national ratio. So we do this by calculating what is called a location quotient. which represents the occupational concentration compared to the national ratio. So I'll provide an example to hopefully make this more easy to understand. So if an occupation has a location quotient of 2.0, that means that occupation accounts for twice the employment share in that area compared to the national level. So if it's 0.5, it makes up half of the percentage compared to the national level. So what this does is just helps us understand the weaknesses and strengths of an occupation in a particular region, and what tends to just prosper in that particular economy at the regional level. So the handout does have the location quotients for each of those healthcare occupations on the handout. It's Texas versus the national ratio. It's a little bit different because here we wanted to provide a workforce development area view just to see how the different areas vary. So we're only focusing on, we're only focusing on 2 occupations. And that's because we would have to create one of these heat maps for each of those occupations, which we can do and provide if that's what's needed. So just let us know. So we're looking at home health care and personal care aides, as well as registered nurses, mainly because they had the greatest ratio of employment compared to the WDA employment for those areas. So the darker the color, the more concentrated the employment. Lower Rio Grande Valley workforce development area leads with a location of 6.1% on the left, and that's for home health care and personal care aides, followed by Cameron County in South Texas. Just for comparison purposes, the statewide location quotient is 0.9. So having a location quotient of 6.1% just means it's very concentrated. Healthcare is very important in all of Texas, but it's very prevalent in that particular area. For registered nurses, the range of location quotient is a lot smaller, so that's why the shades of blue are more similar or not as, distinct as far as the shades of blue. Central Texas led with a location quotient of 1.6, so it's that darker area. The lowest location quotients for RNs are Rural Capital and Permian Basin at 0.5. So in those areas, registered nurses only made up about 1.1% of employment. The lower the location quotient means obviously lower concentration of those particular occupations, which could mean that that need for that occupation is not being met. So that's one way to look at it. We did look at the strengths of the different occupations, and we're using wages to focus on just because that's so important for people, right, to make a living. Having that pay premium a lot of times makes a difference in retention as well. So on the next few slides, we are going to focus on wage differentials. It's the ratio of occupational wages to the average pay earned by all workers in a specific area. So as we all know, the cost of living fluctuates by area, so does the wages. So what wage differentials provides is it's some insight into the value of that particular occupation, as well as to some extent the cost of living, because the higher the wage, the better living conditions you probably have. So for these slides, we averaged the wage differential across the workforce development areas, and we're showing the top occupations along with the statewide average wage for the occupations. So out of the 46 healthcare occupations, only 20 had a wage differential of over 1. So right now we're showing the top ones. Those with the lower wage differentials typically require less education, and that's very common with almost any occupation. The more education, typically the higher wage you earn. So on this slide, you can see it was led by medical and health services managers, which had a wage differential of 2.05. So that just means that those in those particular occupations earn more than 2 times what the average worker for those workforce development areas. So again, the higher the wage differential, the higher the pay premium. We did break it down by education, just so you can see what that looks like. For those occupations that require associate's degree, those are 12 out of the 46. The top 3 occupations include radiation therapist, dental hygienist, and magnetic resonance imaging technologist, all with an average annual wage of over $84,000. 17 of the 28 WDAs do have dental hygienists as the top occupation. It earns more than 1.5 times what the average worker makes in the WDA areas. The medical and health services manager, and that's the next slide. We're looking at bachelor's degree occupations. We do have 4 occupations, by the way. And just because an occupation typically requires a bachelor's degree for entry does not mean that they're going to make the highest wage, because out of those 4 occupations, 2 don't meet or have a wage differential of less than 1, so they're below the average. Those 2 occupations are substance abuse counselors and clinical lab technicians. However, medical and health service managers do have the highest wage differential in all of the 28 areas, with a statewide average annual wage of over $120,000. So they earn about twice the amount earned by the average worker in the WDAs. Registered nurses comes in second.
Excuse me, can I ask you a really quick
Sure.
question? What are medical and health services managers examples?
I don't have a list of all of the occupations that are included. That I can get that for you, but it's management. And honestly, those aren't part of the 2 major healthcare professions. There are a few. It's just the way the standard occupation classification system is broken out. Those are management positions. So moving on, we only have 1 occupation that typically requires a master's degree for entry, and that's speech-language pathologist. The average earnings are of over $91,000 with a wage differential of about 1.5, so they earn 1.5 times more than the average worker in those areas. So across the 28 WDAs, Lower Rio Grande Valley does have the highest wage differential of 2.02. So again, in that particular area, they earn twice as much as the average worker. So just for comparison, let's say, and I don't have the number in front of me, but even though somebody in that same position in capital area earned more, it might not mean more of a pay premium just because it's a higher cost of living. So that pay differential would probably be lower than 2. And then here are the middle skilled top occupations by employment and earnings. As I mentioned earlier, 41 of the 46 occupations do require a typical education for entry less than a bachelor's degree. So here, these middle school level education occupations, only about 30% of the jobs earn more than the average worker in Texas. So that could contribute to retention, higher turnover rates, all of that. Radiation therapist does have the highest wage differential and earn over 1.7 times the average pay. And so we are listing the top 6 occupations that do pay more than the average worker. However, as I mentioned, most of the jobs in this particular category pay less than the average worker. And then here we're listing the occupations that typically require an associate's degree or post-secondary non-degree award. So we're listing those that pay above both the statewide average and the median average pay. So those are 12 occupations. However, we do have 17 out of those 28 that pay above the median wages. So if we're just looking at one or the other, the number can vary. And then here we're providing 2 charts to kind of discuss the unmet need or where that greatest gap exists. I think I mentioned at the last meeting, we don't really have a perfect process to identify unmet needs. The issue lies in the fact that we can easily determine demand, what current demand is, by looking at job posting analytics, or what we call the annual demand, which is looking at using our long-term projections to determine demand on an annual basis. The problem is we don't have a good supply number. We don't exactly know, who in our labor pool is available for those particular occupations. We don't collect enough information at the occupational level to determine that. So right now we do use our Work in Texas profiles to look at what current supply looks like. So it's limited though. Those are mainly, it's a pool of people who create profiles in the system that typically because they become unemployed or they're looking for a job or things like that. So it's a very limited number of supply pool. On the annual basis, we use the Higher Education Coordinating Board graduate data. But again, the data is a little bit skewed there because there's more data available for occupations that require actual degrees and not anything below like a certificate or non-degree award, things like that. So here, the areas in red represent a bigger demand or greater gap. The green represents a smaller gap, so meaning that the need is closer to be met. So for example, if we look at the Panhandle, on your left, it's going to be orange. Only 38% of the demand is being met for healthcare occupations. And the lowest is Central Texas, 30.2. The highest is Lower Rio Grande Valley at 86.1. Registered nurses does top the list on on 24 of the 28 workforce development areas as being the occupation with the most unmet demand. Speech language pathologists, health technologists and technicians, radiologic technologists and technicians, and cardiovascular technologists and technicians follow on that list. Looking over on the right, the annual gap. Again, Panhandle is red here, so only 19.7% of the demand is being met for those healthcare occupations on an annual basis. The lowest is Northeast Texas at 18.4, and the highest is Golden Crescent at 70%. There's not enough information available to create a gap analysis for the Concho Valley workforce development area. However, top occupations with unmet demand for those WD areas include medical assistants, medical secretaries and administrative assistants, nursing assistants, and medical assistants. Again, I wanted to mention that we do have these available for each of the workforce development areas as far as the detailed, so you can see which occupations have the greatest unmet demand. If you'd like to see those, we can send those over electronically. It's just they're large files, so. Okay, in these last two slides, we were asked to provide what job demand looks like as far as job postings. So those in red, there's two slides, by the way. There's a total of 4 healthcare-related job postings on here. Registered nurses is number 1, and it's been number 1 going back to 2012. It's been number 1 for 132 out of the 150 months. So there's been a lot of unmet demand there for registered nurses. I did want to mention, though, these are the other 3 here. Those 4 occupations, they have some of the highest exits and transfer rates. So again, that's what's contributing to the higher job postings and need for those occupations. So that concludes my slides. I did provide a handout again. It has the 46 occupations and a lot of the data fields that I went over to include projections, wage information, the wage differential data, as well as the location quotients, just to see, again, compare education needed to maybe earning potential, things like that. So thank you.
Thank you very much. Your data is very connected to jobs available and individuals available seeking the jobs. I just want to let the panel put some perspective around when we hear from DSHS next, their data is different. Their data is looking at the projected need in the healthcare system. And so that's where it's a task force responsibility to kind of try to figure out a way to put those two pieces together, because they are not the same, but they're both very important aspects of the same issue. So we will be able to do that, and when we hear from Pam, she's going to say that need is significantly greater and it's significantly different, but she's also looking at it from a different perspective. So just wanted to put that context out there. Thank you very much. It was a great presentation.
Hi there, good morning. And you did cue us up nicely. So thank you. Thank you. I was wondering how, I was like, check. This sounds really good. So I'm Carrie Ballast. I'm Deputy Director in the Workforce Division and oversee our workforce education programs. Our director, Mary York, is here with me. And Mary and I are going to talk to you a little bit about the programs that we have in place to assist in filling some of the gaps and building the pathways that you're talking about. As we get started, I wanted to let this panel know that any of the work that TWC does, that we are so heavily involved in partnerships with other agencies, with local governments, and with colleges, and we want to reiterate that anything that we do from the state level here is truly in partnership with those at the local level and across other agencies here at the state. So as decisions are made and as this task force makes its request, just picture that you're building a network of agencies and other entities who can come together and do this work for you. One of them that I really want to touch on right now is our Tri-Agency Workforce Initiative that I've already heard mentioned a couple of times, and want to let you know that this is a partnership across the Workforce Commission, Texas Education Agency, and our Higher Ed Coordinating Board. Our main charge, Governor Abbott brought us together, and the legislature seconded that, and we are to work together in collaboration to build a strong workforce now and for the future. When we did this, we selected priorities that touch on all the work that you're doing. Number one, we're committed to building pathways for all of our students and adults. We're committed to putting in supports, whether that's the advising that needs to happen or the wraparound supports that you have talked about here too. So we think about not just the career journey, but how we make sure it's a successful one. And then finally, the infrastructure. And that's how the three agencies come together. We share data, we share people, we share processes, we share resources to make these things possible. And so just know that that's already in place for you. Some examples of how we're already working together, an initiative established by Texas Education Agency called the Texas Regional Pathways Network is a great example of how our workforce boards, our colleges, our industries, and our K-12 schools come together to work at the regional level to build pathways for students. We already know of great examples in which healthcare pathways are being built, and all of these entities are working together. TEA puts out funding to support the development of these pathways, and this is a great example of how we work together. We also work together on developing the list of certifications that are essential to our high school students and our future workers. TEA, as you know, publishes a list for public school accountability. And for those of you that have touched in this area, you know it's essential. You want to see your certifications listed on that. That lets you know that high school students are getting prepared for these jobs. On the Workforce Commission side, we oversee the Industry-Based Certification Advisory Council that brings together K-12, college, and industry to make recommendations to TEA on those certifications. And so if certifications are identified here by this group, or I'm hearing the need for new certifications, this is a group who can work closely with you in putting those recommendations together. So with that said, I also want to re-emphasize that not only do we work with our state agencies, at the local level we work with economic development councils, with our industry partners, with nonprofit organizations, with public colleges. This probably could have been a very long list, but we wanted to hit the high spots for you. So with that said, and at the request of our chair, we wanted to back up a moment and let you know how we work together in the planning for workforce needs. This is both a state and local process. So if you imagine at the state level here, we always look at all the labor market needs across the state, but as Mariana has really underscored here, we look very closely at healthcare professions, and they are definitely part of our planning processes, both state and local. We come together to put together a strategic plan. We receive quite a bit of federal funding under the Workforce Innovation and Opportunity Act. Dollars are sent to Texas to support the training and employment of workers who have challenges and barriers to employment. And so this is one way that we put together a plan on how we use those dollars, the programs that we put in place to put people in training and education and onto employment. When we develop these plans, we are required to seek input. And so as our boards work on their parts of their plans, they are getting input from their local industries. I dare say some of you are probably part of that. You strike me as very engaged in the workforce development here, and so some of you probably say, yes, I know well what this is happening here. So what we do is we work, number one, with our boards in developing this and at the state level, and then we put this together in what we call the Combined State Plan. It goes both to the Departments of Labor and Education, because this does include adult education and literacy services. It also includes vocational rehabilitation services. So a lot of our divisions are represented in this plan. It serves as our roadmap for the work that we do. I mean, it goes through a very strenuous review process. The governor's office reviews. Once it gets to the federal level, it's reviewed by those agencies too. And once we have that, we are set for the next 4 years going forward. Likewise, our boards go through a similar process at the local level. So while we look big picture across the state, our boards are looking locally and within their workforce development areas. One thing that they do is they think strategically on this. They look at the labor market needs. So number one, we send labor market information to them. They work closely with business and industry to hear what the needs are. So they think, number one, what data and information do we have? Where should we head? And then number two, they operationalize it and make decisions about how they'll meet those needs. So with that in mind, we're going to get down to the heart of the matter here. Once they have those conversations, once they know the labor market needs, once they've seen the labor market data, once they've talked to their local industry, they develop for their area. They look at high demand occupations and industries within their areas, and they set what they call their target occupations list. And by workforce area, they identify the occupations that they will focus their greatest resources on. And this is a result of data and local feedback. And so for those of you who work closely with your boards, you have probably provided input that underscores the need for healthcare in your areas, and it's being reflected on those target occupations. Once they are at the state level, we are available for assistance. Number one, they're offering labor market data, but we also have, and this is in workforce development, we have state staff who work closely with boards on questions of eligibility, logistics, guidelines, federal and state statute and rules. And so we do work closely with boards when they have questions, or just simply we in partnership work with them to address some of these workforce initiatives that you are looking at here. And then they too send a plan here at the state level, and once that's done, we we continue working closely with our boards throughout the year. Number one, through funding that goes to them, but number two, through the technical assistance and the supports that we have here. I hope what you heard from that is we work very closely together. So anything that's here very easily trickles down to the local level. Again, just touching on this idea of the boards developing their target occupations list. This is really our North Star. This is where we work. If we make referrals, we refer customers into training for these target occupations. If someone comes in and wants to be a farrier, for example, we're happy to send them to something, but it's not on our target occupations list. We can't put training dollars behind it. We can help them get there, but our main focus is on those target occupations. So with that said, I don't think this will surprise you at all. I wanted you to see what's appearing on our target occupations list. It's kind of tough to read, but I think you know what that very first one is. Our items number 1 and 2. Number 1 is our licensed practical and licensed vocational nurses. That 28 means that appears on all 28 lists of our boards. Likewise, registered nurses appears on all 28 lists. So that's to say this is on in every workforce area in Texas. Now, from there, you do start to see it drop. For example, medical assistants appear on 22 of the list, meaning that 6 areas have not identified that as a target occupation for them, possibly because they feel like they've got the supply and the demand filled at this point. All the way, just for sake of seeing how far we could go down, got down to 7 boards with the medical. This was a new word for me. Yes, and medical record specialists, but wanted you to get a feel for how frequently some of these jobs are appearing and how much our boards are focused on sending customers into these trainings. So again, as we go into this, where we do recognize these gaps, we do have the ability to start addressing them. I mentioned this at the first one. One thing that our commission will do is when we become familiar with a gap or know of impending gaps, for instance, teacher shortage, and then going back to this idea of tri-agency initiative, our 3 commissioners representing the tri-agency, which would be our Chairman Daniel of Workforce, Commissioner Morath of TEA, and our interim commissioner, and she's over my left shoulder. I saw her just a moment ago. They've asked us, come together, work together as 3 agencies to address teacher shortages. Likewise, when a gap such as healthcare professions, the 3 commissioners come together and start asking us to think about how we work together in addressing these. But as far as what we can share and how we address gaps, we continue to send labor market information to our boards. It helps them know how things are currently, but also what they should prepare for the future. Boards also can become aware of, let's say, for example, they become aware of a new industry coming into their area. They can adjust their target occupations at any moment. So when someone, an industry representative says, we would like to locate here, we would like to work with you to ensure that we have a good, steady pipeline of workers, that can become a target occupation for that area. So thinking back to the previous one that I showed you, our boards are agile. When they begin to see these demands creep up, they can adjust target occupations and start routing the customers who walk through our doors into those trainings for preparation for those occupations. So moving from there, where can we send them? That's the next one. I keep saying we're sending customers, so I want to give you an idea of where we send them or how we work with them, either the customer themselves, which would be your worker, your employee, or actually engaging with the business themselves in doing this. And this is where Mary and I are going to let you know about the programs and services that we have available. So number one, at the state level, Texas Workforce Commission houses the Adult Education and Literacy Services for this state. The agency subgrants to every workforce area for there to be AEL providers that serve every county in Texas. We do this based on data that we get about adults in these counties who do not have high school diplomas, and so it's kind of a needs-based allocation that we send. And what we do is at no cost to these adults. Our office, our boards, our colleges, our nonprofits, they can make referrals to send individuals to AEL services if they need to. We help them get ready for jobs. We help them get high school diplomas. We help them get high school equivalencies. And in Texas, that's just the GED. That's the one that TEA is recognizing as our state high school equivalency. We help them with English language acquisition and many, many other services. So if you can imagine an adult who's just needing to fill in some gaps from previous education or work experience or relocating to the state or this country, AEL services can help that. It's not needs-based, so they can be, it is not a look at income or anything like that. It's just simply, I need additional help in recovering some lost education. One that you've already touched on that we can assist with is that our AEL providers are able to work with internationally trained professionals. And these would be individuals who are from other countries and were professionals or were certified to be in the healthcare fields in their countries. Very often when they get to Texas or to the U.S., one of the first things we need to do is do a transcript evaluation. So we take what they achieved in their country of origin or the university or college of that country, and we help them translate what was earned in that other country to college records here in Texas and identify what else is needed to help them complete a degree program, a certification program, a certificate program. We can also help them pass and this has come up too, the TOEFL exam, which I hear sometimes is a barrier. Our AEL providers can sit and help with the preparation for that exam and help them pass that if needed. They can also help them get ready for their licensure or certification exams. And so picture the AEL provider as kind of the guide in getting whatever education happened in the other country transferred to Texas and getting the right certifications or credentials in place for them. I'm also going to say that along the way, we have also sprinkled in some funding to put behind the work that you're doing. So we're going to call out some items that our commission just recently put in place in May of 24 in commission action. Our commission has put aside $500,000 for this program. So we will be putting money out there to help get more internationally trained professionals certified or licensed to work in Texas using these dollars. Another service that we can provide, and this is usually working pretty closely with an employer, in the AEL world, I think it's important for you to remember that our providers are focused on the literacy and numeracy training. So we're thinking about the classroom. we're thinking about helping cover any kind of academic gaps that they give. But what we also do is we will work with the employer or a college to do the workforce training part of it. And so if you'll picture bringing students into a training setting where they are learning a skill, but we have the academic support built in, and so we're doing contextualized training. We're teaching them the vocabulary that's important for that occupation. We're teaching them the writing skills necessary for that job or occupation. We're doing the remediation work that they would need for that. Similarly, under that category of integrated education and training, we do have examples of where our AEL providers can come onto the employer's work site and, working with that employer, do the AEL and workforce training in the same setting. And again, this is a no-cost service, and I'm hoping that this one resonates with a lot of our systems right now. So with that, I'm going to hand off to Mary to talk about some of the other programs that we have available.
Good morning. I was checking my watch to see if we passed noon. So I think Carrie has given a great overview of the way our partnerships kind of feed into what we're doing, and she touched on the fact that our commissioners had recently taken some action to authorize additional funding, and there are a couple of places here where I'll touch on that as well. But I do want to emphasize the fact that our three commissioners, one representing the public, one representing employers, and one representing labor, they're all very much in the community and talking to their constituencies about what's needed. And healthcare is one of those topics that continuously comes up. In addition to the various formal planning processes we have and the agency's strategic plan, our commissioners do direct dollars as necessary to make sure that we are addressing critical needs within the workforce. One of the first ones I'll touch on, this dual credit program that's first listed here, that's actually been in place for some period of time. School districts, community colleges, technical colleges can apply in partnership to offer dual credit courses that are as part of CTE programs. The program funds equipment for those courses, and it can either be new equipment or it can even be, if they have an existing program, to replace or refurbish existing equipment. And that is all driven by that local demand, local employers, and in fact the statute requires that it have the support of local employers. The second item, specifically dual credit for healthcare occupations, is one of those that I spoke of our commissioners recently approving. If you think about, I just said for dual credit, we have an equipment piece. Well, we wanted to add sort of a companion program that could go towards tuition and curriculum development, specifically to drive new or expanding programs. So we want to see more of those CTE programs in our high schools and our community colleges. So that was recently approved in May and will be launching soon. Going to the next slide, the High Demand Job Training and Texas Industry Partnership, did I not go to the next slide? Programs are, programs driven at the local level. We are able to utilize Workforce Innovation and Opportunity Act funding and provide that to local workforce development boards for them to formalize partnerships. In the case of High Demand Job Training, they're doing that in conjunction with an economic development corporation who has frequently type A or type B sales tax dollars that they're able to use as a match for our federal funding for those projects. In the case of Texas Industry Partnership, that can be an industry association, a nonprofit or foundation of some sort that has an interest in seeing the advancement of training resources for a particular sector. And again, it provides a one-to-one match. These two programs are incredibly flexible, even though they're federally funded. They have a lot of flexibility for the local workforce development boards to come up with creative projects. And sometimes in rural areas, what we'll see is several school districts coming together in partnership with a local economic development corporation to offer training, in a variety of industries, but healthcare is one that we repeatedly see within the program. So that is available. Both of those programs are available on an annual basis and are, again, driven by that local need. The next item is our internships, and we have seen more and more, internships aren't what they used to be. And we've seen more and more interest in internships, especially from our employer partners. We operate the Texas Internship Challenge, again, in collaboration with our tri-agency partners. We provide a site through our Work in Texas platform where employers can post internships. Obviously, students can find those internships. And I'm sure the coordinating board is going to talk about the wonderful program they have, Texas Works, where they're able to actually help offset the cost of some of those internships. In addition to that, again, as part of that May 2024 meeting, the commission approved $1 million for boards to support paid internships, specifically for healthcare employers. So again, that is one of those resources that has been targeted recently towards healthcare. And then the next item, the next resource is our JET grant. So as I was speaking previously about dual credit, we also have JET, which stands for Jobs and Education for Texans. This program came to TWC in 2016, and right before I came up, I looked. Since 2016, for healthcare occupations specifically, we have awarded about $28 million to community colleges, technical colleges, or independent school districts for the purchase of equipment that leads to a licensed certificate or post-secondary degree in a high-demand occupation. In this case, with that $28 million specifically related to healthcare or healthcare support occupations. One of the things that this program, I think, is great at doing, and we've heard this through other testimony, while we know that top of that list of the job postings we have are registered nurses, not everybody starts out as a registered nurse. You've got to many times work your way there, and through starting at, frequently that high school level or community college level, that's how it begins, right? If we can help them get those introductory certificates or credentials, it puts them on a pathway. Similarly, through some of the equipment that is funded through this program, and maybe this isn't what y'all want to hear, but it helps people identify that healthcare is not for me. I mean, that's a real thing too. We want students to find the occupations and those things that are not only of interest to them, but that are in demand and that they can be successful at and, be a valuable contributor to the Texas economy. So that's really what this program is all about. And I do not have a slide on it, but I do want to mention, I don't think we have a slide on it. This program also works hand in hand with our education outreach specialists. We have both a state team, and then we work with the local workforce development boards. And I think West Central is a great example of a board area that has one of these teams. They go into schools and talk to students about occupations, in-demand occupations. I mean, just from the list, and I think that there was at least one occupation that was new to us. How are students going to know? They might know nurse, but they may not know all of the other healthcare occupations that exist and what it takes to get there. And maybe not everybody is built for a 4-year degree, and we think that that's just fine because we need a lot of people in a lot of different occupations in the state of Texas in order for us to be successful. So that team is all about providing that career information, most of it driven by the labor market information that we have, but helping them to identify potential career pathways and then help them identify these CTE programs where they might be able to start on their career journey. So I wanted to make sure I mentioned that as well. The next slide touches on a brand new program for us that was adopted during the last legislative session, the Lone Star Workforce of the Future Fund. It helps individuals who are either underemployed or unemployed receive the training that they need to enter the workforce and earn a self-sufficient wage. Again, it's all driven by in-demand occupations. So those occupations, many of them are healthcare related. And this program just launched this year, and we are in the process of accepting applications. Currently, the target cost per trainee for this particular program is about $7,500, and the individuals at the end of their training need to be placed into the occupation, obviously, that they were trained for at a self-sufficient wage based on their county that they live in the state of Texas. The next slide touches on our Skills Development Fund. This program has been around since 1996, and the reason it has been around so long is because it is really here to serve Texas employers. It provides customized training in partnership with community colleges, technical colleges, local workforce development boards, TEKS, to ensure that an employer who is either new or expanding in Texas or just needs to upskill their current employees has some funding available. Currently, the target cost is around $2,000 per employee to help them get an additional certification or credential. This isn't intended for someone who is going to, need to pursue an associate degree or a bachelor's degree, but if they need an additional certificate or, some other type of training that would benefit them in the workforce, this is one that is available to them. And in May, typically this program is for private employers, so, a private hospital or, a group of clinics or anything like that. But so typically it's for private employers, but the commission did approve some additional funding specifically for public employers. And we do see, especially as it relates to rural hospitals, that those might be public. Upskill Healthcare is another program that we offer for employers, and this one, the employer is the grantee. The commission has dedicated some additional funding to this program based on, it was a pilot in 2023 for all occupations. We had $5 million available. I think that we received within the 60-day window, I think we received about $25 million in applications, some of those from healthcare providers. So in May, the commission made an additional $2 million specifically for healthcare available, and these grants go directly to employers to provide training for incumbent workers, for current workers, and that training can come from a variety of different training partners, or it can even be provided internally by the hospital or healthcare provider directly. And with that, I think I am turning it back over to Carrie.
And I also wanted to touch on TWC is also the agency that houses vocational rehabilitation services. So I also do want to remind the task force that through through our workforce solutions offices and our boards, we're also able to connect to employers with individuals with disabilities. The counselors who are in place to help can do matching, can help an employer know what kind of accommodations to put in place, can help with placement and with the accommodations and with the training to place individuals there, but wanted to also remind you that service is available too through our boards. And then finally, because apprenticeship came up, and the chair, I'm seeing it all now, we're going to help differentiate between the conversation going on about apprenticeships. I know that you've heard that there are federal models. We've also introduced the idea that there's a state model. And I also just want to introduce the idea that and we all sat in history class for this, we know the apprenticeship training model goes back way, way back. So imagine just this idea of taking the employees that you currently have, and while they're working for you and while they're earning wages, you are putting other training in place, you're putting mentorships in place, and you're moving them up within your organization as an apprentice. And so I dare say everyone's using the apprenticeship model in some way or another, but there are avenues for you to pursue if you would like to look for funding to assist with those. And so what we're going to do here is differentiate between the two that we can support and help you with. And I think that'll cue you up very nicely for the conversations that you'll have later today. So number one, from the state agency perspective, one thing that we are able to do is we do receive apprenticeship expansion grants from the Department of Labor. Now, these typically are application-based, and we have a pretty good we have an excellent track record of getting these grants. So far, every time we've applied, we do receive funding from DOL that we turn around and subgrant to our workforce areas to help with the creation or expansion of registered apprenticeship programs. And so these are registered with Department of Labor. And what our job is and what our subgrantees' job is to help new programs get started or to look at existing programs and perhaps add some new occupations to them, expand them. And so we do have the ability to do that. Through our grants, we can typically pay on average about $2,000 per apprentice, and what we do is help offset the instructional cost. So anything that the employer would incur on the instruction side, such as instructor costs, equipment, materials, curriculum, classroom space, can be used for that. On the state side, we have what we call the Texas Industry Recognized Apprenticeship Grant Program, and in another slide I'll let you know how to differentiate those two. We also have, by virtue of state law and our Texas Education Code and through general revenue, we're able to support registered apprenticeships each year by helping employers offset their instructional costs. So while number one, we can send out funding to build programs and grow programs, each year we can also help offset the instructional costs of those programs. And then finally, through legislation that was passed, we also work with the Comptroller's Office, and for those who have adopted an apprenticeship model and a registered apprenticeship model, those employers can apply for tax refunds for those apprentices. And that has gathered a lot of attention and interest, and is so far is working very well for what it's intended to do, which is to encourage apprenticeship models. So which program is right for you? They both have very distinct qualities about them, and I think everybody could find a way that either one or the other or both fit your needs very well. Now, for for entities that pursue the federal route, this is looking at long-term apprenticeships. They're at least a year long, and as you probably know, in your healthcare, most of your occupations take more than 1 year of education. Usually, the shorter ones are, for instance, IT. A lot of apprentices can get certified and fully trained within that first year. On the other hand, when we're looking at, for instance, a registered nurse apprenticeship or an LVN apprenticeship, you're going to see those be multi-year programs. So number one, keep in mind registered apprenticeship, longer term apprenticeships. DOL dollars can be put behind them to help with the instructional cost. Because you're going through a federal registration process, you're doing a lot of work up front. You're developing that curriculum. You're identifying the competencies that they're going to learn and show mastery of. You're putting your plan up front. You're saying it's going to be this many years, and this is what they're going to learn along the way. These are the credentials they're going to earn along the way. These are the wages that they're going to earn along the way. And so it's a very structured upfront planning piece. On the other hand, what our Texas legislature saw a couple of sessions back is that sometimes the apprenticeship model can be used to address more pressing, urgent needs. And in shorter terms. So Texas also developed an apprenticeship model in which we can support shorter term training. Tyra, for example, that I referenced just a moment ago, that's for 26 weeks or less training. So imagine brand new, low skill employees coming in, and you recognize that within 8 weeks you can move them from this to this. Tyra dollars can help you do that. Now, it's still an apprenticeship model. You still have hired them. They're still an employee of yours, but you have put instruction and mentorship in place, and you're moving them from one skill level to the next to continue employment in your organization. This is where Tyra can help you. In this one, we can pay up to $10,000 per apprentice in reimbursement of those instructional costs. So while the DOL, if you think about that as a longer term planning, if you were to find some shorter terms, you need to see some pretty quick turnaround in some of the occupations that you need to fill, this might be where you are. This one offers a little bit more flexibility. It gives you a chance to be a little bit more innovative because you are not you are addressing an immediate need, and you have found a solution within your own business or industry to do this. And so you're thinking outside the box, and you're addressing something among your own industry. So that tends to breed a little bit more innovation than the longer DOL approach. It also tends to have less administrative costs behind it, and again, it must be faster, 26 weeks or less. So with that in mind, wanted to give you a little bit more information on the federal apprenticeship side of it. There are two ways that states approach this. You're either an Office of Apprenticeship state, or you are a state apprenticeship agency. Texas is an Office of Apprenticeship state. So imagine that we do the administrative function for DOL, but we're merely just passing it along to DOL. So we have staff who can help with registration, with expansion, with connecting programs with other programs to learn from each other, from finding sponsors for apprenticeships. We can also help in learning how to work through the DOL reporting system, because those who do take the DOL route will do their reporting through what they refer to as RAPIDS. They track the apprentices and the number of programs that are out there. And so as an Office of Apprenticeship state, we can be the middleman between you and DOL in helping with registrations and expansions. wanted to let you know currently what the registered apprenticeship landscape looks like here in Texas for healthcare. So number one, and I think you've touched on this, to undertake the job of overseeing and managing a registered apprenticeship job it's a pretty big undertaking. And so you've got to find sponsors who will do that administrative work for you. In the work that we've been doing in the healthcare right now, for instance, John Henderson with Torch, they have become a registered apprenticeship sponsor for rural hospitals, and they are serving as the sponsor for these rural hospitals and registered nurse apprenticeships. They did this because these small hospitals were concerned about the resources they were going to need to manage these programs, and Torch said, we'll do it for you. And so they're all working together. So wanted you to see the kinds of sponsors that we have out there. Number one, we have business associations that are serving as sponsors. We have community-based organizations who are serving as sponsors. We have community colleges who will serve as a sponsor. So if you were to identify registered apprenticeships in your area, I suggest that your community college already has a way of helping you with this and is serving as your sponsor if you would like that to happen. By far, the greatest number of sponsors are the employers themselves. We have helped quite a few hospital systems get registered lately, and so they're serving as the sponsors. I also want to break it down just by the numbers of programs that we have, and I'm so glad that this PowerPoint will be shared later. But as you look at this, number one, the number we have so far in the healthcare industry, we have a little over 5,300 apprentices in healthcare. And this slide breaks them down by occupation. Now, if you see a 0 there, that means that we do have an active program. A program has been registered, but they currently do not have active apprentices in that. Now, that's kind of we're going to do the glass is half full on this one. The registration work has been done. DOL recognizes this as an apprenticeable occupation. Standards have been developed. A program has been registered, but for whatever reason, so far, that program has not enrolled apprentices, or they cease to enroll apprentices. So if you see a 0, take that to mean work's been done, standards have been developed, and there is potential there to start growing in those occupations. On other ones, however, for instance, a registered nurse resident, right now we show a little over 3,700 apprentices in Texas here with that. And I think that that's just a reflection currently of what we're starting to see some of our larger hospitals move over to the apprenticeship model. For the TWC side of it, a couple of years ago, and I recall I touched on this in an earlier meeting, and it's funny how the more we talk, we're all becoming experts. We're becoming quite the workforce development experts here. So I think some of this is going to mean more for you now. But several years ago, our commission worked with colleges, communities, and healthcare systems to develop standards for a registered nurse apprenticeship. So currently at DOL, there is a Texas-based registered nurse apprenticeship program that has been approved, and it was a result of some work that was done here in partnership with Board of Nursing too. So we worked very closely with them to make sure that everything was good and in line with what Texas needs to see in a registered apprenticeship program. But what our commission did is we have put aside dollars to support healthcare apprenticeships, registered healthcare apprenticeships. And what we do is we work with the employer to submit an application. They show us the pathway that they're building, whether it's moving someone from a phlebotomist to an LVN, or an LVN to an RN. We just work with them to see where they're going to start and where they're going to end. We can put up to $4,000 for instructional costs behind that apprentice for the instruction that he or she will receive. But we can also grant $2,000 to offset the clinical costs for that apprentice too. And that $2,000 would go to the apprentice themselves to help just sustain them while they're doing those clinicals. So that application is currently open, and that's how we're starting to see these registered programs spring up in Texas. On the other side, too, we have the TIRE grant program. That application is open, and again, if any of the hospitals or systems identified they wanted to do some quick training to move kind of that grow your own model where you're taking some of your current from a low level to mid-level skills. That's through an application system. We work with the employer to get the application, and we can grant up to $10,000 per apprentice to reimburse the instructional costs on that. Our legislature is all about a Texas model. This was really generous funding on their part, and so we're able to help in this quite a bit. In May of '24, our commission specifically called out that $1 million of these grant dollars will go to healthcare occupations, and so we're ready to assist in that too. And then one more slide, but this idea of how we can engage our high school students and how we can get people thinking about healthcare occupations early. We also have quite a bit of funding that we can put behind pre-apprenticeships. So, for example, a high school student or a worker who's thinking about a new career, sometimes what they'll do is they'll go into pre-apprenticeship programs. Is this for me? Is this where I want to go? We can also put funding behind pre-apprenticeship programs. We can put this in high school classrooms to help. Number one, the employer gets to start looking in high school classrooms and finding that future workforce there. And we can also start helping with the training, getting them ready to enter into a registered apprenticeship program with that employer. So that's a strong one. It's a great place to get people started and for an employer to see the potential there. And so we can put dollars behind that. So with that said, that's a lot. And we know that as we promise, number one, our executive director made a rule. We have the one door rule. So I want to reiterate, if anything sparks an idea with you, one of our jobs is that no matter who you contact, we get you to the right person. So if Sydney or Victoria, if you need to follow up with us about anything, we're happy to assist and start making connections for you.
I appreciate it very, very much. I'm very excited about this apprenticeship. I know this was a long presentation. I do apologize for that. It is my fault, not theirs. I did ask them for a whole bunch of this information because understanding that connection between the workforce planning piece and then the healthcare system piece that the rest of us have a little more expertise on, I think we had to bring it to bear so that we all understood the context in which we were going to be making these decisions. And I think we both heard in both of the first work groups that earn while you learn is an important aspect of it, and apprenticeships are fundamentally that model. So thank you for taking the time to explain that. All the other components of the data and the assistance programs and the technical assistance, we will be circling back around. And thank you for your time today. Any questions from the panel?
I have a quick question. Just you've described a lot of programs, and I was curious whether you see the healthcare sector participating kind of proportionately in these programs to their representation on the targeted occupation list, or whether there's discrepancies, certain industries using them more than others, or whether it might be hard to generalize.
You go for that.
I think that's hard to say because not only does every local workforce development board, sort of set their own, list, although we did see that there was a lot of overlap amongst those 28 boards, but there are different training partners and providers in those areas with different capacities. There are obviously different employers and different educational institutions that are feeding into either direct to employment or into another educational institution. So it becomes a little tricky. I will tell you, with programs like the Skills Development Fund, we might see a little bit more interest from manufacturing historically, but that doesn't necessarily mean that it's because healthcare is a bad fit for the program. It kind of comes down to like who the eligible applicants are, and I'll go back to maybe rural hospitals, and Carrie's point a moment ago of, do they even have the capacity to take the time to build a training program, to apply? We do have a team of employer engagement specialists around the state that's actually there to help them build a project, to help them put unfortunately, we are the government. There is a little bit of paperwork involved, but to help put those pieces together in case they don't have the capacity to do it. But, candidly, there's still work to be done, ensuring that people know of the programs that even exist. That is something, that we're working hard, and industry has been great about this too, and coming to us and saying, okay, what have you got? We're working very closely with EMT groups or ambulatory surgical centers, or that they've actually come to us and wanted to share information with the people or the businesses that they're serving. So I think it takes the deepening of partnerships sometimes to continue to sort of penetrate the market, and so everybody truly understands. And again, by thinking about things in a pathway, hopefully, as we're working with CTE instructors, for instance, they're also imparting information into, with those young people about, here are the different ways you can go with this. Or as we're providing information on labor market data, we're also sharing that with the school counselors. And so those counselors are able to talk about, this is how you can move forward. And there are some resources available to you. And, that could be, directly from a college, that could be from a local workforce development board. So it's a hard question to answer because it probably depends on the program at any given point in time. But I don't think that, obviously, everything we presented today, we believe is a viable option for healthcare, and we've seen participation for healthcare.
Quick question. Do most of your programs have limitations on that the folks participating have to finish within 3 months, 6 months? And the reason I ask that is because we've heard a lot about flexibility in both education and pipeline programs, right? And that you have a traditional student and traditional paths, and then you have folks that have to work and have to take care of their family. And so I'm wondering how varied, those requirements are, and then how, that payment structure works, so that you only get paid for your expenses if you finish within 6 months. But if you've gone through it and you don't finish until 8 months or 12 months, then you don't get any of the money for the costs you've incurred. Does that make sense?
Okay. So obviously all of our grants that we administer have an initial grant term, and there is a plan for how training is going to take place. We communicate very regularly with our grantees in terms of, how are things coming along? They report to us, in some cases even monthly, on how they're performing, in some places quarterly. But if for some reason they're not making progress towards a goal, then we do have the ability to, amend grant agreements and extend that timeline. For programs that require placement, there's typically a little bit more flexibility because that placement needs to take place within the grant term, so we can, measure performance. Most of our grants, the grantee is able to draw down funds during the grant term, so they don't have to wait till the end. that's in most cases. There are some limited exceptions based upon just the nature of the funding that is being used. But so the grantee isn't out of pocket those expenses. They can keep moving and making progress. I think, like if we were to look at Tyra, for instance, there's a specific, there's the maximum of 26 weeks. So the the apprenticeship's going to have to be completed within a 26-week period. So there are some things that we may not have, the flexibility to change just based on, what is prescribed in statute or rule.
Thank you all very much for being here today.
Thank you.
We next will hear from Department of State Health Services, and Pam is back, the program director, and we have very much appreciation for everything you have been doing for us.
Okay, good morning. I'm Pam Lauer, and I'm from the Department of State Health Services, and I oversee the Healthcare Workforce Branch, which includes the Texas Center for Nursing Workforce Studies and the Health Professions Resource Center, and we also coordinate the Statewide Health Coordinating Council. So today I'm going to talk to you about those three programs, what their roles and responsibilities are, and I'll touch on the data that's collected by HPRC and then the data that's collected by TCNWS. I have two handouts. One of them has the list of the TWC occupations that we received at one of the earlier meetings, and I've put in the HPRC professions that we collect that are on that list. What's missing is the backside of that page, which has all of the HPRC professions, but I'll make sure that you get that electronically. And then the second one has questions that have come up through the work groups that might pertain to data that would be nice to be collected and things like that. And I'm pleased to say that there's a lot of data that you guys asked about that we do actually collect and have available. So I'll go over those items as well. Okay, first I'm just going to touch on the organization of these three programs. So like I said, HPRC and TCNWS, which is the Nursing Workforce Center, are in DSHS. Statutorily, they are under the Statewide Health Coordinating Council, which is an independent entity that is not part of DSHS. But they work together to provide administrative oversight and then professional expertise and guidance to these programs. So you can see here, HPRC and TCNWS are in the Center for Health Statistics in DSHS. And now I will talk about the Statewide Health Coordinating Council briefly. So the role of the SHIC, which is how I will refer to it, is to ensure healthcare services and facilities are available to all citizens through the implementation of appropriate health planning activities and by ensuring that healthcare services and facilities are provided in a cost-effective manner. Now, I read it just like that because that is how it is in statute. I put the role exactly as it is in statute for HPRC, TCNWS, and the SHIC. The SHIC is a 17-member council. 13 of those members are appointed by the governor. 4 are agency representatives, and the agencies that are currently represented on the SHIC are DSHS, the Texas Higher Education Coordinating Board, and then there are 2 representatives from HHSC. I think in statute it is HHSC and then the Department of Aging and Disability Services, which no longer exists as an agency. So again, we provide administrative support to the SHIC, and that's done through HPRC. In statute, there are a few responsibilities that the SHIC has. One is to form a nursing advisory committee. So we have the Texas Center for Nursing Workforce Studies Advisory Committee, which is an advisory committee to the SHIC, but it provides guidance and oversight to the Nursing Workforce Center. We also, the other responsibility is to form a Health Information Technology Advisory Committee, and that is a function that the SHIC did many years ago. It's not a functional advisory committee anymore, and instead we have a member of the SHIC who serves on HHSC's HITECH, which is their Health Information Technology Advisory Committee. The other responsibility is to establish a comprehensive professions resource center, and that is the HPRC. So that program exists under the SHIC. The other one is to establish a nursing section specifically under the HPRC. And then the main thing that the SHIC currently does is develop a statewide health plan. So that health plan is developed every 6 years with an update every 2 years between the 6-year plans. And the next one will be delivered November 1st of this coming year. So the other responsibility that is included under the SHIC is to collect and report on health professions data. A little bit about the state health plan. Like I said, it's done every 6 years, and there's an update that's done every 2 years. The state health plan must identify major statewide health concerns, the availability of use and current health resources, including IT and higher education, and it must identify future health service, IT, and facility needs for the state. So those are general guidelines that need to be addressed through that plan, and the SHIC currently determines what topics it's going to cover in each state health plan and its updates. Okay, the Health Professions Resource Center. So this is a comprehensive resource center for the collection and analysis of education and employment trends for health professions. There are 3 positions in this program, so the amount of work that can be done is limited, but I think there's a lot of health professions that are covered. So the responsibilities of the HPRC are to establish a nursing research section, which I will address when I talk about TCNWS. It's also to collect and disseminate data on health professions, demonstrating an acute shortage, so nurses, physicians, and a lot of other health professions, so oral health providers and things like that. To report on educational and employment trends, supply and demand trends, and other issues concerning health professions. It is also responsible for conducting research regarding graduate medical education system. So there's a specific report that HPRC is responsible for that looks at physician shortages and the need for GME in the state. And then, of course, to support the Statewide Health Coordinating Council. So HPRC has been around since about 1989. And so you can imagine there's a lot of health professions data that HPRC has collected since that time. In 2007, I think it was 2007, yeah, there was a minimum data set for health professions data that was established during the 80th regular session. That was through SB 29 that session. And that legislation created a minimum data set of fields that needed to be collected by licensing entities. So there are a number of fields that licensing entities must mandate on their licensure renewal forms. And then there are fields that they must include, but they don't have to mandate people to respond to them. So I think in one of the earlier presentations, Dr. Lisette Curry, who oversees HPRC, talked about the data collected by HPRC and how there are gaps in that data because there's different levels of completeness for certain fields and things like that, and that's where it comes from. So HPRC has 21 professions that are required by statute, but it collects data on 56 different health professions from a number of different licensing entities. And again, these are health professionals who are licensed or certified by the state of Texas. So we don't have data on the supply of any other health professionals who are not licensed and certified, so we wouldn't be able to look at PCTs or things like that. We look at nurses, physicians, dentists, acupuncturists, athletic trainers, massage therapists, all sorts of mental and behavioral health providers, just a very wide list of providers. The data fields that we usually get from those licensing files each year include addresses, both residential and practice addresses. We have information on their educational background and training. So if there are different levels of licensure, we might have information on their initial level of licensure and their highest level of licensure. We might know what year they graduated from their education program and the certifications and trainings that they've had. We have information on their date and place of birth. We have information on their sex or gender, race, ethnicity, the location of the high school that they went to, hours per week spent at their primary practice location, and primary and additional practice settings, specialty, and their county and zip code for those practice settings. So when HPRC collects this data, what we do is each year around this time, we reach out to the licensing entities and we remind them that it is their statutory requirement to provide this data to HPRC. We receive those files, we review them to make sure they've included the fields that they're supposed to include, we clean it up, and then we geocode it. So we take those licenses, the addresses that are on those licenses, and we geocode them so that we have exact location information for every profession. In addition to that, we process it down to a file that is what we consider the active workforce. So those licensees who have a license that is in an active status, that is current, that they are practicing in their field. So for example, with nurses, we don't count nurses who say they're practicing in a field outside of nursing. And then we look at whether they're practicing in a Texas county. So if they're not practicing in a Texas county, we're not considering them part of the active workforce. Then we take that data and we create a number of different data products. So we put together supply tables, which are the number of providers in each county. We create supply ratios from that, so the population to provider ratio and the provider to population ratio. We put together fact sheets that have demographic information, geographic information, practice information, all sorts of things like that for each provider type, or for a number of different provider types. We also then use all that licensing data to feed into the supply and demand projections that we produce. Those are the ones that feed the supply side model. And then, of course, all of that data is publicly available, so we make custom data requests. Anytime someone wants information that's not currently in a report online, they can just email us, and we provide them the information they're looking for. In terms of data sharing, like I said, all of this data is already online through these publications, and we provide data by request, but there are no formal data sharing agreements to provide this data to anyone else. However, if anyone wants it, they just have to send us an email. And generally, we provide most of this data in an aggregate form. So we receive these licensing files. We often get a lot of requests for, can I have this entire licensing file to email people that work in this area? And generally, that's not how we use the data. So, okay. And then we have the Texas Center for Nursing Workforce Studies, and its role is to collect and analyze educational and employment trends specifically for nurses. So it's under HPRC and statute, it's in DSHS. It is funded from nurse licensure fees collected by the Board of Nursing and then transferred to DSHS. Right now it's a small team of 3.5 FTEs. And we have the Texas Center for Nursing Workforce Studies Advisory Committee who provides guidance and oversight to all of the work that the program does. I think I have a slide about them as well. So the responsibilities that the Nursing Workforce Center has is to collect and disseminate data on nurses. There's also reporting on educational and employment trends, supply and demand trends, and other issues concerning nurses. Where there's a workplace violence prevention grant program that the TCNWS implements, and then we provide support to the Nursing Advisory Committee. The Nursing Workforce Center has been around since 2003. As far as the data that we collect, well, again, we get licensure data from the Board of Nursing. So we have the number and geographic distribution of every nurse in the state. We know their age, their race, ethnicity, their initial nursing education, their highest level of nursing education. We know their employment status, so whether they say they're working in nursing full-time, part-time, or on a per diem basis, or if they're working in a field outside of nursing, or if they are retired, we know all of those things. We know what employment setting they report and what position they say they hold. And that is the supply side of nursing workforce data. On the demand side, the data that we collect is collected through surveys. We survey employers of nurses, and right now specifically we survey hospitals, nursing facilities, home health and hospice agencies, and governmental public health agencies. And while we are, required to collect demand data, none of these entities are required to respond to us. So these surveys have varying response rates, and they vary every time we conduct a survey, and they vary by every setting. So the availability and quality of the data varies from year to year. From that data, we produce reports based on facility characteristics. We have some on staffing numbers. So we ask them, how many positions do you have budgeted? How many are vacant? How many additional positions do you plan to need in the next year? We ask them about their average number of employees during a calendar year, the number of separations they had. We ask them about their recruitment and retention strategies. And we calculate vacancy and turnover rates from that data. And so we have just quite a bit of data, specifically on hospitals, nursing facilities, and the other groups. As far as education data, we collaborate with the nursing education, we collaborate with the Board of Nursing on the Nursing Education Program Information Survey, which we call the NEPIS. This is an annual survey that goes out to all vocational, professional, and graduate education programs in the state, and we collect a lot of data through that survey and produce reports on program characteristics for all of these programs, admission, enrollment, and graduation trends, student demographics, and then faculty numbers and demographics. There's no response rate to this because it is required by the Board of Nursing, so that is a wonderful resource of data that we have in our state. And then we also have some initiatives on workplace violence. So we have a survey of individual nurses asking them about their experience of violence in the course of their career. This was first required of us by statute in 2015. So we did that survey in 2016 and we repeated it again this past year. So we'll have new results for that in the coming months. And then we also have a survey of employers. So we ask all the same employer types that we survey about staffing. We ask them about their workplace violence prevention programs and policies that they have in place. So we have a good sense of, how hospitals and nursing facilities have evolved in terms of workplace violence prevention and training for their staff. Again, in terms of data sharing, all of the data that we collect, we put online through reports. If it's not up there and there's something more specific you want, we always provide data by request. All of the survey data is provided only in aggregate form because we ensure confidentiality to our survey respondents. So that data will never be released in any other format. Okay, so we do have the Nursing Advisory Committee. And again, this is a nursing advisory committee to the Statewide Health Coordinating Council. The Nursing Advisory Committee currently has 21 members. It has representatives who are employers of nurses, educators of nurses, organizations that represent nurses, organizations that represent educators, researchers. We have 3 state agencies, currently DSHS, the Coordinating Board, and the Board of Nursing. There's a nurse representative from the Statewide Health Coordinating Council who serves as co-chair to this advisory committee. We have 1 LVN representative and a non-nurse consumer member. Their purpose is to provide subject matter expertise on nursing. The advisory committee uses specific task forces for each project that we have so that we can bring together subject matter experts on those specific areas to help develop the surveys that we use, to help promote the surveys, to help network with their, or to reach out to their networks to ensure people want to participate and to share the importance of why this data is being collected. Then they also put together the policy recommendations that come from the Nursing Advisory Committee. They are responsible for reviewing and providing feedback on the data and reports before we publish them, so nothing that we produce goes out before it's been reviewed by the Nursing Advisory Committee. And they develop the policy recommendations. So that is what the Nursing Advisory Committee does. Is there any formal data sharing? So currently DSHS has no formal data sharing agreements with other agencies or regional or local planning entities for healthcare workforce data. But all of this data is very accessible and easily available to anyone who's interested in using it. And like I said, all of it is available upon request. Okay. So I have these additional questions that I'll go through, and then there's just contact information. I'll just focus on the ones that we do have data for. On this list and this handout, if you have it online, you can see it as well. There were just several questions that came up. So one was forecasting future healthcare workforce needs using predictive analytics. Currently, we have a supply and demand model, and that is what it's projecting the need for additional healthcare for nurses, physicians, oral health providers, so dentists, and behavioral and mental health providers, as well as physician assistants. So there are about 5 or 6 providers that we have the supply demand model for. The next one says make health.
Sorry. In the supply and demand, where do you get your data for supply and demand? Like we heard Workforce Commission,
yes,
they get
yeah.
it from job postings and then they get it from, so
Sure.
can you?
let me talk a little bit about the model that we have. Okay, so our model differs from TWC in that we're not looking at the labor market. The demand side of the model that we use is looking at healthcare utilization. So it uses historical data from the past 3 or 4 years, depending on the data sources that they're putting in there. So they use data from like the Medical Expenditure Panel survey. They look at different data sources that look at healthcare use. And that is what helps, that's what goes into the model, the demand side of the model for utilization. They also put in population characteristics to create these population profiles for each county to look at what the projection of that population's healthcare use is going to be if based on the current characteristics. So if today this population has these demographics and experiencing these chronic conditions and all of these things, and they're using this level of health care, what is that going to look like if we project growth into the future? So it's very much looking at demand for healthcare utilization. So for nurses, for example, it's looking at, based on the utilization, these are the number of nurses that we used before, so this is how much nursing services we're going to need in the future. The supply side of the model looks at this licensing data, looks at migration, in and out migration of the state, education trends, work patterns. So how many hours nurses are saying they're working, to what age are they working? And so we can adjust these models a little to look at different scenarios, which we do have available, but our reports really focus on the status quo because for most of these, we're projecting shortages based on already just what we have. So if we're looking at increased retirement, well, the shortage is only going to get worse, right? And then on the other side of it, when we make adjustments of like, what if we increase production by 5 or 10%? It's not making a big difference in the model because it's the demand side that is really increasing. And our ability to stay up with that on the supply side is not quite there yet. So is that? Yes. Okay, all right. Okay, so then there was a question about whether healthcare professions data could be made available on a regional basis, maybe even aligned with local workforce board regions, and the answer is yes. So currently, a lot of the HPRC data is in dashboards online, and we have that data with certain filters available already. So you can look at it by public health region, you can look at it by urban rural designations, you can look at it by border, non-border region, metro, non-metro region. So adding the workforce board regions would be a simple thing that we could do. But if it's not currently on there and however long it might take us, somebody could request that data from us and we're happy to provide it. Let's see, I'll go down to where it says, do you collect employee attrition data and at what level of detail? So for nurses specifically, we have vacancy and turnover data from schools of nursing. So we have that information about faculty. We have it for nurses who work in hospitals, in nursing facilities, and home health and hospice agencies and governmental public health agencies. But that data is available based on survey data, right? So the data is only as good as how many people respond to our survey at any given time. Although I will say for the hospital data, and hospitals employ almost 2/3 of nurses, we get a 50% response rate. The quality of the data is very good. The next question says, regarding applications for nursing school, collect more detailed information about why an application was not accepted, and that maybe not all of them were actually qualified or fit to be accepted. In the NEPIS, the Nursing Education Program Information Survey, we ask about the number of qualified applicants who met admission standards by admission period for the last academic year. And that term, qualified applicant, is defined in the survey. So they're supposed to be reporting an applicant for admission that meets all minimum requirements necessary for the nursing education program. And we've been asking it that way at least since 2013. So the numbers we have shouldn't be based on people who weren't qualified for the program to begin with. We also asked them to rank the importance of reasons why qualified applicants were not offered admission. And the reasons that they can rank are lack of faculty applicants for budgeted positions, lack of budgeted faculty positions, lack of clinical space, limited classroom space, high faculty turnover, delays in hiring new faculty, and then other, and we give them the opportunity to tell us what those other reasons are. So we do have that data available. We ask it in the survey every year, and so we have lots of years worth of that data. And that's where we tell, we can say the pinch point for nursing education is clinical sites, because that information has been consistent over the years. And that's available on the Nursing Education Program Information Survey fact sheets, which are online. I feel like I'm repeating these words over and over again. Okay. So the next one that I can address is facilities don't report 1, 2, and 3-year retention rates. What data does the center collect regarding nurse retention rates at facilities? So we ask for vacancy and turnover rates by nurse type. And in hospitals specifically, we ask for turnover of first-year RNs. And that question is, what was the turnover rate, both voluntary and involuntary, as calculated by your organization of first-year RNs during the last calendar year? So we do ask that information, but again, it comes from surveys. We have it, the data quality is pretty good for hospitals. It varies a little bit more for nursing facilities and home health and hospice agencies. Now, we don't have it for that 2-year and 3-year mark. And that would be a great discussion to have with the task force for that project, is how readily available is that data? Because we can ask these questions, but the more questions we include in these surveys, or the more difficult it is for hospitals or these entities to go and calculate that, the less likely they are to respond. Okay, is there any data collection from alternative treatment sites like FQHCs or nursing facilities? So we don't collect data from FQHCs, but we do collect it from nursing facilities. And when we conduct these surveys, I should have said this earlier, these surveys go out to the entire population of facilities who are licensed by HHSC. So the entire list of public hospitals, all of the nursing facilities. For home health and hospice agencies, we reduce it to agencies with a certain patient census, because we're not trying to capture the one nurse who serves as a home health and hospice nurse in her community. And they go to the facility administrator or whoever is listed with the licensing entity, or the director of nursing. So when we send these out by email, by regular mail, by fax, and we give them all a call and invite them to participate. So we really strive to make sure that we're reaching all of these entities with these surveys. But right now, those are the ones we collect. Those are the ones we have resources for. We don't collect this information from FQHCs. The next question says, does the center collect data related to nurses who are leaving the profession versus leaving the bedside? So I think the short of it is no, we don't collect that data, but we could review licensure data to assess changes in their license status. So someone who says I'm employed in nursing, so this would be their employment status, right? They're employed in nursing versus those who might report that they're not employed in nursing, and we can see whether there are changes in that from year to year. We can also review changes to the positions they report. So I believe one of them is staff nurse, and then there are other position types like manager, administrator, researcher, consultant, different things. And so we can assess those changes as well. And we could also look at changes in their license status. So they had an active status, then it moved to an inactive status or retired status or what have you. Those are all things that we could assess, but we just don't get to so far. And then the last one says, could data be collected regarding unlicensed workers in the health professions? It would be very difficult to collect data from unlicensed professionals because you don't know who they are. On the employer side, we could report on positions. And so in our nursing facility and home health and hospice surveys, we ask about, in home health and hospice, about home health aides, the number of positions they have, the vacancy and the turnover. Hospice aides, and CNAs. We asked that question with all three of those combined, so we don't have it broken out at this time by those types. And then for nursing facilities, we do ask about CNAs, medication aides, and restorative nurse aides all separately. And we also ask for those numbers by position for direct resident care versus administrative positions. Now, this is where I'll say the surveys vary across setting based on how we might ask these questions, because the task forces are comprised of subject matter experts, and we really try to hone in on what is most critical to that industry when we develop the survey. So that's why in the home health, those are combined. In the nursing facilities, we ask it all broken out, and then we ask about administrative positions versus direct care positions. So it just depends. We have some of that data, but it's limited, and it's based on the employer, the number of positions that they report having, and the number of vacancies they have. And of course, it comes from survey data. Okay, so those are the questions that I had on this sheet. And then, of course, you have the list of occupations and the HPRC professions that we track based on those occupations. And then I will make sure that you have the list of all 56 professions that HPRC collects, and it will note the 21 that are listed in statute. Oh no. Well, the last slide is just our contact information and some, oh, there you go. Our contact information, and then the next one has links to our website where you can find our data. And then the very last one is Texas Health Data, which is the dashboards that we currently have up there. All right, that concludes what I was going to share today.
Any questions from the panel?
I have a quick question. Hi, Pam. Do any of your reports or annual reports, or however often that you do them, include any public policy recommendations? Or is it more of a summary of the data?
So there are recommendations. Not all of them are public policy recommendations. So in the nursing reports, the staffing data has recommendations that are, a lot of them are specific to employers. Like, these might be best practices to address these issues. And then the Nursing Advisory Committee occasionally puts together recommendations that are policy recommendations. So it's a mix of both. And then the recommendations that come from the SHIC and the state health plan specifically are policy recommendations. Mm-hmm.
Thank you very much. Appreciate your being here today. So for the panel, lunch is in the back. Please feel free to get up and help yourself. And I do have to make an adjustment to the agenda. And so I do apologize. Dr. Hooper, I'm going to ask you to hold on just a minute. We're going to have the Higher Ed Coordinating Board give their presentation, and then we'll circle back around to y'all. Thank you so much. So we're going to hear from the Higher Ed Coordinating Board, Elizabeth Mayer, Assistant Commissioner for Academic and Health Affairs, Dr. Tina Jackson, Assistant Commissioner for Workforce Education, Chad Contero Poles, Assistant Commissioner, Student Financial Aid Programs, David Troutman, Deputy Commissioner, Academic Affairs, and Michelle Singh, Assistant Commissioner of Digital Learning, and Carrie Gritz, the MILS Director. So thank you all very much for being here today.
Yeah, sorry. Good morning, afternoon-ish. Oh, the clicker. Can I have the clicker? Thank you. All right. So I'm going to go through a couple of items today. I'm going to talk about our program approval process for all the degree programs that our agency oversees, and then I'm going to talk about the health affairs grant programs that are administered by my division, and then Chad and Tina will go through some specifics in their area as well. So, program approval. So the coordinating board is authorized by the Education Code 61.0512 to approve new degree and certificate programs. So what I'm going to go over today is for all the programs. This is not special for nursing. So we're ensuring high quality programs are going to be offered throughout the state, regardless of the discipline. So you can see here, here's the list of criteria that we have in rule. So state and local needs. So is there a need for the program? Second is duplication. So is the program going to be duplicating any existing programs in the area or the region? Third is comment from other institutions on need and duplication. So this is a little bit different. We just went through a pretty significant rule revision on program approval. We used to just say, institutions, go do your comment period and then let us know if there's any comments. What we're doing now is we get the proposal and then we actually send it out to the institutions in the region and say, are there comments? But you can't just comment about anything. There are two specific things that you should be commenting on. One is related to a state or local need or evidence of whether there is potentially unnecessary duplication. Next, is there appropriate financial support for the program? We don't want them starting programs that are going to close soon because they don't have the appropriate resources. Are there adequate number of faculty and staff to support the program? Are there adequate resources to support the proposed and existing programs? Do they have existing programs that are struggling? we take that into account. So is there alignment with the board's strategic plan, Building a Talent Strong Texas, which Dr. David Troutman will be providing an overview on in a few minutes. And then are there any concerns with the existing programs offered by the institution? So that's kind of like all of the things that we look at to make sure that the institution is going to be offering a high quality program. As I said before, no specialness about nursing programs in that regard. We do, however, look at any programmatic accreditation. It would raise some flags if there were some issues with some Board of Nursing, if there was some issue with any of the accreditors, particularly for the graduate level programs, which I'm not really going to talk about today, but just wanted to let you guys know that. Okay, so there is a special portion of the statute related to BSN that are going to be offered by our community colleges. So you can kind of see here all of the buckets of things that we look at. So there's a letter from the Texas Board of Nursing showing that the proposed BSN program meets state standards. We also want to make sure that the current associate's degree program for that initial licensure program is a strong program, and that they are going to be able to offer that strong bachelor's program as well. Evidence that the program has acceptable job placement rates and licensing exam scores as determined by the Board of Nursing licensure exam, and they must be 80% or higher for the previous 3 years. And then the copy of each clinical site agreement and a letter from each clinical site showing adequate long-term clinical space to support the nursing program. So this is kind of a lay of the land in terms of what our agency does. We are separate from the Board of Nursing in terms of what their requirements are, but in terms of what we offer or what we have approved, so there are 54 initial licensure programs that are offered at our community colleges. In addition to the Associate's Degrees Awards, there's also 18 programs at community colleges that are that RN to BSN program. There are 28 universities that are offering that bachelor's initial licensure, as well as the 7 health-related institutions. In addition, we were asked to provide how many new programs have been started since 2020. So we've had 24 new programs that have started, and 22 of those are at community colleges, but they're RN to BSN programs, 1 at a university and 1 at a HRI. There was 1 program closure, and that was based upon not meeting the necessary NCLEX pass rates for the programs. And then this is, I apologize, I was working and I think I deleted part of this label, but this is showing basically health professions for all the programs we offer in the state in terms of certificates, associate degrees, and bachelor's programs. So it's like the universe of what I call CIP 51. I don't know if you guys knows, but it's so it's intended to show the production or those that are practicing as a licensed professional and assistants in the health profession and related clinical sciences. So it's kind of like a very wide bucket of all the things that are approved, but you can see there kind of where we are in terms of the state. Certificate 1, Certificate 2, those are typically shorter term credentials, don't take as long to complete. And associate's degrees, and then bachelor's degrees. And then you can see on the right kind of the community colleges who's offering kind of what. The certificate 1s, they are at least 15 hours or no more than 42, and they took 1 to 3 semesters. Their certificate 2s are at least 30, but not more than 51, typically take about a year. I just went and calculated, and it looks like in terms of production, based upon this, we have about 18,000 students who completed this last year. So I'm not going to go into this in detail, but did want to highlight as part of our House Bill 8, which was the community college financing, drastically changed what we're collecting in terms of shorter term credentials. So this universe, we're going to start having more of a line of sight on than we have historically. Yes. So this is kind of like the start of that. A lot of the institutions, particularly community colleges, offer those shorter term credentials. Universities are starting to do more of that, and we are going to get a better understanding of what that looks like holistically. So just wanted to plug that. Okay, so that is the program approval kind of portion of my presentation. I'm now going to move to the funding overview, and so these are the grant funded programs that our division oversees. Okay, so You can see here, professional nursing shortage reduction program. I know we've talked about this, I think, a couple of times. Minority health research and education, nursing, allied health, and other emergency trauma care, and then the nursing innovation. So this is the funding. And so left to right, you can see the darker blue is the 2020 to 21 funding, and then that middle is 22 to 23, and then that last one is the 24 to 25 funding. So you can see the professional nursing shortage reduction program received a pretty significant bump this last legislative session. For the most part, the other programs have remained relatively stable. That last program, not to be confused with Nursing, Allied Health, and Other, it has historically been called NIGP, but then the legislature included a rider also calling Nursing Innovation or Grant Program. They're actually two separate programs, somewhat called the same things. But I'm going to go through each to kind of give you kind of an overview of what each of these is intended to do. Okay, so the professional nurses reduction program. So this program has actually been in existence since 2001, and it's intended to increase the production of licensed nurses at Texas public and private and nonprofit institutions. So you can see there, as I said before, had a pretty significant bump. The program has gone through since some revisions since it was started. So in 2020, there was a work group. So there used to be three separate buckets for the program. So there was the regular program, the over 70, which was based upon graduates, the under 70, which was based on graduates. So nobody liked that. So they decided to, let's have a work group. And so there was a rider that was put in place in 2020 to look at that. So after all of that work, we basically decided, okay, we're going to have one program, and that was established to be the growth tier. So you had to show that you were increasing the number of graduates. We didn't like that. So now we're back to three buckets, but it's three different buckets now. We have the growth tier, the production tier, and the faculty tier. And so that was what was implemented this legislative session in rider. A little bit of a wrinkle, complication for this program is the statute really hasn't been touched since 2009, but there's some challenge to harmonize the statute and the rider, and we went through a rulemaking process. We went through negotiated rulemaking recently, and it was a challenge to align all of those things. And really the focus of the rules was really that growth tier, because that is actually what's in the statute. So that is just a little bit of a wrinkle with that program. But from last legislative session, I think there were about 42 programs that received funding when it was just based on growth. And this coming, what we're actually pushing out money for now is about 83 programs. So based upon that revision, it did increase the numbers of the types of programs that we're going to receive funding. Okay, so the Nursing Allied Health program. So this program has also been around for quite some time, since 1999. The funding has remained relatively stable since that time. It's intended to support nursing innovation grants and to help relieve the state's nursing shortage. The program has maintained the funding, as you can see, and these are funded through the tobacco settlement. Since 2000, the agency has awarded approximately $46 million to 96 institutions. This isn't directly related to nursing, but I wanted to go ahead and just kind of highlight this other program, which is the Minority Health and Research. So this is also tobacco funded and has been in existence since 1999. So this provides grant funding to Texas institutions of higher education to conduct research or educational programs that address minority health issues, or form partnerships with minority organizations, colleges, or universities to conduct research and educational programs that address minority health issues. So you can see there, like I said, funding has remained relatively stable. The Emergency and Trauma Care Education Partnership Program. So this program actually is intended to fund GME, so graduate medical education, as well as nursing. So there is not a lot of nursing programs that are focused on emergency. So there's not a lot of applicants, and so the portion that is received from the nursing, I think it's typically one program, and I think it's about 1.9 million. The rest of it really does go into GME, since there's a lot more of programs that are focused in GME related to emergency and trauma care. And then last, so the Nursing Innovation Grant Program. So as I said, this was not put in statute, it was just in writer. And this is basically the writer language. So what we have done is we've actually partnered with UT Health to complete a scan of the current landscape of kind of what this looks like, what programs exist at this point. And they also pulled together a grant program design, and we're in the process of reviewing that. And after we're done with that, we will likely be releasing an RFA to figure out how we're going to distribute those funds based upon that feedback that we received. So now that was a lot, but that is my portion. I don't know if you have any questions or if you want to do the panel, how you guys want to desire. Okay.
Hello, colleagues. So glad to be here with you afternoon. Well, while she's pulling up my slides, I'm Tina Jackson. I serve as Assistant Commissioner of Workforce Education. So glad to be here with you all today. And I'm going to share an overview for you all about the Carl D. Perkins program. And so this is a very well-known program across the state, and we have great participation with all of our colleges. So what is the program? Basically, it is a program that helps to make sure that we support our career and technical education work across the states. We primarily work with all of our 54 community and state technical colleges. And this act that first originated in 1984 is now really helping to support everything connected from equipment to classroom, things that our faculty need, to making sure that our students are really where they need to be to get right into the workforce once they complete their degree, certification, and go on to a 4-year entity. So really excited about this work. And then also the act was revised in 2018, and so I'll talk a little bit about that and what those changes were. So just to share a little bit about this, I'm going to go very quickly because I know I have other colleagues who are going to present. The goal is really to focus in on academic knowledge around career and technical education, also to provide employable skills, and so things related to occupation specific. So we also are very much aligned with TEA and their programs of study, and the work is really to make sure that as students seamlessly transition, they're able to get those certifications and those really credentials of value quickly and in a way that really meets the industry partners' needs. And so another component of the program is that all institutions are required to meet certain performance indicators. And so as we look at this here, I'll just share briefly that these 3 areas are important because we want to make sure that our institutions retain our students and place them into the fields where we see needs necessary. We also know the importance of, we've been talking about this for the past probably 4 years now, the recognized credentials that really are the high demand credentials. And so we have an area for performance indicators in that area. And along with that, the non-traditional programs are critical. So making sure that our students who are, let's just give you I'll give you an example. So for nursing, that we have males in those particular programs. In the trades and constructions, that we have females in those programs. And so as we monitor these programs, we are also expecting that our institutions meet 90% of their indicators for performance basis. So this is across the board. To share a little bit more about another requirement that's critical to this work, we do require that all of our state colleges and community colleges have local, comprehensive local needs assessments. And so as you can see here, these are the 6 areas that the institutions have to focus in on. We've got great participation across the state with student performance, making sure that students are getting what they need out of their CTE programs. The performances across the state look unique based off of regions, but definitely we have a lot of people engaged in this work. We also have a piece that talks about the program size and the importance of the quality of the program. Labor market demands and alignment is critical, and we also are looking at our retention, making sure that students are completing these certifications. As you all know, because they're in high demand, there's a lot of emphasis put on completion because some of these students, of course, are recruited before they complete their certifications or their degrees. And then lastly, but definitely not least, making sure to identify gaps that we see with the data as it pertains to closing achievement gaps. So these are really important areas when we talk about this work. I thought it would be nice just to share the budget with you all, colleagues. Just to talk on a federal level, the dollars come straight to TEA, and from there we get 30% of the budget with this program. And so as you can see here, we have about a little bit over $38 million that helps to run the Perkins program. Of that money, a little over almost $2 million is for admin. And then we have a leadership program for all of our colleges that are engaged in innovation and helping to scale things that we see as promising practices in the field. And lastly, $32 million goes directly to all of our institutions across the state to run the programs. I thought I'd share a little bit about the differences with the nursing programs and who's being served, and my colleague talked about that a lot. So I'll just say that what we're seeing for the most part is that the individuals involved with getting resources across the state, they support things like professional staff, making sure that we have the equipment that's necessary. Also focus a lot on curriculum enhancement and revisions and things around continuous improvement planning. We also have pieces in place for professional development as the field changes so that our faculty and staff and administrators are aware of that. And lastly, we're really focusing in on how we can support our overall student with things like childcare and other challenges that we've seen that came out of the pandemic related to wraparound services for our students. So to share, I talked a little bit about this, but just to share at a state perspective who Perkins reaches, there are 54 community and state technical colleges that receive funding. Out of those different programs we have seen across the state, the community colleges are very much engaged in this work. Colleges in general, as my colleague mentioned, are engaged in making sure that there are programs available for nursing students to go through and get the right high-value credentials. And then this is also to share a little bit about the funding that we know has already been implemented. As you can see here, for this year alone, we've got Perkins funding that's supporting the work across the state. We also have budgeted really a lot of initiatives that are reaching towards making sure that our students receive excellent education around nursing and also healthcare. And I'm going to turn it over to my colleague. I know we've got like 3 others that are going to present, so I won't stay long.
Hampered here. So I don't have a PowerPoint, but you should have a handout regarding loan repayment assistance programs in Texas. I was asked to speak about the scholarship and loan repayment programs that are available, particularly in relation to nurses, and wanted to start with just a quick follow-up to what I've discussed with you before about the nursing scholarship, simply because today was the day that the rules for that program became effective. And so the program is in place now, and we will very soon be providing the allocations to all of the eligible institutions, both 2- and 4-year public institutions, so that they can have funding to begin offering the nursing scholarships this fall semester. That was made possible through the funding attached to Senate Bill 25. And the creation of that nursing scholarship really creates a unique program in terms of the financial aid programs at the agency, in that it is the only program we have that is targeted towards a very specific academic program. All of our other financial aid programs are really looking at students regardless of the academic program they're pursuing. So nursing scholarship is very unique in its structure in that way. The place where we provide funding for the healthcare programs, particular nurses, is primarily through the loan repayment programs that we have. And we have 4 loan repayment programs in the state, 3 of which nurses are eligible for. And the handout provides you some details with those programs, one of which is the brand new nurse loan repayment program that, again, also has its rules that are effective today. And we will be launching the application for that program on September 4th. So that nurses can begin applying for loan repayment through that program. It is, again, funded through the funds attached to Senate Bill 25 and provides us an opportunity to provide funding to help licensed vocational nurses, registered nurses, and advanced practice registered nurses to be able to repay up to $16,000 per year, depending on the type of license they have, depending on whether they're full or part-time. But really, we targeted that towards the data that we were able to find regarding average federal educational debt levels that these individuals carry, with the goal that if they participate in all 3 years of the program, that it would repay in full that average debt level. We have 2 other programs that nurses are eligible for. There's the Nursing Faculty Loan Repayment Program, and that program was revised as part of Senate Bill 25 as well to allow part-time nursing faculty to participate. In the past, it had just been full-time nursing faculty. And another change in the past, the amount that we could provide to each nursing faculty member was limited to $7,000 per year, up to a maximum of 5 years of participation in the program. The statute was adjusted to provide the coordinating board with the ability to determine the maximum amount. And so we're going to be looking at several factors in terms of actual participation of the average debt that those individuals have, as well as national data on debt, as well as the funding that's available for the program, so that we can identify how to raise that annual amount above the $7,000 level. There are also nurses who are eligible for the mental health professionals program. And so specifically advanced practice registered nurses who are focused in the mental health area are eligible to participate in the program as one of many different disciplines that are eligible to participate for mental health professionals. The amount that mental health professionals are eligible to receive ranges from $10,000 all the way up to $160,000 that they can receive over 3 years, depending on the discipline and practice specialty. And so like psychiatrists are the ones all the way up at the $160,000 level, and it's varying levels depending. But that is a program that is eligible for nurses. Rounding out our loan repayment assistance programs for health care professionals is the program focused specifically on physicians. That is the program that has been around the longest of all of our loan repayment programs, and that does provide up to $180,000 over 4 years of participation for physicians who are licensed through the Texas Medical Board. I'm happy to answer any questions about any of the specific. I'm sorry, I forgot to mention something else on the back of the page, because one of the questions that was asked was what information that we might have about outcomes related to these different programs. And so we did provide some information for the nurse faculty, the mental health professionals, and the physicians programs, those programs that have been active, to provide some data about what percentage of individuals participate in the maximum number of years of the program, as well as for our mental health professionals and physicians. We do look at recipients who have remained in the shortage area, both continuing in the program, but also after the program. Have they continued to work in the either the mental health professional shortage area or the health professional shortage area, to see, because a key piece, the ideal with these loan repayment programs, is not just for them to go and take a job while they're getting their loan repaid, but for them to then stay in the community to continue to support. So did want to provide some of the data on that, as well as some basic information about how many people are participating on average each year, how much we're dispersing annually each year, as well as how much we've been appropriated for these various programs. We'll move and let the next group of people come.
All right, thank you. So we have David Troutman and Michelle Singh and Carrie Gitz.
Thank you so much. I'm David Troutman. I'm the Deputy Commissioner for Academic Affairs at the Texas Higher Education Coordinating Board. So thank you so much for having me this afternoon. So I'm going to talk to you about Talent Strong Texas and just give you some information on the metrics we're striving towards for higher education in Texas. I don't have a PowerPoint. It's just we'll have a conversation. I'm happy to answer any questions you might have. So when we think about building this Talent Strong Texas, we released this in 2022 that was supported by the Governor's Office and other agencies. The center point around this is credentials of value. How can we help students be better off going to college? How do we prevent them from experiencing a credential of harm, but actually reaping the benefits of a credential in post-secondary education? And when we decided to go this route, we're the first state in the country to actually place our metrics in context of credentials of value. Thanks to the partnership with the Texas Workforce Commission, we have access to earnings data, so we can understand the benefits of degrees for students that are residing in Texas. And with that, we leaned in and we really wanted to make sure we had metrics associated with that to make sure that we're supporting our students. So when we think about credentials of value, our goal by 2030, we must produce 550,000 credentials of value per year. So 550,000 students have to receive some type of credential of value. If you place that in context with city populations, we would be the 33rd largest city in the country if we hit that mark, or when we hit that mark. And I think that that is exciting, but also daunting. I also want to acknowledge that one of our metrics is focusing on attainment. So 60% of our young adults ages 18 to 24 would have some type of credential. And then we also reframed it to focus on 25 to 64-year-olds, making sure that we help our Texas citizens have some type of credential that would benefit them in our workforce, our raging economy that we have in Texas. And we're also trying to tackle the 4 million Texas residents that have some college but no credential. And I think part of our effort is really figuring out how we can look at supply and demand in Texas so that we can fill the void with an educated workforce that we know that we need in healthcare related fields. So that's why I'm excited to be here. And so with those two metrics of the 60% attainment, but also the 550,000 credential value, we're leading through a number of initiatives. Elizabeth Mayer, Chad, and Tina, thank you, briefly mentioned some of the work that we're doing. I also wanted to highlight some additional work that we're doing to make sure that we are creating this pipeline of opportunity for our students in Texas, or our potential students in Texas. So the first is our mytexasfuture.org. Think about it as being the higher education entity website that all potential students can go to learn more information about the avenues of higher education and the benefits of receiving a credential. Think of it as like a texas.gov for registration of a license and such. And so within that on that website, if you go to it, it's going to ask you one simple question. Are you a middle school or high school student? Are you an adult learner? Are you an adult or a current college student? When you click that button, it reshapes the website content based on who we're speaking to. We don't want to speak to an adult as if we're speaking to a middle schooler. We want to create career quizzes and other types of information at the fingertips of individuals who might be interested in healthcare. And so we have these quizzes that students can take or individuals can take to really help them frame out what they're interested in doing, and then we connect them with the institutions that provide those types of programs within our state. Another initiative we just went live in June is we've taken over Apply Texas from UT Austin. With that, we've revised it so that it creates a better student experience so students can help themselves through the process and counselors can help them as well, making sure that we're lowering the stress levels of students so they're exploring options for what institutions they might want to go to and the programs of study they'd be interested in going to. So that's another thing that's really important. We're implementing next month direct admissions. So we have 27 four-year campuses that are participating in a direct admissions initiative with us. When a student will go to My Texas Future, they'll be asked 7 questions. Based on those 7 questions, it's going to let them know if they're automatically admitted into an institution, and then it will ask the student to go through the Apply Texas portal so that they can understand what programs of study they'd be admitted to. And so it's really going to help broaden the opportunities for students to explore higher education. Because when we zoom out and we look at the data, since we have the tri-agency relationship, I understand what's happening to students after they receive a high school diploma. 28% of our students in Texas don't even attempt to go to college, either at a 2-year or 4-year. 1 out of 4. We can do better by that. We can make sure that we can provide an opportunity for students to have a line of sight of where their potential careers could go and how they could benefit from those careers. So it's really exciting to see that. Internally, we've been working with the data that we have with the Texas Workforce Commission and the coordinating board data to create secured portals for our institutions to have a better line of sight of their students' progress towards a degree. So Elizabeth mentioned, having a number of degrees produced. Well, who starts out as a nursing major and who ends up completing that degree? Having the persistence and graduation data to understand what's happening to our students, and then being able to disaggregate that by race, ethnicity, gender, and family income status will be key to understanding the barriers that may face students as they're pursuing. I get so excited when I think about the data of how we can craft a message and stories and reduce blockers for students who want to be a nurse. What courses are creating barriers for them? Or what types of limited opportunities with a headcount of space available for a certain department? And how can we help create an environment where they might be able to go and attend a university to become a nurse based on the headcount that can create restrictions? So that's one area. Transfer students. We're trying to get a better line of sight of transfer students and their experiences in the healthcare related fields. So we have, based off of SB 25 that was passed a couple of sessions ago, we are required to request data from our 2 years and 4 years on recommended course sequencing for each of the programs that are offered at their institutions. Now in the healthcare related fields, we know the courses that are being required their first year, their second year, their third year, their fourth year. And so we can have a better understanding of any kind of college readiness barriers that may exist based on either math readiness or English or language readiness. And so we can do more interventions and help supporting students as they want to pursue a healthcare related field. And then we also have our student success team that's really creating a robust inventory of student success programs across our state. So right now we have around 500 programs that we've identified that are taking place at either our 2-year or 4-year campuses. And how can we look at those programs to see what types of health-related student success programs are helping students strive towards their degree? So that's really exciting as well. So I've thrown a lot of numbers at you, and I've floated a lot of initiatives at you. I'm trying to be really brief because I know I want to respect everyone's time. But do you have any? You might have any questions for me. I'm happy to answer.
Any questions on the panel? Okay. Thank you very much for the background. Yeah. It's a really innovative report. I really appreciate it.
Okay, and I think we are getting the show started. So while we do that, good afternoon, everyone. Thank you so much for allowing us some time to be in front of you today to introduce some exciting work within the Digital Learning Division portfolio. Our Open Educational Resources OER Nursing Essentials project, which we affectionately call The One. I realize those are a lot of 3-letter words, so clearly we'll keep it simple for y'all. I'm Michelle Singh. I'm the Assistant Commissioner of the division, and I'm joined today by Carrie Gitz, who is our lead project director on the project itself. And so to give you just a quick insight on the division itself, we were established in November 2020. You can see our mission articulated on the slide, as well as our small but mighty team on the right-hand side. And really to stress that the division, through collaboration and partnership with stakeholders across the state, manages and leads a robust portfolio that includes a high level of digital excellence, which includes open education and OER initiatives, similar to the OER grant program, our OER Texas Digital Repository, which houses over 500 million users from across the world collaborating on open content and enhancing innovative pedagogy efforts. We also do a significant amount of research within the open educational area to ensure that we stay relevant with the resources, programs, and services that our division builds. We pride ourselves on the goals of advocacy for, capacity building, and recognition of digital excellence, which we know exists across the state in spades. And we pride ourselves on partnering with the best and the brightest across the state of Texas, which includes several of our institutions, as well as industry partners. Our partner for this particular project was OpenStax at Rice University, which is the world's leading publisher of free open educational resources. We had the pleasure of working with Anthony Palmiato, who is the Director of Higher Education for OpenStax, and it is my pleasure at this time to hand it over to Carrie, who will talk a little bit about the background on the project.
Thank you, Assistant Commissioner Singh. The project goal for the One project was really just to design and develop OER that was focused and aligned with the American Association of Colleges of Nursing, the AACN New Essentials curriculum. And just for purposes of definition, when we talk about OER, or Open Educational Resources, that means or refers to a teaching and learning resource that is publicly available in the public domain or has been released with an intellectual property license that allows for free distribution, free access, adaptation, and redistribution by any person. And it can be available in a variety of formats and ranges from full course curricula to individual textbooks, assessments, etc. So it ranges in the broad type of material. But the highlights of the particular project, as Assistant Commissioner Singh mentioned, this project really built on our existing partnerships and collaboration with OpenStax that enhances and further builds capacity for our open educational resource landscape in Texas. And this particular project was a $5.2 million project that leveraged funds from the governor's emergency education relief funds. And it brought together expert faculty, competency-aligned curriculum, and freely available resources. And it included and includes a robust editorial process and production process that existed and created opportunities for extensive collaboration across the state in the peer review process, authoring, input, and design of these course resources. The origins of the project really generated from conversations with nursing educators about the changes in the curriculum and the impacts that the new essentials curriculum were having on the new competencies and how educators were addressing these, but also changes in curriculum to the next gen NCLEX and the need for student preparation and how educators were addressing this. The opportunity to develop curriculum or OER for this curriculum not only supported instructors in addressing these changes, but it also provided opportunities to reduce barriers to students by lowering the cost of course materials, essentially eliminating the cost of course materials. And really that collaboration expanded stakeholder involvement. We had over 500 participants that ranged from nursing educators to deans, department chairs, expertise and input from nursing boards and other organizations, not only in Texas, but across the state. And this really led to significant student success and faculty innovation, and the ability for faculty to have those resources and be able to modify and adapt and meet their teaching and learning needs, and to have the student not pay anything for those materials. The particular project, actually, the funds supported 3 phases of the project, and it started with the discovery phase, which was really the essential research and feedback stage, which we gathered information in partnership with OpenStax directly from those the nursing educators and those in the field about what the challenges were, what the needs were for instructors, what the student voices were and the experiences of the students, to help us design and craft and really sort of understand the benchmarks of what developing these resources would mean. This laid the framework for the planning phase, which included identifying the subject matter experts of who would serve as the authors and the peer reviewers for these materials, identified which books would be developed, the content that would be included, including a robust table of contents, all the ancillary materials, all the artwork, all of the things that would be needed to develop high-quality open educational resources that would be usable and adaptable for instructors and students. And then it further, we did some further analysis on existing open educational resources that existed from other projects like OpenRN out of Wisconsin, to see what could be reused and adapted and put into these resources as well. And then finally, the implementation phase, which is the most exciting phase, which is the actual publication and release of 8 openly licensed textbooks. And this phase not only created put the final touches on these works and it developed not only the resources but the instructor materials, but it included a 2-day virtual summit where it was the One Summit, where we gathered more than 600 nursing educators and nursing practitioners, open educational resource practitioners in the field to come together to learn about these resources, to hear directly from the authors and the contributors, and also attend workshops on how to adapt and map these resources to their curriculum, so how to implement them in the classroom for their teaching. And this slide is just courtesy of our partners at OpenStax, but it demonstrates how for each textbook, the process that went into the design and development and the focus on these core considerations to make sure and ensure that these resources are usable, they're relevant, and that they address the needs of the student preparation as well as the faculty teaching the competencies and the curriculum for these changes. And above all of these books we've said, and you'll hear more when Michelle talks about the impact, but they are openly licensed, they are freely available, they are written by experts, and they are available in multiple formats, so they can be accessible in online, print. These are the 8 titles that are available. 6 of the 8 are fully published and available online. And when I say fully published, that means they are being used, and they not only include the books in multiple online formats, but they can be downloaded, and they also include full ancillary materials for instructors as well as students. And the remaining 2 will be published in September, but there are free pre-publication versions available online for use if faculty choose to at this time.
So let's talk a little bit about the impact and where we are today. So we really wanted to take the conversation into different aspects of impact and what we mean by that. When we talk about open educational resources, the natural inclination is to talk about affordability because, of course, a zero-cost textbook is going to have a resultant cost savings for our students. So when we start to talk about that, on an average, students can spend $500 to $900, if not more, a semester on course materials, with the One Nursing Series materials being completely free, also providing day one access and perpetual access so that students can utilize the information throughout their curriculum and throughout their career progression. We have a potential cost savings with the 32,000 nursing students in Texas, approximation, with $100 per textbook save. And this is an average. We have the higher textbooks, the lower textbooks. So you're looking at across the 8 textbooks of a $25.6 million savings. That is a significant amount and also only relative to our nursing students. We are not accounting for the ability for other majors such as psychology, counseling to also utilize some of the content because it is so easily adaptable and flexible. It can be leveraged across different academic disciplines, all the way from certificate to graduate degrees. And we've heard a lot of very innovative opportunities that faculty have gone in and seen specific content pieces. Maybe they can't absorb the entire, but they see those case scenarios that they want to absorb into their classes. So on affordability, it is making a major marker. But where I think we don't tend to spend as much emphasis and have a conversation is on the big gains that we have in both pedagogy and practice. And so one of the biggest things that we saw, of course, to iterate what Carrie has mentioned, is collaboration. And we saw that we see advancing innovative pedagogy as a community that involves several different perspectives across an ecosystem, from students who were also a very visible voice in this process, to our faculty, administrators, practitioners out in the field, to nursing boards, and so forth, innovating together, working on content together to meet the demands that are there today for our nursing students so that they can be competitive when they leave our institutions. In addition, we created a centralized hub, which is a digital presence where not only could you access the content, but you also can engage with other faculty to start amplifying the content that already exists. So what we're starting to see is collections of groups working on assessment strategies together, working on how do you deploy this, how do you adopt this as a team, as a department. And so we're really starting to see these amazing synergies that are starting to arise from engaging with this content. Faculty innovation has also been propelled. We all realize we are limited on the time that we have to dedicate for faculty preparation. We are seeing pockets of faculty come together and set these curriculum examples and places to begin, so you don't have to reinvent the wheel. As we know, several faculty members are also adjunct faculty that need to come in at a very swift pace and level set. This is a very important piece of the conversation because these materials allow us to share openly with each other and already have a set curriculum and courses that people can jump into at the fast pace that is needed. So again, because of its flexibility and its responsiveness, there's a relative component to it. With the ever-changing the speed of innovation and the way that we are just thinking about artificial intelligence and all of the impact that that will have, this allows us to respond quickly. It's agile enough for us to be able to contribute real-world examples as they are happening, as we are engaging, instead of having to wait for another production of a textbook or another series of something to come along. These resources are comprehensive across the entire curriculum, so it isn't about a stagnant piece of you read this textbook, you utilize this textbook, and never again will it be seen. It can actually produce continuity within the curriculum, and you can amplify examples to be relevant to the different subject matters that are being introduced. So in addition to all of this, we're really starting to see that faculty are taking the textbooks as a starting point, creating full courses together across institutions, across states, across different levels of programs. And it's really amazing to see this community that has risen up from the engagement of this work. So we're really starting to see some gains in innovation and starting to see some gains in cost savings because of faculty time that is being invested in this that can now be redistributed to other tasks that they need to apply to. Of course, we realize that nursing and the health-related fields are the leading innovation with all of the different facilities that they have. So we're really hoping to lean in and utilize the examples you already have in practice to upskill others that may be healthcare adjacent. And so we really need to make sure that that is something that we highlight as an impact. So let's talk a little bit about current adoptions. We just launched these textbooks, and as you saw, 6 of the 8 in June, end of June, early July. And so we've already had several institutions that are communicating, we don't just want to adopt 1, we want to adopt 8. We want to make sure that we can engage with this curriculum at all the different levels within the program, which is absolutely fantastic. We have approximately 150 formal adoptions, which represents approximately 3,000 students, but that's an unduplicated headcount, so some will have more than one textbook. And this is just the beginning. Some colleges that have been represented have really been advocates for this content include Alvin Community College, Grayson College, the UT Health Science Center in San Antonio, Stephen F. Austin, and the list will go on and on. We also are happy to report that some high schools have also adopted this and started to create their communities on how they implement these at that level. Highest reported adoptions are in nutrition for nurse and pharmacology for nurses and psychiatric mental health. And so again, we're starting to see these cross-discipline communities with counseling, psychology, and nursing, all having a conversation of how they can learn from each other and build these new assessments, these new scenarios, and so forth. So we're excited about seeing where this goes, and we're just getting started. And so Carrie's going to talk a little bit about some of the promotion and where we go from here.
All of the resources are available in multiple places. The Division of Digital Learning maintains OER Texas, which is the statewide OER repository, and we have created a collection there, our one hub, sticking with the acronym, and this hub allows users to access the 8 resources. They can also join groups that is associated with each of the titles that allows users to co-create materials, supplemental resources. They can share their stories of adoption or approaches that they've used. And we also have access to all of the session recordings from the 2-day One Summit that was held back in February. And so that is accessible from the OER Texas repository that also Michelle mentioned has access to other thousands of openly licensed resources. The resources are also available directly from OpenStax's website, where users can not only access the nursing resources, but more than 70 openly licensed textbooks across the curriculum. So the opportunity to have full degree programs with 0 textbook costs. But OpenStax also provides access to instructor materials as well as supplementary student and other high-tech resources to support the adoption of the textbooks. And we are committed to getting the word out about these resources. We have continued to present and communicate with various communities, not only in nursing, but also in the open education space. And together with OpenStax, we've talked directly to faculty and departments, but we've also gone to organization meetings and conferences, and we have a couple of conferences upcoming this fall, both the Open Texas and the Open Education Conference, where we will be talking more about these resources and sharing.
So at this time, if you have any questions, if not, this is definitely the one resource that you need. I know, my marketing department was really liking that one because they didn't realize I was going to say that. So there you go.
Thank you very much for that presentation. I was very glad to hear that high schools can use it as well. That was one of the things that we heard, that it was expensive for high schools to try and create curriculum or put those pieces out there. And so this exists as a tool in the toolbox, ready-made with excellent credentials. So thank you so much for that. Any questions from the panel? All right, thank you all so much, and all of the folks from the Higher Education Coordinating Board. Next up, we have the Board of Nursing, and that's Dr. Janice Hooper and Dr. Kristen Benton, the Executive Director. And just a reminder for all of our speakers, we still have a little ways to go on this agenda, so please do not read your presentation to us, but give us the important parts. Thanks, everyone.
Can you hear me okay? Thank you very much. Thank you for inviting us today. And I'm Jan Hooper from the Board of Nursing. And our Executive Director is here, and we're delighted to have her here. So I'm going to give kind of an overview, and then she's going to proceed, where we are now. As you know, the mission of the board is to protect the public, like most boards. And we do that in 2 ways, by regulating the practice of nursing and by approving nursing education programs. And the approval, I'm going to talk a little bit about our approval of nursing programs. We base that approval on our standards, which are our rules, Rule 214 and 215. So we do set those standards. We approve new program proposals, and then we have ongoing approval of existing programs. So, thank you. In our new program approval process, and we constantly have new programs coming to us wanting to have their program approved, they're developing them. The first thing we do when we get to know them is invite them to come to an information session. One of our consultants gives that information session about 3 times a year. We also require that they come to a board meeting or either watch it online so that they have a feeling of what the board meeting is like and what it's like when someone comes before the board for approval. The program will start writing their proposal based on guidelines that we provide them. And sometimes it takes up to 3 revisions to have a proposal ready to come before the board. Often there are quite a few suggestions back and forth and corrections that need to be made. But when we feel that it's ready to come to the board, we plan it for the next board meeting. We do tell them in the beginning to have this within 1 year, because if they don't, the things are not up to date after a year. So that's the way we approve new programs. Not all programs are approved. Some never make it to that presentation at the board, and a few are not approved by the board. It's the board's decision. The other area that we work on approval is the approval of programs in an ongoing fashion. We constantly review program data. I want to say thank you to Pam for her presentation. We've worked very closely with her. When I joined the board in the dark ages, we would send out a paper form for everyone to fill out, and that came back in through the snail mail, and we would read those, and then we had like an Excel sheet, we'd write all the data in a sharp pencil and send that over to the commission, and they would put it into an analysis form. But we started working on having an online form quite a few years ago, and it's been perfected over time so that I think we have a pretty brilliant one. The National Council of State Board of Nurses just started collecting national nursing data 4 years ago. It's not easy. Some states have never done this before, and it was voluntary, so not all of them participate. But we do have now 4 years of data, and think of the value of that to be able to look across the country and get this data together. But they were happy to see our form because that was a format that could be used. They developed their own, but we have a beautiful format. I want to say, too, that you've heard different agencies speak here about nursing, and we work very closely with all of those agencies. And I think about 2007, the legislation thought it'd be a good idea if we assured we weren't duplicating our approval processes across agencies. So we started at that time meeting with the coordinating board and with the Workforce Commission twice a year to go over what might be different in our rules, how we regulate, some programs that we both regulate, how they're doing, the status of their approval status. And that's been a wonderful experience. We added TEA 2 years ago because of the influence in trying to prepare high school students to getting into a profession. So we have frequent interactions, and we're very helpful. I feel very comfortable calling them, well, what about this? And they help a lot. So I wanted to show you the standards we use in our rules. They're not different from a lot of other boards, except our rules are specific and they're good for Texas. The first one is that we do have a section on program development, program expansion, closing a program, and then we have a section basically that is about the program of study itself. We usually think of that as being the didactic portion and the clinical portion, both very important. So the programs must have a philosophy and a mission. They have an explanation about their administration, their organization. We have rules about faculty and students. And we do have rules about the curriculum, what needs to be included. We do not prescribe courses, but we have content that we want to be included in all programs. Clinical learning experiences. You've heard a lot about the value of simulation today, and yes, it's very valuable. It cannot replace hands-on clinical. That's such an important part of the education. And we don't know where that optimum point is for the right number of hours. But when I'm talking to programs, I tell them for each major category, pediatric, maternal, med-surg, you should know about the number of hours that are going to produce a competent nurse in that area. It might not be the same in every area, but it's very important that they feel competent. We have found, and I'm jumping ahead of myself a bit, a few years ago I made a survey, last December in fact, it wasn't so long ago, asking programs, what in your program helps students to be ready to walk into practice? And I got some really good responses. But the number one thing was hands-on care with real patients. But not too far down was simulation. They're seeing the value of that practice, that getting ready to see the patient. And as we've heard this morning, it's the debriefing and the skill of the faculty that's so important. The second big thing was working with a diverse population. And this is why it's important for students to have clinical in more than one facility so they can care for diverse peoples. And the other big one that stood out was good relationships with clinical settings. And that's key to a lot of the success in the clinical practice in the area. So going back, giving Chris a challenge. The standards, the other ones that we address in our rules are the facilities, resources, and the services they must have appropriate, and then records, how they keep their records and reports. And then we added a new section last year, use of standardized examinations prepared by a private entity, because many programs are using the prepared exams, prepared modules, all of those things. And the legislation actually passed a law fairly early that they cannot use those exams for more than 10% of a grade in a course, nor as a graduation blockage. So that was happening quite a bit. So that's been interesting. As soon as the programs knew that was going on, they started calling us, asking us what to do. We approached ATI and asked them, would you list all your products you consider to be standardized exams? It was quite a number. So there have been some rearrangements of that. And then the clinical practice in nursing, I've said, is very important. You can't just learn nursing by reading a book or hearing a lecture. You have to work with patients. And this is where the real learning occurs. Patients are random. They're not like a simulation mannequin. They're not going to behave the same every time. But the clinical practice also involves the hand-on care that is preceded by those things, the skills lab, students in the lab learning a skill, simulation to practice what it's like in the setting, role-playing with each other. And then some programs are using standardized patients. They bring in someone to pretend they're a patient. And then computer labs, those are another ways. The importance of clinical also includes the contracts between the programs and the healthcare settings where they're going to be. And I know our rule defines hands-on practice as students working with actual patients in settings where they're receiving nursing care. So that's hands-on care. Okay, let's go down to types of pre-nursing programs. So here are some types of programs. It gets to be quite a list when you look at it. We have one hospital-based program now. That's the old model, diploma program. And there was nothing wrong with it. In some ways, we're looking back at that and we're establishing partnerships where the student is doing more in the facilities. Associate degree programs, we have somewhere in the high 50s of associate degree. The 2-year ADN. They also have a 1-year LVN to ADN. Some of them have a one-year paramedic or EMT to ADN. Those haven't really enrolled as much as they thought they would in the beginning. So those programs have the curriculum to prepare them to become a registered nurse. Then there's the bachelor's degree. You did hear a mention of RN to BSN and community colleges. Those started a few years ago when the legislation allowed some community college to give RN to BSN degree. And we've had a good number of them that come to before our board. The coordinating board, we worked with the coordinating board in setting up a process, but they did want us to review the program, the curriculum, and the clinical and the other aspects before they would finalize their approval to make sure they were in compliance with our rules. So we do that with them, and we actually bring it before the board and let them hear about it. So it's good. The bachelor's degree in a four-year university is also a type of pre-licensure nursing that's actually grown in our state. We have almost as many associate degree as bachelor's degree, and it used to be much heavier for associate degree. We have a new model we're seeing quite a bit now, an accelerated BSN, where a student may have another bachelor's degree and they want to enter a nursing program. And it's more fast-paced, and they often have many of the prerequisites. And then the other one that we have right now on our books is MSN entry program. This is where when a student enters the nursing program, they're planned to go toward a master's degree. And recently, when someone is interested in that, we strongly recommend that they not have the student ready to take the NCLEX until they finish that final degree, because then they will have a degree. If they don't have to get that and they're able to test earlier, they may not finish. So that encourages them to finish the degree. So those are some of the programs. There may be more coming up. And then the next thing is looking at the types of pre-nursing programs in a different way. There are the high school tracks. We have 6 LVN programs that have a high school track in there as a part of their VN program. So it becomes a track in their nursing program. And the students are usually enrolled in high school courses while they're also enrolled in the nursing program. So they have to make decisions if they're going to enter a program like this, because it's very time-consuming for them. And, maybe they won't be able to go to prom or be a cheerleader. So they have to make a choice. But the programs that are doing it have a different model. Each one of them is a little different. I did write up an explanation of those 6. If you would like that, I can provide that to you. And we stay in close contact with them. The other one is a dual enrollment, and that's what this is. It's usually they're enrolled in high school and they're enrolled in nursing. If a student is taking high school courses that will be a part of their prerequisite for nursing, that's a dual credit. Not as many seem to be following that, but though we may see that more in the future. So it's not an exhaustive list, as you can see. We may be hearing of others in the future, and we're perfectly open to that. I want to tell you a little story before I end. My annual physical stuff that you have to do. I was having a blood draw in a clinic, and I got there and was taken in by a young man. He was going to be the phlebotomist. And he was very nice, and he was very skilled, probably the best I've ever had. I had no marks and no bruise. But we were talking, and I told him I worked at the Board of Nursing. He said, I want to be a nurse. I've already gone to a school here in Austin and talked to them about it. And he said, I have to work out the funding, but I do have some military benefits. And this is one of the issues for people looking at nursing. They have to have a way they're going to support that. So I'm glad you're thinking about along that line. But he was very good. I encouraged him a lot. I said, I know that program. It's very good, and I encourage you to do that. So this is someone in like a stackable mode, because he already is used to working with patients. He had a great way about him in working with patients. He was proper in getting all the questions asked, and I was impressed. So I hope I keep running into people like that and encouraging them to be in nursing. So I'm going to turn you over to Dr. Kristen Benton. She is our executive director.
Thank you, Dr. Hooper. I'm here for tech and moral support, really. Thank you for having us here today. It's great to be here. Thank you for the hard work that you're doing and pulling all of this information from a cajillion sources together. It is a Herculean task, and we appreciate it. And just sitting here today, I've learned about programs I've never heard of, and I've been working with the board for coming on 11 years now. So there is a lot going on in Texas and a lot to be proud of. I have some presentation information that I'm going to breeze through because some of it is duplicative, because you heard from the State Treasurer, Pam Lauer, and the Workforce Center. And some of the questions we received were related to how we work with the Workforce Center. And so I'm not going to define what they do because you've already heard that. But the reports that they produce are extremely valuable. They cover the realm of nursing practice, employment, specific settings like school nursing, in addition to all of the education reports that are provided. They also use the education program data for nursing to put together a dashboard, a geographic dashboard. So anyone interested in going to nursing school can just go look at that map, zone in on the area that they want to attend, look at the various types of tracks that Dr. Hooper just described, and actually look at some quality outcome data too to inform their decision about where they want to go. So we are so blessed to have the Workforce Center. Not all states have such a robust and talented, small but mighty group of statisticians helping us figure out what's happening in our state. So specific to our agency, we really rely on them to assist us with administering the Nursing Education Program Information Survey, aka the NEPIS. And I know Pam talked about that, but I'll just refresh. It's an annual survey that all pre-licensure schools are required to complete. It's usually administered in October. And it asks all kinds of questions about faculty, enrollment, students, graduation, their curriculum, where they're going to clinical, how much time they're spending in each clinical setting. Do they have specialized tracks for high school, for veterans? It really helps us get an overview of what is available in the state. And when we get questions, we often consult with the Workforce Center to, drill down on some of the data. For example, last legislative session, we received questions about long-term care. We hear it's underutilized, how much so? And Pam, within an hour, was able to provide us that data that definitely demonstrated that, in particular, professional nursing, RN nursing programs are not using long-term care, despite recommendations over many, many years to expand out of the acute care settings and, get students clinical learning experiences in those settings. Another survey of sorts that we administer every 2 years is a compliance audit, and the Workforce Center assists us with that. And as Pam mentioned, there are a number of data that are always available based on request in aggregate form. So it's very helpful to graduate students and policymakers. Okay. Another question we were asked was to talk about our task force. We've had an education task force at the Board of Nursing since 2011, and it continues to receive charges from our board, so it's never really disbanded. But it's comprised of stakeholders in education practice and in regulation. And it really is there to create dialogue, to look at, what are the trends, what do we need to do to ensure that we're providing a quality workforce of nurses while the environment changes. So since 2011, there have been lots of projects that they've worked on. Here on this slide, you can see a few of the products that have come out of the workforce. We produced some guidelines to help expand the shortage of clinical faculty through use of preceptors, and provide guidance on nursing programs on how can you use a preceptor, what are the qualifications that a preceptor should have so that the student has a quality learning experience. We've produced a guideline on utilizing part-time clinical faculty who may not fully meet the education criteria to be a full-time faculty member, but still have education and experience that would provide a quality learning experience for a student. We also, this was back in 2014, I believe, maybe 2013, put out a guideline on optimal clinical learning. And some of the recommendations from that guideline included expanding settings beyond acute care for clinical education, particularly looking at long-term care. And then also, you know, rather than being sort of dug in on we do X number of hours here, X number of hours there, think about the quality of the experience. You know, we were learning that there may be a rotation where, you know, you have one faculty member and 8 or 9 students, and the faculty member is focusing on one student during a particular patient experience, and you know what's really happening with the other 8. Is this really a good setup? So really thinking about quality versus a finite number and quantity. More recently, the task force came together and planned statewide summits. There was one held in February of 2020, and then you know what happened the next month. So we worked really hard on recommendations, and honestly, after you know the pandemic came on, we felt like we needed to sort of have a redo because the world has so changed. And but it is interesting to see that some of the recommendations from 2020, such as establishing education practice partnerships, have really obviously accelerated since COVID. But our 2024 summit was recently held in April of this year. We are about to publish all of the recommendations, so I don't have those for you today, but can absolutely send those to you when it's published. I can tell you the themes that emerged. It was held in a World Cafe format. We had, over 100 people attend, and the themes that emerged from all of the conversations, each table had note takers, and so we have a lot of conversations to look through, and we had some great doctoral students who helped us with that, and they recently shared the themes with us, included collaboration and partnering, increased and expanded clinical learning. There were a lot of conversations that emphasized the value of simulation, but the definite need for real patient care. And I think that's a post-COVID comment, obviously, because so many students couldn't complete 100% of their clinical with patients. Another theme included planned and structured role transitions, meaning that when a student graduates, you know, what are the support pieces in place to transition that nurse to the role of a real world nurse. And then the fourth big theme that emerged was increased and effective use of technology, not just in the practice realm, but also in the education realm. So as I said, we'll be publishing that. We're hoping to bring it to our board meeting in October, and I'll definitely share that with you. The last piece that we were asked to look at was what are some practices that are being implemented by other states, by other boards of nursing? And so Dr. Hooper immediately sent out a survey through the National Council of State Boards of Nursing. So we did get a few responses, but this was like
Monday. So, so it's fresh, hot off the press. So I can describe on a high level what some of these are. If any of them really pique your interest, we can dig in and get much more detail from the respective board. And I won't read this to you. I'll just highlight a few. And to be proud, I'll say, you know, a lot of the projects that we did learn of, we were already doing in Texas. So I know we want new ideas, though. With regard to streamlining licensing, going digital, absolutely. Our board went paperless in 2020. Issuing temporary license, that is something that we also do. North Carolina is a very innovative state. They've really looked at making sure there are no restrictions or barriers to younger high school students transitioning into nursing. Let's see what else here. They've also engaged in collaborating with workforce groups, task forces. Georgia has had some funding programs to increase scholarships, to increase enrollments. Nevada recently implemented the ability for registered nurses to delegate to unlicensed people certain tasks to improve the quality of nursing care. And let's see. One thing that stuck out to me that I'd like to learn more about, and I'll share this with the task force, is West Virginia has a free support group for nurses, and it's in two different categories. One is for nurses with under 4 years of experience, and one is for more experienced nurses. And from what I could find, it looks like the intent is really to provide nurses a safe place to discuss the challenges, the joys of their roles as nurses in a post-COVID world. And then Nevada is looking at apprenticeships. One that I don't have here, but is definitely of interest, particularly to the third workshop that's coming up, is Washington State was provided funding to implement a grant program that allows any nurse who meets requirements to apply to be a clinical preceptor through the Board of Nursing. And it's an 80-hour commitment, and they're reimbursed, I think it's around $800 per gig. And this is one way to help facilitate clinical education for nursing students in their state. So I don't think there are any outcomes published yet, but it's definitely an interesting program. And that's all I have. Be glad to answer any questions.
Since you mentioned apprenticeships, I didn't say anything about that. Dr. Valerio at South Texas just got an approved DOL apprenticeship. We only have 4 because it's quite a lot of work, isn't it? And it's very restrictive. But many schools have adopted the partnership, and we have a guideline on that, by the way. Yes. And they establish a partnership arrangement where their students will work extra hours. And this will often mean they won't be looking for other jobs, but they'll actually do that kind of work. What we've heard from programs that have been doing this for a while is it's extremely successful. And those students feel like they're a part of the team, and the team accept them. They learn the setting, and many of them get a job in there right afterward. So we're just learning about this. They've been very selective. It's not every student that has the opportunity. But I think we'll see more of this in the future. I did write to the 3 accreditation organizations to make sure that wasn't something outside of their accreditation, and they were all fine with that.
Thank you. Any other questions of the panel? Okay, thank you very, very much. We appreciate you, and we are going to learn a little more about apprenticeship still. We got a couple of more folks coming.
Good.
First, our next up is the Texas Nurse Association. We're going to hear directly from the industry. So we're excited about that. Serena Bumpus is the CEO of the Texas Nurses Association, and she's going to give us the actual nursing industry perspective today. So thanks so much for being here, Serena.
Well, good afternoon, everyone. Again, my name is Serena Bumpus. This is my colleague, Jack Frazee. He's our Director of Government Affairs at the Texas Nurses Association, and we appreciate you all allowing us the opportunity to be here today. You have two handouts that are coming your way that will just reinforce what we're going to talk about today. One is related to staffing in Texas, and the other is related to nurses' perceived professional risk. You also should have received in your email, and I apologize, I got this to Sydney late last night, but is the Nurse Staffing Standards by Specialty organization. That might be helpful for you all to look at later as well. So you all have heard a lot today and just over the course of the last month, and you've heard testimony on the education side of the challenges that we're experiencing with nurses. And so today, I really want to focus on the practice challenges that nurses are experiencing, and particularly the ones that are causing them to really think about whether or not they want to stay in the profession. And there have been several studies over the last 2 years that are really looking at the drivers that are affecting a nurse's decision to stay in their current position. And those drivers include physical and psychological safety in the workplace, flexibility, the feeling of doing meaningful work, as well as balance. And when I talk about balance, that's not necessarily work-life balance, that's workload balance. And the two practice issues that really impact those drivers are staffing and professional risk. And so we're going to talk a little bit about staffing first, because that truly continues to be the top issue in our profession today, next to workplace violence. But staffing and the conversations around staffing are really causing a lot of unrest in the profession, and it's also starting to cause some distrust in the system, which we can't afford to have. So during the pandemic, nurses worked extraordinarily long hours, and our profession really started to report a great deal of burnout as a result. And so in Texas, we typically have a prohibition on mandatory overtime. Overtime is one aspect of staffing that we have to look at, and that prohibition was meant to protect nurses from being asked to work excessive hours. This isn't necessarily just for the nurse's benefit, it's also there to protect the patient, because we don't want a nurse who is overly tired caring for someone, because the risk of medical errors increases substantially. And so our prohibition on mandatory overtime contains an exception for public health emergencies. So one of the effects of the 3 years that we were in the COVID-19 public health emergency was that nurses had no limit on the number of hours that they could be asked to work. And so as a result, we had nurses reporting to us that they were working around 100 hours a week. And that was during the various spikes in the pandemic. Of course, this led to burnout and, for some, leaving the profession. We typically avoid these excessive work assignments through staffing plans and policies that are required by statute in the Texas Health and Safety Code, Chapter 257. This statute was adopted in 2009. It's been in place since then. It has not been looked at since 2009. There have been no attempts to revise that statute since 2009. I do want to, for those maybe who are not familiar with that statute, this is not a ratio bill. This bill actually requires hospitals to assemble a staffing committee to create a staffing plan and policies for their hospital. And the backstop to that statute is the prohibition on mandatory overtime, which immediately follows in the Texas Health and Safety Code, Chapter 258. When this statute was passed in 2009, it was not only supported by the TNA, but it was also supported by the Hospital Association, Texas Organization of Rural Health and Community Hospitals, as well as other 24 hospitals and health systems. So this was a strongly backed statute that it's time that we go and look at it and see what kind of reinforcements we can do. So over the course of the pandemic, the regular order for staffing and overtime really completely fell apart. The entire state operated in crisis staffing mode, as they should have been during that time. That is not a negative, I'm not negatively talking about our facilities. We were all doing what we could at that time. Ever since the public health emergency ended, though, we have heard frequent complaints that staffing has never gotten back to where it was before. And as a result, that is what continues to be one of the top dissatisfiers in the profession. The shortage obviously presents a challenge for staffing. If we don't have enough nurses, it's hard to staff appropriately. And we can resolve this challenge, though, if we are adequately planning and focusing on our hospital's policies and procedures. National specialty groups have made recommendations for how to staff various specialties that are backed by an enormous amount of research. Again, that was what was provided to you in the document that was emailed, and it has every position statement from most of the major specialty organizations, all of whom, I would say 90%, have revised their staffing positions since the COVID pandemic. What is important to note is that the majority of them identify the fact that you have to look at your unique needs in your facility, the acuity of your patients, the skill mix of your nurses, because, man, I remind you that before the pandemic, the average years of experience of a nurse was 6. Today, it's 2.8. So we have a challenge with experience as well. So every staffing committee should actually start looking at those recommendations. They should draft their policies with an eye towards the unique needs of their patient population. And we are hearing from nurses that that is simply not happening. What does happen is, here's your budget, make your grid, instead of the plan informing the budget. And so when this is done well, I can just speak to, I was a very young staff nurse when this statute was first implemented, and it was rolled into the shared governance structure that we had in our hospital. And we had our representatives who would attend the staffing committee. They would talk about staffing, bring recommendations from the staff to that committee, and then they would actually report back in staff meetings what the decisions were, what was happening. That isn't consistently happening everywhere across the state. What we do here is that the unique needs in the skill mix are not being considered. It is not being looked at in real time either. There is a heavy emphasis on productivity, and so it doesn't necessarily matter what's going on sometimes in the units. It's just staff to your grid, staff to your grid. Why are you one nurse over? Staff to your grid. And we have to look at that in a more holistic way, because the grid is not always a good depiction of what's happening in our departments. And there is also, there's an opportunity for education as well, is what we're hearing too. So the statute does contain several mechanisms for enforcement, but as we have investigated the breakdown of the system, we've learned that those enforcement mechanisms have some pretty glaring flaws. So first, hospitals are required under the law to report their compliance with the various aspects of the law to DSHS. This data is publicly available upon request, and when we requested that data, it showed that 5% of hospitals reported that they were not complying with the statute. So we thought that this would lead to enforcement actions. So to confirm that theory, we requested the enforcement records from HHSC. And in cross-checking that data against those enforcement records, we found that there was no relationship between the data that was reported and the enforcement actions that were taken. We've also since learned that HHSC uses an entirely different process in compliant-based enforcement systems. So they're not going to investigate a hospital for non-compliance unless someone files a complaint. And so that then puts the burden back on the individual nurse to file that separate complaint against their employer to have that particular situation addressed, even if the state has already received data showing that the hospital is not in compliance. So this is a fundamental flaw of that statute. And if a hospital reports noncompliance, it really should immediately be referred to enforcement for a corrective action plan. So and it should trigger an investigation as well. Secondly, the statute currently requires hospitals to include in their policy some undefined anti-retaliation statement for nurses who report staffing concerns to the committee. This is bound to produce varying protections depending on the facility, because each facility will draft different anti-retaliation policies. And so the statute should explicitly protect nurses from retaliation when communicating staffing concerns. And that protection should include a remedy for when it's violated as well. One of the things that we repeatedly get calls about is nurses who have expressed concerns around staffing. They have invoked safe harbor, which is a process that nurses could use if they feel like they're being asked to do something that violates their duty to a patient. And it's unfortunate to hear that nurses are being told to go home after that happens, or that they feel like they're being targeted after the fact. So we aren't, there is not a mechanism there for that anti-retaliation piece. Third, the enforcement framework needs to be tightened up. The enforcement records we were able to request from the state show that in many instances, the total penalty for a violation was $500. The highest penalty assessed was $18,450. And that's far below the cost of hiring another nurse. The average cost to replace a nurse is anywhere between $40,000 and $50,000. And so if it's cheaper to pay the penalty than to meaningfully staff the facility, the incentives of the law aren't really aligned. And so there's a lot of other legal minutia that's required to address this part of the statute, but the general point is that the system is not adequately pricing the cost of the violation. And understaffed facilities, as we know, have worse patient outcomes. They have worse satisfaction amongst their workforce. And if we fail to adequately address the staffing challenges that we do have, we will continue to lose nurses from our organizations and from the profession as a whole. I also want to talk a little bit about professional risk that the nurses face. So because of the staffing challenges, nurses are typically spread pretty thin. They're managing a patient population that is sicker than we've ever seen before. The patient who is in a med-surg unit today was in the ICU when I started 22 years ago. So there is a vast difference in just the acuity of the patients that we're caring for. On top of that, we're asking nurses to train the new graduates that we've just hired, which health systems are hiring upwards of 200 to 400 new grads a year. There's a retention issue there. And they also are precepting students. And on top of that, they are having to navigate the ever-growing number of regulations and other burdens that we place on nurses. So that strain puts them in an increased likelihood of committing medication errors or other practice violations. And as we know, medication errors have remained a major public health concern since 2016 when the alarm was sounded, and we have yet to reduce that rate of incidence. Recently, there have been a handful of cases where a nurse committed a practice violation, and instead of addressing that violation through their professional licensing board, the nurse was penalized through the criminal justice system. The most notorious case that occurred was in 2017 in Tennessee, which involved a nurse by the name of Redonda Vaught. In short, Ms. Vaught administered an incorrect medication that led to the death of a patient. It was a very tragic mistake. She owned every aspect of her mistake. She immediately reported that mistake. And originally, when her licensing board looked into it, they decided that they would not take any action due to the extreme number of systemic issues that were found in the health system that Ms. Vaught worked in at the time. Eventually, however, that unfortunately, I should say, that case made it to a prosecutor who criminally prosecuted Ms. Vaught for her medication error, and she was ultimately convicted of gross neglect of an impaired adult and negligent homicide. And she lost her nursing license as a result. This particular conviction really just shocked the entire nursing community. And suddenly nurses began to wonder if their excessive workload would cause them to make an error and be criminally prosecuted as well. This is not a productive way to support healthcare in general. We want nurses to report medical errors, and the looming thought of making an error and the chance of being criminally prosecuted consistently hangs over a nurse's head. And so we know there are a great deal of systemic issues in our healthcare organizations that aren't being resolved. We have the Band-Aid approach a lot in healthcare, and we slap a Band-Aid over the issue instead of trying to solve for the problem itself. And so we have to discover these issues, and we have to address them in order to continue to move healthcare forward. So if nurses are afraid to report because they think they'll be criminally prosecuted for those practice violations, they will stop reporting. And our quality will deteriorate. And in Texas, we can't afford that to happen any more than it already is. Kentucky recently passed a law to address that situation, and we think Texas should follow their lead. Kentucky lawmakers heard about the RaDonda Vaught case and decided to codify the understanding that has long existed in healthcare, which is that practice violations are addressed through licensing board and civil court, while intentional harms are addressed through criminal processes. Texas has long operated under that same legal assumption, but it needs to be made explicit in statute so nurses know that they will not be criminally prosecuted when they make a mistake in their practice. If we do codify this system, it will help surface those systems issues. It'll provide reassurance to a workforce that badly needs it. And it'll promote a safer healthcare system and chart out a more orderly and legal system for future cases. Nursing is the backbone of our healthcare organizations. There is no healthcare without nurses. And so if we're not retaining them, if we're not addressing those retention issues, which these are two big issues that could help solve for that, we're going to be in even more trouble in the future. So I appreciate you all. Again, I appreciate your time, and I'm happy to answer any questions.
First, thank you.
Thank you.
I was a nurse manager in 2009, and I implemented this at my hospital, and I'm a big proponent of this Senate Bill 476. But what I wanted to ask you about the compliance, because every year I get the survey, and I have to say, are you doing all of these things? And I sent it in. I'm a rule follower. What I wanted to ask you is, you said 5% are not complying. Is that correct?
That's correct, yes, ma'am.
But is that 5% of a true denominator, or is that 5% of who submitted? Because I know you're required to submit, because I'm a rule follower, but that doesn't mean that there's no penalty for not submitting, as far as I know. So is that 5% of, if you check the boxes of all the hospitals that should be, because it may be greater from a non-compliant perspective, we just don't know.
That's a great question. And Jack, I'm going to lean on you to answer that since you did all the legwork.
I can tell you the way it presents in the data set is that you're just given a data set with, have you complied with this section of the law or not? It's a yes or no answer. And out of that, about 5% of all that report just say no on various fields of data.
And Dr. Ward, I would add that in having conversations with nurses and CNOs, some of them are actually trying to track down who in their facility fills that out because they've never seen the document before.
That's true. In mine, they all know to send it to me, but it is true. Like, is it HR? Is it corporate? Is it whomever? So I think that's another great point.
Yes.
Because they may just not fill it out because they don't know if they can.
Right.
If they're authorized to. So great work.
So ultimately, we have absolutely no idea if anyone's complying. I mean,
It is a pretty opaque system, yeah.
Yeah.
okay, great. Any other questions from the panel? Thank you very much for being here and for all of your help with this. Y'all have been actually really helpful, and I appreciate that. I look forward to keeping in touch with you and working with you throughout the rest of this process.
Thank you.
Appreciate you all.
Yes.
Okay, we're going to move on now and talk a little bit about what we've heard a couple of times about today, and that is stackable credentials. So we've got a panel with a variety of different folks. I'm going to call. Okay, I'm going to call Dr. Peter Riley Barr, Associate Professor with the University of Michigan, and his co-presenter, Jennifer May, just Jennifer. And they're a virtual presentation, so we're going to let them go first.
Thank you so much. Are we coming through okay? We clear enough? Slides visible and so on?
Yes.
Thank you so much for having us. My name is, as mentioned, my name is Peter Barr. I'm an associate professor in the Center for the Study of Higher and Post-Secondary Education at the University of Michigan. My colleague here, Dr. Jennifer Maitre-Folletti, is a member of my research team. We were asked to, the coordinating board asked us to come in and talk a bit about our research and more broadly, like what research can tell us about stackable credential pathways, a space in which we've been doing quite a bit of work in the last 4 or 5 years. And so we'll launch right into that. But let me give you a brief outline of what we'll be discussing. We're going to move along as expeditiously as possible. Let me just briefly introduce my team since we are coming in from outside of Texas. I don't know if there's other folks presenting today that are outside Texas. I'll explain a little bit about what my team focuses on, and then I'll turn to Jen, who will talk about what research can tell us about stackable credential pathways with particular attention to health fields. When I talk about, I'm going to mention, and Jen will as well, the we and the our of our team. We have quite a large team for a set of academics here at the University of Michigan, a number of folks who work with us on us. We want to make sure to acknowledge all of the important work that each one of them does. Writ large, my team and I are focused on answering the question, how can we create, grow, and sustain educational and economic opportunity for those who are facing the greatest obstacles? And the health fields happen to be a field that tends to draw individuals who are looking for stable employment and a family-sustaining wage, many times coming from low-income backgrounds. And indeed, we have 3 main student groups that we look at in our work: adult-age students or older learners, socioeconomically disadvantaged students, and more recently, justice-impacted individuals. We tend to focus on community and technical colleges because these are the institutions that serve a majority or serve a disproportionate share of the students who are facing the greatest obstacles. And in that space, we focus on a combination of transfer pathways to baccalaureate degrees in STEM, which you can see here. But a larger piece of our work is looking at career and technical education pathways, which would include nursing, medical assisting, and a number of fields that would be relevant for the conversation here today. And our focus of late has been in trying to understand how we can better prepare students to complete high-quality, high-value credentials, how we can meet employer needs and industry requirements, and how this interface is or is not serving students, individuals, and employers in the best possible way. Because our aim, of course, is that we would maximize students' labor market outcomes and maximize the economic growth in the states that we're working with. When we're talking about CTE pathways, just briefly, we're thinking about at least 4 topics here. One of them is non-credit occupational education. Another one is upskilling and reskilling, individuals coming back to college to strengthen their labor market position through short sequences of courses. We're thinking about stackable credential sequences that we'll talk about today. And then we're also thinking about post-secondary education in prison, which often includes a significant CTE or career and technical education component. If you'd like to know a little bit more about our work, you can go over to edpolicyresearch.org. All of our work is presented there. And actually, I breezed through it rather quickly, but if you want to grab a shot of our slides here, we've got them up for you. You have a phone handy. Everyone is so small on our screen that we'll never know if you're actually doing it or not. But if you grab a snapshot of that, you'll have access to our slides. Jen?
All right. Is my screen visible?
Yep.
All right. Turning to what we know from the research about stackable credentials, I always like to lead with the takeaways, especially because we're trying to keep this brief. And as Dr. Barr said, you have access to the slides if I gloss over anything that you're more interested in. But what we're hoping you'll get out of this presentation is that definitions and understandings of credential stacking vary, and that affects how we think about stackable credentials pathways. We've found that credential stackers don't always follow anticipated or planned out pathways from their first credential to their stacked credential. There's great variation in actual student behavior. Although many stackable credentials, pathways, models, ideas want to include steps from non-credit courses and non-credit credentials to credit-based courses and credit-based credentials, we do not see a lot of movement between the two sectors. That continues to be a bit of a barrier for students. When we think about the labor market outcomes of stackable credentials, the evidence generally suggests that stacking a higher level credential on a lower level credential is associated with increased employment rates and earnings, both in health and in other fields, while other types of stacking are not necessarily associated with improvements in students' labor market outcomes compared to not stacking. So what are stackable credentials? This is one of the more common definitions you'll see of stackable credentials, and I think the big takeaway from this is the alignment between what students are doing in college, the credentials that they're accumulating, and what they're doing in the workplace, in the workforce. And the two should work together to help students move along a career ladder or a pathway to more advanced, higher paying jobs, and certainly that family sustaining wage that Dr. Barr mentioned. Stackable credential sequences can include all sorts of credentials from baccalaureate degrees to credit-bearing certificates, associate degrees, non-credit certificates, and even credentials like licenses and certifications issued by third-party states, licensing boards, associations. We generally see two types of stacking. The first is called vertical or progressive stacking. And that's when students earn credentials of requiring increasing numbers of credits or increasing amounts of time in school to more advanced credentials. So as an example, a student might start with an EMT certificate and then move up to an advanced EMT certificate that requires a few additional credits and build on that toward a paramedic, an associate degree in paramedic, and ultimately licensure to work as a paramedic. The other type of stacking that we see is horizontal stacking, which is also called lateral or independent stacking. And that's when students earn two credentials that are essentially of the same length. So two certificates, in this case, in a related field that represent sort of the same amount of time in school. Stacked credentials can be in the same field as their first credential, a related field, or a different field. Going back to our EMT example, as a hypothetical, if a student is earning their first certificate to be an EMT, that advanced EMT certificate would be the same field. Any other health field like nursing or phlebotomy would be a related field. And then a different field could be childcare, IT, anything that's outside the health field. And we do see, we'll show some numbers later, but we do see a good amount of stacking where students are changing fields drastically when they do stack. Stacking can occur at the same institution and sector as the first credential, or students can move to a different institution and sometimes even a different sector. Although we see here in this large green block that in this particular study, which used data from Ohio, most students who started at a community college also stacked at a community college. So a few things to keep in mind as we're going through the rest of the presentation. We're really most often talking about individuals who earn multiple credentials, whether or not they completed a program designated as stackable or designed to be stackable. It's been very difficult for researchers to identify those programs that are designed or intended to be stackable in the data. So most of what we know is based on students who earn multiple credentials, regardless of whether it was a designed program. So we'll use the term credential stacking to distinguish individuals who earn multiple credentials from those who we know did so as part of a program designed to be stackable. A little bit on stackable credentials in health. Much of the research on stackable credentials has, in fact, focused very much on health. As you all know, health professions are especially well suited to stackable credential pathways in many ways. Most students enter a stackable credentials pathways through earning a certificate. That's usually the first step in many sequences. And nationally, a large number of certificates awarded by community colleges are in health professions. Continued growth in the healthcare industry, entry-level jobs requiring certificates, but then opportunities to advance, typically with higher level credentials, and the well-defined ladder-like structure of fields like nursing can really make stackable credentials a workable model for education in health. And some consider one of the earliest models of stackable credentials to be the RN to BSN. Our work focuses primarily on sub-baccalaureate credentials and stacking, but the RN to BSN is another great example that goes up to the bachelor's degree level. How common is credential stacking? Again, common theme throughout this presentation is that there's great variation in what we know about stacking based on things like context, definitions of stacking, how long we allow students to stack before we consider something a stack. But in our research, we found that around 41 to 44% of certificate earners stack credentials, and this was consistent with a national estimate of about 40%. Looking specifically in health fields, our research found that between 22% and 33% of certificate earners who earned that first certificate in a health field stacked credentials within that 4-year time frame. One of the major motivations for stackable credentials is that they could be a promising pathway for students who have historically struggled to complete credentials, particularly to complete associate degrees. Historically underserved students like adult learners who have responsibilities outside of college that can sometimes lead to detours to their ultimate educational goals. So stacking is seen as a way to allow students to exit and re-enter and maybe help them eventually earn a credential. The evidence on whether stacking supports students from historically underserved backgrounds is a little bit mixed, but overall it is somewhat promising. We do see more students from low-income backgrounds stacking, and in at least some research, but we also see adult learners stacking at lower rates. So there is some promise, but it is something to keep in mind in thinking about stackable credentials programming. The vision of stackable credentials, what is commonly thought of when we think about stackable credentials, looks something like this, with the blue squares representing what's happening in education and the yellow representing what's happening with students in the workforce, in the labor market. And in an ideal world, they'll enroll in community college, earn either credit or non-credit certificate, use that to secure entry-level employment, and then build on that to advance within their industry of employment, build on that to a certificate or degree and advance within their industry of employment. Of course, as anyone who's worked with students knows, actual student behavior can vary. We see large proportions of students who are stacking by earning multiple certificates or a certificate and a degree at the same time. About 1/3 of stackers in our work did so. We also, as I mentioned, found that taking credit courses after taking non-credit courses is rare. So even though many stackable pathways would like to see this type of movement, it's not particularly common. In a study we did that used Iowa and California data, only about 7% of Iowa students who started in non-credit courses later took credit courses, and about 23% of students in California. We actually did break that down by field and found that, again, 7% of Iowa students who took non-credit courses in health later took credit courses, and that number was 18% in California. So not much movement between the non-credit and credit spaces. Another question that comes up with stackable credentials is whether students who do stack are able to apply their credits from their earlier lower level credential to their higher level credential, particularly to an associate degree, or whether they end up taking extra courses, potentially extra time, costing them extra money. Overall, this is one study, one estimate from one state, Ohio, so take it lightly, but the research that is out there shows that students who stack to an associate degree did indeed take more credits than those who went directly to the associate degree. And we saw the same pattern in health. So that's something to be mindful of in thinking about whether it's designing stackable credentials programs, evaluating stackable credentials programs, or communicating to students how different courses and programs are related. And again, including some of this work has focused exclusively on credential stacking in health. And those who earned the non-credit certificates in health, very few went on to a credit-based credential, even though in an ideal world, many stackable pathways would allow for that. The other thing we see is that changing fields is relatively common. So earning a first certificate in one field and then a second credential in a completely unrelated field is relatively common. Among the health stackers in the health field who earn their first certificate in the health field, we do see that about 1/4 of them stack their credential in a completely different field, although that does include students who earned a certificate in health and then an associate degree in a liberal arts type field. So could be signaling a change of career or industry instead of advancement within an industry, or could signal some sort of diversification of skills, as in the case of earning both a credential in health and a credential in a liberal arts field. Turning to the question of value in the labor market, the short answer is yes, that credential stacking is associated with increased employment rates and earnings. But of course, the longer answer is that there is substantial variation by the level of credential and the field of study. And we'll just drill down into the findings related to health. Compared to other fields, stacking in health tends to yield higher returns, and in some cases, the highest returns of any field. However, drilling down into this further, it's really driven by those health students who earn that first certificate and then stack to an associate degree, with returns to certificate stacking being much lower. And then within the broader health field, the returns are also driven very much by stacking within nursing. So that associate degree in nursing as the what's really driving what we're seeing in terms of higher returns to the health fields in stacking relative to other fields. So I said at the beginning, we're focused mostly on students who earn multiple credentials. credential stacking. And that's what most of the research has focused on. But there are a few studies that have looked at programs that are designed or intended to be stackable. And they've generally found that when a program offers clear signals to students that two credentials are related, or that a common set of courses or a set of Launchpad courses are related to multiple different options and pathways, it does increase rates of re-enrollment in those programs, continuation on to the second credential, and completion of that second credential. So there is promise for those programs that are designed to be stackable, if they're communicating clearly to students and showing that hierarchy and that relationship, that students are getting that and benefiting in terms of earning additional credentials from those types of designs. What don't we know about stackable credentials? Again, the literature on adult learners and other students from historically underserved backgrounds who are a huge population of interest for stackable credentials programming. The jury is still out there. Research is promising, but it is mixed. Also, not yet fully answered is the question of whether credential stackers are able to apply credits earned from their first credential to their second credential, and the extent to which this might vary by field or by the specific pathway a student is following to stack credentials. We'd also really, data continues to be a challenge. Acquiring data continues to be a challenge to really understand whether programs that are designed to be stackable are achieving their intended goals. And if so, what program features are driving this so that they can be replicated and generalized. And finally, we still don't have a good handle on why non-credit to credit transitionings are not happening, and whether that's because students are getting what they need for their chosen career out of that non-credit program and calling it a day, or whether there are structural barriers where students don't know that they can move from non-credit to credit, they don't know what opportunities are available to them, or some other structural barriers that are inhibiting students who do want to make that transition. Returning to our key takeaways, I know I went through this material very quickly, and we're happy to share our slides, happy to take questions. Just wanted to keep this moving along. But what we hope you take away is that credential stackers are not necessarily following anticipated or planned paths, that transitioning from non-credit to credit is particularly troublesome. But when students are able to stack credentials, certain types of stacking have led to positive labor market outcomes. And I'll turn it back over to Dr. Barr.
Thank you so much, Jen. That was just outstanding as always. So we'd be glad to field any questions. Do you mind going forward one more slide, Jen? We'd be glad to field any questions that may arise here.
Any questions from the panel? Thank you both very, very much for a very informative presentation. We very much appreciate it.
Thank you. We're grateful for the time.
All right, we've got going to come back down to Texas. We've got Ray Martinez from the Texas Association of Community Colleges, who's going to put into context for us how the community college reforms from the last legislative session work in this space and help the community colleges facilitate stackable credentials. And then we have Austin Community College, Dr. Nina Almsay and Dr. Gay Lynn Scott, who are going to talk to us about their program. And then we'll hear from Eric Bean with the College of Healthcare Professions, which is a private college also sort of working in this space with allied healthcare professionals in particular.
Good afternoon, Chair Ford and members of the task force. My name is Ray Martinez. I serve as President and CEO of the Texas Association of Community Colleges. I'm also a former legislative staffer, so it's a little odd to sit at this end of this room. I'm usually in the small chairs behind the big leather chairs. So thank you for the invitation to be here this morning. So if I'm going to the focus of my PowerPoint will be on House Bill 8, and I'll mention a few things about stackable credentials towards the end of my presentation, but we have others that you'll hear from our institutions, and of course, Dean Valerio and others are very familiar and much more conversant on stackable credentials from an institution perspective. But I think the important thing to stress through the presentation that I'll give to you is how HB8 has created a tremendous amount of increased momentum across our 50 community colleges towards even greater innovation and ways to improve student success in many different ways, including the idea of micro-credentials, reskilling, upskilling, and stackable credentials. So that's the general message, but I also want to get you familiar with the transformative change that House Bill 8 makes to the funding model for our 50 community colleges. So that's the focus of what I'll try to lay that groundwork, say a couple of things about stackable credentials, then you'll hear from the actual experts who can add some context to that. So in 2023, 50 community colleges across Texas awarded nearly 130,000 degrees and certificates to students from all walks of life, including traditional age students, adult learners, and through a growing array of dual credit courses to young Texans across the state that are still in high school. We're proud of the excellence that abounds across our community college campuses, and we're especially proud to serve the 670,000 students or so that are enrolled or were enrolled in the last academic year across 50 community colleges. And by the way, that's a 3.5% increase in enrollment for our sector from 2022. So 670,000 students approximately. Those are credit-bearing students. That does not include non-credit-bearing students that are also enrolled at our campuses. And I'll tell you why that's going to be an important footnote to this conversation as we get through the presentation. So we're proud to serve this vast number of community college students across the state of Texas. We're proud to be open enrollment institutions. And we expect, and we have the sense that our enrollment numbers are going to continue to project upwards. We're seeing that trend for public junior colleges, community colleges across the country, and we think Texas will be no exception as we move into this new academic year, especially in light of the changes that have occurred over the past 12 months or so because of House Bill 8. So let me also say that the work of this task force we think is critical. Your focus on removing barriers to expand healthcare programs across the state is very much in line with what we will continue to work on and what we want to partner with each of you on. And so we thank you for the representation on the task force. We know that you have different work groups also supporting your work and ample community college representation on the work groups themselves. So we thank you for that. Now, in the 2023 legislative session, the Texas legislature invested an additional $680 million into the state's community colleges. HB 8 established a new set of funding formulas, changing how Texas allocates state revenue to our community colleges. Now, with this change in formula, which was passed, by the way, unanimously on final vote by both the House and the Senate here in the Texas legislature, community colleges are now positioned to equip large numbers of Texans with the specialized skills needed for the emerging and high-demand jobs and to support continued growth of the Texas economy. And so that's where I want to start today. I'll start scrolling through this presentation here, and I'll do it rather quickly to try to give you all some time back, but also, again, to focus on HB 8 and its impact across our community colleges. So this slide here, what I would start with is the why. Often when I give a presentation like this, folks want to ask or want to know, why was now the time for the legislature to make such a transformative change to how we fund our community colleges? And I think there are many different ways that we can answer that specific question, but one of the ways that I like to answer it is I think perhaps one of the most compelling reasons, and that is our population change for the state of Texas over the past 10 to 15 years. And these next few slides will illustrate that population change. So why is that going to matter? Well, that population change comes at a time when the state of Texas has perhaps the most vibrant and strong economy of all 50 states in the country. And if you think about the fact that you have all these folks coming into the state, as they have been, we are the fastest growing state in the country for a number of years now. And if you combine that with wanting to maintain the vibrancy and the momentum of our state's economy, what you want to do is ensure that there's not a misalignment of the skills and the training that occur for Texans and new Texans that are moving in so rapidly, and the workforce demands of employers and industry across the state, whether statewide employers or particularly even more important to our community colleges, local and regional employers. So that's the large why. This slide shows you just some of the data that in 2022, Texas gained more residents than any other state in the nation, and we broke the 30 million resident mark. So we now are over 30 million residents here in Texas that call Texas home, second only now to California, that's 38.6 or so, and falling fast because we all know that they're moving to Texas from California. So, so the rapid population growth is certainly something that's important for us to consider. This next slide, again, just sort of drives home the point that we've had population growth. The line at the top is the trend upwards for the Texas population. The line at the bottom is the trend downward for the United States population. And as this slide indicates, from 2000 to 2022, the population of 11 of Texas' 254 counties more than doubled. And that has certainly implications for educational outcomes and also for resource allocation. So all of that is an important thing that we should be mindful of. This next slide shows just a visual representation. This is actually the data that came after the 2020 census. Everywhere on this slide that you see a shade of green, light green or dark green, means it's a county that lost population. And this was again, this is the data that came to us after the last decennial census, which was given to the state in the summer leading up to the 2021 legislative session. Summer of 2020 is when we got this data. So some of this has shifted around. We've had more population growth over the past few years. So some of these shades of green or light green might be in a slightly different color. But this is pretty striking to see this is where the population of Texas is at. And after the last census, we see that a large number of counties across the state of Texas actually lost population. The urban areas are gaining an incredible amounts of population, and they're doing it kind of quickly. Now, you know, a future iteration of this slide will actually put our community college service areas on this map so that you could see where our community colleges are located. And I didn't have time to do it for this slide, but if I could do that, what you'd find is that community colleges, their service areas cover 250 of our 254 counties. We are everywhere. So even if a portion of the state, parts of this map that are shades in light green or dark green, there's a community college nearby, maybe right dab in the middle of that area. And that community college represents vibrancy. It represents, you know, what it is. It's an economic hub for that particular area. And so we care about population growth and loss, and we care whether it is loss because we want to ensure that that community college continues to exist and provide educational opportunities for that part of the state, or in an urban area where there may be such an immense amount of new population that we need to provide resources, whether financial or people resources, to colleges in urban areas to ensure that they can meet the demands that exist in that particular area. So then moving forward to this next slide, this is just from the governor's website that shows, again, just to drive home the point that we have a growing state economy. In fact, in the 2 years that I've served as President CEO of TAC, the Association of Community Colleges, we've gone from the 9th largest economy in the world to now, as this slide illustrates, to the 8th largest economy in the world. Texas, our economy is strong and it is growing. And collectively, we want public policy and funding policy to support that continued growth as we move forward. And we can only do so if we have a skilled and trained workforce. So why does all this matter then coming to community colleges? This is a picture of a report that is still on the website of the Federal Reserve Bank of Dallas. So the Dallas Fed commissioned a report in the fall of 2022. The report was issued and made public by the Dallas Fed in January of 2023, right at the start of the last legislative session. It's called All Eyes on Texas. It's still on their website. And I won't go into a lot of detail about this. It is a comprehensive report, and it is focused on our community, on the contributions of our community colleges to the economic vibrancy of our state and the important role that community colleges play in our state, in all sectors of our lives here in Texas, but certainly from an economic and educational perspective. One of the takeaways then from this report is that the Dallas Fed expects that between now and 2030, there will be at least 4 million new jobs created in the state of Texas. And while many of those jobs will require a post-secondary education, at least to a bachelor's degree, many, if not most of those jobs will actually require post-secondary education that they term in this report middle-tier skills jobs. And by that, they mean jobs that require more than a high school diploma, but not necessarily all the way up to a bachelor's degree. They call out industries like manufacturing, information technology, transportation, construction, and of course, healthcare as the industries that are going to see the majority of this job growth over the next 5 to 10 years here in the state of Texas. Why does that matter for community colleges? We are that sweet spot. Over 90% of career and technical education training in the state of Texas emanates from a community college across the state. Over 90% of dual credit education in the state of Texas emanates from a community college across the state. So if we're looking at ensuring that we are going to align educational outcomes with workforce, with employer and industry needs across the state, we have all sectors of higher education that ought to be activated toward that, and they are. We have outstanding higher education system in the state of Texas. But there's no question that our public junior colleges, our 50 community colleges, fit squarely in that space. And that's one way that the state of Texas can pull a lever and put some funding and make some policy changes and really affect an outcome. And I think that is, so to go back to where I started a few slides ago, the why. Why was now the time to make such a transformative change to our funding formula for community colleges? That, I think that's a pretty compelling reason. If you think about the population growth, if you think about the desire to keep our state's economy strong, and you think about where can we put funding and policy priority into some part of our state economy that would have the most impact, it is our 50 community colleges. And I think that's an important point for everybody to think about with regard to House Bill 8. All right, now let me just spend a few slides talking about what exactly House Bill 8 does. Most of the press around House Bill 8 since its passage last year, so it was passed by the legislature, signed into law by Governor Abbott on June the 9th of 2023, and became effective September 1 of 2023. So we're not a full year yet into implementation of House Bill 8. We've had a lot of activity in this last 11 months or so. I can't, sit in front of a microphone without thanking our colleagues and friends at the Coordinating Board for the very strong partnership that we have with that agency and with the Texas Workforce Commission and TEA. But in particular with the Coordinating Board, there's been a lot of emergency rulemaking to get this bill up and running and to get House Bill 8 fully implemented. So September 1 will be the first year anniversary of implementation, but most of the press that you see around House Bill 8 is, oh, Texas changed its funding formula. And they went from one that's based upon contact hours that had been in place for decades to one that is based almost entirely on performance and outcomes. And that is true. Texas Tribune stories run stories about HB 8, and that's usually the focus of the media, that change occurred. And all of that is true. But so much more happened because of House Bill 8, and we don't have time to go into all of the changes. I will give you a slide that gives you a preview, if you will, of some of the additional changes, but certainly the headline-grabbing change, and the one that many other states across the country are most interested in. How did you all do it? What exactly does your formula do? I get those calls often. It is this. This slide represents a move from a static formula. So dividing up a pie that gets divided by 50 community colleges at the start of a biennium based upon contact hours, which equates to enrollment. So that was what was driving our decision making, our business planning, our strategic planning. That's how we receive state revenue. Now, on average, for our community colleges, about 23% of our funding for community colleges comes from the state of Texas. Of course, that varies from college to college. It is much higher than 23% for some of our colleges. On average, about 23%. The rest of it comes primarily from tuition and fees paid by students who are enrolled in our community colleges, and the bulk of it comes from local property tax collections from the taxing authority that our community colleges have. Those are the three funding sources. So our funding from our state legislature, from the General Appropriations Act, is an important aspect for us to be able to deliver instruction and operations in an adequate fashion to be able to meet the needs of our particular service areas for community colleges across the state. In the past, until 2023, it was, here's the amount, 50 community colleges that you are going to get, go divide that up based upon a formula that was contact hour based. We changed that fundamentally in 2023, and that is now what we call, as this slide indicates, a dynamic formula. And what that means is we don't compete against each other as community colleges anymore for enrollment, primarily. We compete against our own self, our own college, for what we can do to produce fundable outcomes. Or, as Dr. Troutman mentioned earlier, what we can do to produce credentials of value. That's really the term that we're looking for and that we ought to be seeking when we're looking at these fundable outcomes. So that's the heart of this slide, is a move from a static formula and now into a dynamic formula, more predictable funding, and funding that is based upon real-time data, not a look back 3 or 4 fiscal years ago as to what community colleges were doing. Let's base their funding upon that enrollment trend or those contact hours, but a funding formula that's dynamic, and that is based upon real-time data. And that's what we have moved to in the span of 11 months, not even fully 12 months yet, with the implementation of House Bill 8. This next slide will tell you, here are the major components of House Bill 8. Again, not fully inclusive of everything, but I'll turn your attention to the middle of this slide. The performance tier and the base tier are now in the Education Code, codified in the Education Code. That is the heart of House Bill 8. And the performance tier drives 95% of state funding. And the performance tier is based upon 4 metrics, essentially. Credentials of value, so the number of credentials of value that a college confers, the number of credentials of value in high-demand fields that a college confers, students who achieve at least 15 semester credit hours at a community college then transfer to a 4-year university. That's also a metric in House Bill 8. And the 4th one is dual credit. Students who earn at least 15 semester credit hours through a community college of dual credit, and then that becomes a fundable outcome as well. That's it. That's the heart of House Bill 8. That is how 95% of formula is driven. There are also 3 additional, what some call plus-up categories in that formula, and that is the more a college does for students who are economically disadvantaged, academically disadvantaged, or adult learners, the more in-state revenue that college can earn. So again, that's probably more of a deep dive than what I intended to go into with this slide, but just so that you'll know, that's the heart of House Bill 8. The rest of it you see on this slide are other aspects that were implemented because of HB 8. And the only one in this slide that I'll point out in particular is the FAST program, the Financial Aid for Swift Transfer. This is a new financial aid program that was created as a result of passage of House Bill 8. A 12-member commission actually came up with all of the recommendations to the legislature right before the 2023 legislative session. And one of their key recommendations, in addition to moving to an outcomes-based formula, one of their key recommendations was to create a new financial aid program for students in high school who wish to enroll in dual credit programs. Because what this 12th commission, after a year of hearings, what they determined was that there was a policy interest here, that in some parts of the state, students could not afford to enroll in dual credit programs because those community colleges that offered those dual credit programs had to charge full tuition and fees or at a rate that sometimes was unachievable for students that come from an economically disadvantaged family. And therefore, the recommendation to the legislature was to create a program that allows for state funding to go to our community colleges to be able to work with our ISDs and offer dual credit and be able to allow any student who qualifies for free and reduced lunch under federal guidelines to be able to enroll in dual credit for absolutely free, at no cost for either tuition, fees, or the cost of learning materials. That is what's in place now. 38 colleges in the last 11 months have implemented the FAST program, and the other 12 that have not implemented it yet, as far as we know, have plans to do so here over either the coming fall semester or the spring semester. And we're seeing an enormous growth in dual credit enrollments across the state, as we expected would happen. All right, and I'm going to move on and try to wrap this up here so that you all can go on to more compelling speakers, of course. This next slide just shows you a visual representation. This is the old formula and how state funding was divided by community colleges based upon the old formula. And this is the new formula. Where you see blue, that is the performance tier. That is money, state funding from the General Appropriations Act that goes to our 50 community colleges that is divided up based upon outcomes and performance. And the other 5% is the base tier that I hadn't explained yet. And just very quickly, the legislature created a base tier funding because we know that there are some community colleges that don't have taxable property to the extent that perhaps a property in Austin would be. So raising funds for basic instruction and operation for some of our community colleges is a challenge because they don't have the property tax base that other community colleges have, particularly those that are in more urban areas. So the legislature created and said, we're going to set aside 5% of formula from now on, and that will be attributable to base funding. And 23 colleges in FY24 across the state of the 50 actually qualified for some base tier funding. I think it's about 22 colleges that qualify in FY25. All right, and I will wrap this up here as we move into these final slides. This slide is just to show you that one of the most important things that I can try to convey in this presentation, having heard the folks from University of Michigan and some of our previous witnesses here or invited guests testifying, there's a lot of game changers in House Bill 8. But one of the big game changers is reskilling short-term, upskilling, reskilling short-term credentials. And the fact that House Bill 8 makes fundable outcomes not just for credit-bearing credentials, but also for an array of non-credit-bearing credentials. Prior to HB 8, our 50 community colleges really didn't do a lot to put their arms around non-credit-bearing short-term credentials that they offered at their campuses. They were abundant, but there wasn't a systematic way of reporting that data in, for example, to the courting board. We reported data, community colleges reported data on credit-bearing outcomes, whether it's an occupational skills award, a level 1 cert, or an associate degree, but we didn't do that for continuing education, non-credit-bearing credentials. The game changer in House Bill 8 is that House Bill 8 makes these short-term credentials fundable. There's a fundable amount for the way to put some guardrails around it that I won't go into a lot of detail about, but it is a game changer with regard to what you all are, what we're all interested in, and that is these micro credentials, upskilling, reskilling credentials, and certainly stackable credentials. That was a recommendation from the 12-member commission. It was adopted by the legislature and codified into our education code because of House Bill 8, and this is it's a major provision within the bill. These are just the funding amounts per different outcomes, and then of course stackable credentials. And I'll end with this. I'm only going to highlight maybe one or two slides of this, and I'll do the Alvin Community College. I think they were referenced earlier. Here on this slide, and again, I think others can do a much better job of showing what Alvin Community College has done in this slide, but also what our 49 other community colleges are also doing. And that is to build these pathways that are student-friendly, that allow, we know that students who enroll in our community colleges often have other obligations in their life, whether it's a job, whether it's a family, whether it's life that just gets in the way because of unforeseen circumstances, or all three and more. So we have to be prepared within our colleges to put programs together, educational pathways together that allows for students to be able to earn a credential that leads to economic mobility, and to do so knowing that sometimes, often for our students in particular, life gets in the way. So what you see here is a representation that other community colleges are doing, not just in the healthcare arena, but in other arenas as well, but healthcare prominently because of the need, where a student can enter into Alvin Community College with a desire to achieve an associate degree in nursing after 2 years of study, but look at this pathway and what they can achieve along the way. So that if life gets in the way somewhere along the way, there are marketable credentials that have been earned by the student, and hopefully that also serves not just to help them to make a living with that credential, but as an incentive to come back and earn ultimately that ADN, or even better yet, to move on to a BSN and so forth. So I'm not going to go through all those examples because you'll have, again, more qualified folks to do that piece of it than myself. I'll end my comments and get out of your way simply by saying, you know, there are certain aspects of a student's journey. I have 2 kids in college myself. There are certain aspects of a student's higher education journey that we as either parents or as administrators or as policymakers should always be mindful of. Just touchstones along the way. So access. We always want to make sure that students have access to post-secondary credentials. Success. Once they have access, we want to ensure that we do everything we can to get them to achieve success, whether it is toward a micro-credential or ultimately toward that associate degree or bachelor's degree and beyond. So access, success. The third touch point, I would say, economic mobility. We want that success not just to be, I've got a credential, but I don't know what to do with it, or I'm not sure I can do anything with it. We want that credential to have confidence and to say, that student to be able to say, I have economic mobility because I put the time and effort in to earning this credential. So economic mobility is a third touch point. The fourth touch point, I would argue, is affordability. That we always want to be vigilant about ensuring that higher ed is affordable to anybody that wants to access it. And here's where I'll end. House Bill 8 is particularly exciting as public policy because House Bill 8 touches each of those 4 touch points, and not just touches it, but improves each one with various aspects of what we saw occur through House Bill 8. Madam Chair, sorry if I took a little bit longer. I'm enthusiastic about community colleges across the state. They are the backbone of our educational system, and I'm equally enthusiastic about House Bill 8, as you can probably tell. I'll turn it back to you for any questions.
Thank you so much. Any questions from the panel? Thank you very much for being here, Ray. Austin Community College and College of Healthcare Professions. So we can call you up at the same time and kind of get this, get moving.
Good afternoon. My name is Gaylyn Scott. I'm the Vice Chancellor of Instruction, and I'm here to continue preaching the gospel of community colleges and the work that we do. I'm here with my colleague, Dr. Nina Almasi. She is our Associate Vice Chancellor for Health Sciences, so she is the content expert. I also bring you greetings from ACC, where we are launching our free tuition program this fall. Any high school grad in the class of 24 in our service area can come and take advantage of free tuition, and we are hoping that that makes a huge difference in the work that Ray referenced in the economic mobility and the community impact that we believe in. So very quickly, on stackable credentials, I just want to run through this. You know this already, but I wanted to hit the highlights. The idea, of course, is to embed one credential on top of another on top of another. We have some standard kinds of credentials that we offer. Most often, the OSA is where a lot of students start, the Occupational Skills Award. Very short term, very quick, and get a student maybe a very entry-level job in the field that matters to them. So they can at least be working in a field, and then they can come back and gain more skills and gain additional opportunities for better employment or promotion or that sort of thing. We also offer an enhanced skills certificate. That would be the next sort of level of a stackable credential, just layering in some additional skill building. OSA is a very entry level, and enhanced skill credentials going to give them a few more skills and perhaps a bit of a raise at work or a little more interesting assignment at work. Then, of course, you've heard before of the level 1 and the level 2 certificates. Those are very standard. Those are embedded in every applied associate degree that we offer at ACC. So in any workforce degree, students can get a level 1 and often a level 2 certificate. Level 1 has that credit hour limit, so it's not more than 42 credit hours in a standard associate degree that's 60 hours. So it could be anywhere from 15 to 42, depending on the skills and the knowledge and the abilities you're trying to help students gain in the context of a larger associate degree in applied science. Level 2 is going to be a little bit more. And then, of course, the Associate of Applied Science, typically 60 hours, sometimes a few more in a certain fields, particularly in healthcare. And on top of that, it's not on the slide, but we also offer an Advanced Technical Certificate, ATC, and that can be something that students can only get after they've achieved that associate degree. Might be a little more specialization, a little more focused skill building with an ATC. So that's a quick run through of the standard stackable credentials. You've heard this before. Why do we do it? There's a lot of opportunity for students to come and leave and come back, lifelong learning, get a job, but remember they can always come back through our doors and build more skills and get perhaps a better job. There's a lot of focus on keeping students moving forward in their learning. Stackable credentials can often fit an earn and learn model. At ACC, 3/4 of our students are part-time students because they do have jobs, they do have family obligations. So you might get an OSA or a small credential, get you a better job in the field that you're interested in. You can start working in that field and then come back and get more from us. So there is that earn and learn component. Multiple entry and exit points. We're going to show you some visual examples of this notion. At ACC, we have sort of a subway map example, and you can think of it as hop on, hop off. You can come, you can get a credential or two, go to work, come back, get another credential. So there are lots of entry and exit points, lots of opportunities for reskilling and upskilling if you've really intentionally built these stackable credentials the way you intend. There's a key component of industry partnerships. You cannot do this work in this lane without having industry partnerships. Every workforce program that we have has an industry advisory board. We meet with them regularly. They tell us what skills they need. They tell us what skills are missing perhaps in their workforce. So it's a very responsive and nimble opportunity to work with industry and give them the help that they need so that our students can find the jobs that they want and the industry can hire capable and qualified employees. We also, you've heard this before, it's really about serving underserved communities. For many students, an OSA, just a little, maybe like a 3-class certificate, that's all they can manage. That's not too intimidating. That's not a commitment of a lot of time. So you can reach out to underserved students and make a difference and get them on a different path. So as you can tell, we believe in the power of stackable credentials. This is an example. It's not in healthcare, but I think it's really helpful as a visual aid. This is from our semiconductor work at ACC. On the left are the non-credit opportunities. And then to the right of the dotted line are the credit opportunities. And the colors tell the tale. So you'll see 2 classes. You can be certified production technician, very short, get you a very, very basic entry-level job. But you take 1 more and there's a little more skill. And then you take 2 more, the 2 classes that are in green. That's going to skill you up a bit more. Move to the right of the dotted line. You see those 2 classes in green. Those are the same. So we're taking non-credit classes and we count them in a credit program. You heard from the researchers that there's not enough of that connectivity between non-credit and credit. We're really trying to build out that connective tissue. So we want to teach the non-credit classes at a level and with the quality that we can gladly give students credit when they move over to the credit side. They don't repeat the courses. We just award them the credit. So those 2 green classes under stars on the non-credit side also are recognized for credit. And then they take 1 more class and they've got an OSA, an Occupational Skills Award. And then move 1 more to the right and you'll see the 2 green and the whatever color that is, the yellow-orange, that is the OSA. Those are in this next one, the level 1 certificate. So those classes they've already taken, and then they take 3 more classes in the orange to get the level 1. And you can keep moving. That's the notion. For me, that's a really helpful visual representation of stackable credentials, all the way from 1 or 2 classes in continuing education in the non-credit side through to an Associate of Applied Science. And if the screen were bigger, we could take you through to the bachelor's degree that we offer in advanced manufacturing. This is a different way to represent stackability, and I'm turning the mic over to my colleague, Dr. Almasi.
Thank you, Dr. Scott. Hi, everyone. It's an honor to be here. My name is Nina Almasi. I also serve on the work group 3, so I look forward to the meeting next Thursday and the work. So this is one of our fairly newer stackable credentials that we created on the LMRT side. So we had the traditional radiology technology associate degree, and in response to our industry partner, we designed a step prior to that, and that is the limited medical radiology technology, a 1-year program. It's a level 2 certificate. And so it's very seamless. Students apply and they can choose to go all the way. If they do, they have guaranteed admission. And they can also, after a year, basically, as Dr. Scott mentioned, if they need to, take a step back or continue in the program while working as an LMRT, which our area had demonstrated a need for LMRT. So what we are currently working on is kind of taking another step back and looking at the MA, the medical assisting path, to LMRT. Now that we have the LMRT in place, we can look and see how we can link something like an MA, which we already offer in our continuing education, to LMRT. And then our advanced technical certificate options after the radiology technology, we have multiple that we offer. We have CT, MRI, and cardiovascular interventional therapy, and we recently created the mammography certificate. So these are all after they get their associate's degree. They can, some of them are 1 semester, some might be a little longer, so they can continue on. And go ahead.
You want to go ahead and talk about how we work with the high schools as well? It was an interesting point that she made, that we look backwards as well as looking forwards. We start with something and then we see we could start with something smaller and get students started. And we have some really good partnerships with the high schools as well.
We do. In fact, several of our health science programs, we have a health science academy, and we offer several certificate options for high school students, including pharm tech, EMT basic, as well as phlebotomy. We recently created a pharm tech, a P-tech, where they can, in high school, they advance towards their associate's degree. And we're currently working, as Dr. Hooper mentioned, it's in the works, an LVN track for our LVN program that we're very excited about.
This is our visual aid. This is our subway map, and it's quite dense. And so you have it in front of you. I don't know if you want to talk them through it at all or highlight anything in the subway map.
If I just may refer to, as Mr. Martinez mentioned, we felt it's very important for our students to see that, the visual side of, this is my pathway, it's achievable. And this is our nursing pathway, essentially. 2 entry points, LVN and ADN. Within the LVN entry point, we have multiple options. We have a part-time option, evening, weekend option, full-time option. And then one thing that we did as a result of a grant from the coordinating board, accelerating credentials of purpose and value grant, we looked at the CNA program that we offer in continuing ed, and we gave credit for one of the LVN courses in the degree plan if they are a CNA. So, and that's how we kind of stacked that into this. And then we have multiple kind of pathways into the RN program, either through the mobility track, that's for LVNs, paramedics, other healthcare professionals who want to become an RN. It's a one-year program. We also have the alternate entry, and that is for our own graduates of the LVN program, where they essentially skip the first semester of the ADN program and enter the RN program, and they have 3 semesters to get their associate's degree. Once they get their associate's degree, then their path to our RN to BSN program is illustrated there as well.
This is just one more visual to kind of illustrate a different way to think about it. I like this one. It shows the skills that you're gaining as you move from one sort of credential to another. It shows the impact on your earnings, right, as you build an additional, some additional skills. So this is, this is a fellow community college, and I can't remember who I got this off the Texas Association of Community College website, but it's just another way to illustrate the power of stackable credentials. So just, a reminder of what we think really matters in intentionally building out stackable credentials. Smaller always feeds into larger, right? Shorter into longer. You can articulate non-credit to credit, and students get that credit without having to retake a class. There are lots of entry and exit points for students to come back and get additional skills, or if they have to take a pause, they can always restart. It's really, really important to engage regularly with your industry partners, and of course, the power of reskilling and upskilling. So that's my very brief overview of what we're doing at ACC, and we can take any questions, and then I'll turn it over to my colleague.
A quick question. First of all, thank you for showing us the visuals. It's super helpful. For stackable programs like this, especially in healthcare, how are you measuring success?
That's a great question. Thank you for that. We look at transferring into the next level since all of our health science programs are accredited, those outcomes, program outcomes, completion rate, we track those. And I can give you the example of the LMRT. We started that the first cohort that graduated, we started small, 7 graduates of LMRT, and all 7 moved on. Actually, they choose to move on into the associate's degree. So we continue to look at that, especially from the CE side. We know, as previous presenters mentioned, we have a lot of work to do to better track that piece of it.
We also have some ability to track earnings 1 year out, 5 years out, thanks to a partnership with the Texas Workforce Commission and their UI data. So we can also see where we're succeeding and where we need to improve just by looking at earnings based on a certificate or a degree.
Clearly, this is an advanced example of a program using stackable credentials and really integrating it into your model. I'm going to put you on the spot just a tiny bit. There are schools that don't do this and programs that don't do this. Are there reasons why? Are there particular barriers why for the schools that aren't choosing to go down this path?
I think that's a really interesting question. I think some of this may have to do with the power of your industry advisory committee for a particular CTE program. What did they tell you students need? What are you hearing from them about skills gaps? Because the more they tell you, the more you can start thinking in smaller pieces about how you can give them what they need in a potential employee without putting students through a 2-year degree. It could also sometimes just be a labor issue. You need the right faculty who have those hands-on skills to be able to teach some of those skills-based courses. Can you think of some other?
I can speak to that. Another thing that we're seeing, especially as we're responding to our healthcare partners and creating these kind of shorter credentials, is finding the applicants, finding students who are interested. And what I'm hearing from our healthcare partners is that it's challenging for them because they want their employees to upskill. That is part of the reason why we do this in partnership with them. But then even taking those employees out of those jobs to put them through that program and training could create additional staffing challenges for them. So that might also contribute to the.
And you just have to think very, very intentionally about the 60-hour pathway, because you want everything in that 60-hour path. You want everything in the level 1 to be in the 60-hour, everything in the level 2. It takes a lot of work and intentionality to build it out in a way that serves the needs of the industry and the needs of the student. There are also financial aid rules. You can't have a credential under, I think, 16 hours. It won't qualify for financial aid. So you have to build at least a 16-hour level 1 certificate. So a lot of moving parts that a lot of folks have to navigate.
Any other questions from the panel? Great. Eric, thank you for your patience, and thank you for being here today. Talk to us a little more on the allied side of the house and how the private market is adapting to stackable credentials.
Great. Well, thank you. Is it on? I think it is. Thanks for having us today. Really appreciate it. And it's been a good day of learning and seeing all the different pieces that are happening out there. And, you know, a couple high-level comments that as I've been listening today is one is I thought, as you said aptly earlier today, that, you know, allied health is a big piece of this. And I think that I'm glad to see the focus on it because it's a huge part of healthcare. And the other is it takes the pressure off of our nurses and our doctors to be able to provide better quality care and also more care, because when you don't have enough allied health, it slows down access and just throughput within our system. So I think it's an important part. The other one is you know, I also am looking at some of these numbers, and I ran some numbers, and this is from the Higher Education Coordinating Board. The community colleges have 62,000 people enrolled right now in healthcare, okay? And if you take the average graduation rate of 22.8%, also a Higher Education Coordinating Board number, that's 14,000 a year. We heard earlier from TWC that there's 23,495 MA job openings right now alone, and also half of those 62,000 are in nursing that are out there. And so we obviously need more enrollments, but the other thing that I think is really powerful that we need to focus on is how do we get higher graduation rates for people who are wanting to try. And when you look at it, it comes back to what we were talking about earlier, and so many have talked about is adult learners. And adult learners have extraordinarily complicated lives, huge issues around work, transportation, childcare. And the reality, too, is our average high school graduate now is not a traditional learning coming up to UT, having their dad pay for 4 years. It's not. They're having to help support multi-generational housing, working, have kids, all the other pieces. So when we look at education now, I think we have to look at it more, especially in our 2-year type programming and below in the certificates, very much focused on the persona of a single mom living day to day. And when you do that, you can have some extraordinary outcomes in what you're doing. So I will kind of go through, give you a little idea who we are. We were founded 36 years ago in the Texas Medical Center, and we were there for quite a while before. It was an internal training school for the McGregor clinics because they couldn't find enough allied health. We spun out. There's only one McGregor clinic left in the state. It used to be the largest network, a physician network in the state, and it's in San Antonio. Today, we are producing 28% of all radiology certificate associates and degrees in Texas. That is the market share. 69% of all radiology certificates, 26% of all dental assistants, 24% of all medical assistants. And when you look at who we are helping, it is all adult learners with complicated lives when you really look at it. So we have 10 campuses across the state. You can see all the allied health programs we're doing, from Surge Tech to coding and billing, Pharm Tech, cardiovascular. We do have nursing. I'm not going to spend a bunch of time on nursing today. I'm going to focus on the allied health. But this calendar year, we will graduate 6,000 across the state. And that's with 2,300 different employer partners across the state. So we have a pretty deep view. And the other thing is we're very standardized. And so if you're taking our program in Dallas, it's the same as if you were taking it in McAllen, Texas. But we do understand that every community has different cultures and tie-ins. But when you look at our stats, it's not because it's different programs and what's happening. Again, you can see all the different type of people we tie to. What I want to look at here, and I think is really important, and I'm so glad this task force has come together, because our employers are desperate for people. Our employers are having to, and we're very close to our employers. We came out of an employer. And so we have advisory committees deep and all of these pieces, just like Austin Community College here. And they're having to shut down facilities, delay care. We're watching nurses having to be surge techs, which they don't want to do. It causes burnout. All of these things that are happening. And the reality is we don't have enough high school seniors graduates to solve this problem. We've got to do it with this amazing, intelligent group of adult learners that didn't necessarily have a good K through 12, but are smart people, but are now having to live more of a day-to-day life. And also, we have such an opportunity in increasing graduation rates, not just worrying about enrollments. I also just want to point out, every one of these pictures in this presentation are our students. These are the type of people that we're serving. So 72% are 22 are older, 42% are parents, 85% are of color, 90% are women, 52% are Hispanic, 90% come from the bottom 60%. The average salary when somebody comes to us is $5,600 a year. That's off their FAFSA. That is what they are making. 40% first gen, 43% have tried college. Most of that is community college. And so what has been our approach, and we started this about 10 years ago when we were putting a new campus in McAllen, when we really switched our whole model because we saw who our student was changing at the time. And also, we were hearing from our employer partners that they needed more diversity. They needed more diversity on who was going to be serving in the healthcare settings. So the first piece is short-term and stackable. And this is one of the things, and we just heard a great presentation here tying to it, but our students need 9 months for our student, the ones I was just describing. That would be like you getting a PhD. Trying to get through 9 months is extraordinarily hard. So when you build it into a stackable program, earn and learn, you not only stabilize their life, but the point is when they go to that next stacking piece, that they are so much better prepared educationally and also understanding the context of the healthcare setting and what is happening. So they become a better student. And at the same time, they can do a tremendous amount of this work online. Other than the clinicals, we are huge believers, like our nursing friends over here, Dr. Hooper, on that you do need hands-on. You can't be all simulation or just looking at videos, but there's a tremendous amount of didactic that can happen online. So we have built, over the last 9 years, we have an LVN to ADN, we have got the LMRT to RT to a radiology bachelor's degree. You can do an M medical assisting to a health and medical administrative services up to a healthcare management. All of these can do. You can get a bachelor's in 3.5 years if you want to, but you don't have to. And as we heard earlier in another presentation, people take all sorts of different routes. And we do not believe that it is our place to judge when somebody wants to stack in their life. Our average age is a 25-year-old aspiring mom. And she might want to wait till those kids are out of diapers, but she sure doesn't want to lose credit. And when she knows she's going to lose credit, she most likely won't go back. And I would also add on that I do not believe that any institution in Texas, from accreditation from anywhere else, doesn't have the ability to build these stackable programs. There's a lot of tradition that has been on this is how education is. There is a lot of change that it creates in an organization. It did for us too. But the other side of it is you're creating and increasing outcomes. The second piece of this is flexible but structured, and this is something that I think is just as important as the stackable piece, is our students can't go to class 4 and 5 days a week coming into the schools. What we did is we switched everything to 2 days on campus, and the rest they're doing online. Now, we have availability to help them the rest of the week and on the weekends and whatever else, but the point on that is it's very powerful. You're not going to leave your kid in the car because you don't have childcare. You're not going to not go to your job and then lose your apartment or not be able to put milk on the table. So when you create a program where they don't have to come in as much, you're right there. We're not waiting on, the federal government to fix childcare. We have cut half of it by them not having to come in. We have now launched 1 day on campus programming, and we're pulling people from Eagle Pass up to San Antonio, Hobbs, New Mexico, into Fort Worth, Beaumont and Victoria into Houston. These are the types of things because it is a model that can work for them, and it increases rates. The other piece is I think this is another important part. We heard a lot about it today, so I won't spend time on it. But all of our programs, we provide them with work-integrated learning. They're not paid apprenticeships. The apprenticeship piece is extraordinarily difficult with the employer side of it. But the point is a huge amount of our students are hired directly out of their externships that they are doing. And the last piece is really wraparound services and what's happening to really be there for those students as they're moving through. And I think our state is doing a great job on this, and HB 8 is going to be extremely helpful on a lot of these pieces because it's going to drive outcomes. But the point on it is when you do these things, that you can have extraordinary outcomes. We have 81% retention for our students based here, 84% job placement. Rice University did a longitudinal study on us. We are graduating 78% of our Hispanics, placing 80%, and you saw those other earlier numbers. And the reality is it is because we have gone with an earn and learn model that works for the student and also provides the outcome that they are looking for, which is moving into a professional career. So when I look at this, and I'm going quick because everybody's seen a lot of presentations today, I believe that these 4 pieces are incredibly powerful, and we have proven out in a scalable model right here in Texas. We didn't even realize how large we had gotten over the years, and that you don't have to worry about enrollment. And because when people are getting jobs, they're being successful, it's pulling in. And I think this is a tremendous way to create generational change for so many of our adult learners that have been left behind and the future generations coming up. But we've got to do these pieces. We can't force people to come in 4 days a week. We've got to have the flexibility, the stackability pieces, the work-based learning, those. And that Brookings study up there is a very powerful one that came out recently that ties a lot of this. So that is kind of my piece on this. We have, it's never simple, as our friends here know. But the point is Texas is off to a great start. And I really think there's also some real ways that we, from a regulatory and a legislative standpoint, can push on the HB8 piece to create education that works. We can solve childcare in these 2-year and certificate programs by just cutting how much they have to come in. And the other is you can still have extraordinarily high certification pass rate, participation rates, graduation rates, and clinical success when doing it. So, any questions?
Any questions from the panel? I do want to ask you a little bit about certificates versus licenses, and how does that affect the employability of your students if they're getting just a certificate or if they're getting a license? And do you see a difference between the employability of that? Obviously, they're different skills, but
no, it's a good
industry
question.
accepting-
First of all, it's a lot of people get confused if you're not in it every day like we are, our students get a certificate from us or an associate's or a bachelor's, but they also are taking their national certification test to be certified. That is the test that is so critical. That has to, now, lots of times you have to have a certificate to be able, or an associate's to take your national test like you do in radiology. But this is the other piece that we found that was really powerful. Years ago, we never, for example, in medical assisting, we never, they graduated. Our medical assistants can get certified in EKG, medical assisting, and phlebotomy. They have all of that. It's a front end, back end, 9-month medical assisting program. But we just told them, go take your test and we'll reimburse you. So, but nobody was taking it because people have the fear of, oh my gosh, I might fail. And if you look at that, 74% of our Hispanics are first generation. I mean, there's a lot of fears. And we were like, well, this is goofy, because we know, we had done a study, and this was years ago, they were going to make $2 extra an hour if they were certified. And they had the skills. So we just moved all of that into our programs wherever we can. Now, there's some programmatic pieces here and there you can't, but they have to take it before they ever graduate. And like 99% of them pass the test. And so building again, taking away those pieces and building it in is very powerful. But these national certifications are incredibly important. There is over, and I haven't looked at it recently, but there's like over a $10 difference of being nationally certified in sonography versus not being certified in sonography. And you don't have to be certified to be a sonographer in Texas. You need to have an associate's, but you don't have to take the test. But think about that, $10. I mean, that's $20,000 a year. So building those actual national certificates in is really powerful on changing the wages, and also it just takes the whole fear out. They're prepared. Yeah. We're going to make sure they're prepared. One other comment I will make that I think is something else that we need to really be thinking about in this is allied health. We are not anytime soon going to have enough nurses and doctors. When you just look at math, you do the math. And one of the things that we're really watching happen, and I think y'all are seeing it too, is we're watching the medical assistant, a high-level medical assistant is really beginning to take on LVN duties. And you do it under the auspices of a doctor and such, but we're watching it more and more happen. And for example, you've added the LMRT program. We've had it for like 20 years in that. We were the only ones who used to do it. But the whole urgent care world has changed where you don't have RTs, you have LMRTs. But the other thing that's interesting on the LMRTs is we have a huge amount of our LMRTs. They actually go the management route and they manage urgent cares. And the other one is we built into ours MA skills. So they're multi-task pieces in how they're building out. But I think the allied health piece is something that is well worth this task force focusing on, because there is so much more ability to add capacity quicker as we to offset some of the problems we've got in the system. And also, we just change so many lives for the better when it happens.
Yeah, and you heard this morning, we talked a little bit about Work Group 1, sort of took on this issue, the challenge of knowing how many of these national certifications we have in this state, because they're not state licensed and we don't know exactly where they are. Do you think that that there are ways that we can find out how much of that kind of workforce we have in this state? I mean, so there's some challenges. I believe it's in the state's interest to get a handle on what this piece of the workforce looks like, but we can't count it. We don't have a way to count it necessarily unless we ask the employer or we ask the National Certification Testing Company, who doesn't have to tell us anything. So those pieces, I think we're trying to get our hands around, because the state won't build supports if we don't really know what this piece of the system looks like.
Yeah, I think you're right on track on it. And a couple pieces, I think there's more information out there than we think. I think it is disparate and in all sorts of pockets. Like when I was digging around, I was really impressed with what I found that the Higher Education Coordinating Board had, And I also, the other one is it's really powerful on looking at job openings. Now, we are in the major cities. We're not in El Paso, but all the other. And, I know, for example, and again, we've placed with over 5,000 employers in Texas in the last 5 years, and we probably have more up-to-date wage data because we know week to week, I mean, there's hundreds being hired every week of where wages are changing in these major markets that we're in. But for example, San Antonio, we right now have over 2,000 orders from our employers for medical assistants that we can't fill. And the radiology area has really gotten extraordinarily difficult. And we're the largest provider of, RTs and LMRTs in Texas. And you saw those numbers. And I think we can pull a lot more together obviously it'd be great if we reported for it, and I'm fine with that. But I think in between iPads and a lot of this, you can really begin to see the trends of what's happening. The bottom line is we really have got to produce. And I think also it's more than just enrollments. I think it is also us figuring out how we build education that is not traditional, like it's been done the last 1,000 years, for adult learners that have a lot of other complicating factors in their life and are really living day to day. And it is possible, as we've just been talking about here.
Can I ask Dr. Scott, and obviously, and you can speak for Austin College and maybe speak for your brethren community colleges, because you've got these programs, this kind of very elegant programs of how people can advance. And I'm wondering, what are your barriers to scaling? So you've got all the entry points and the growth points. To meet the deficit that we have, what would you need to scale? What limits you?
I can start, and Dr. Almasi will have additional information. Clinicals are key because every healthcare program requires hands-on learning, and we're not the only folks in the market. And so sometimes the clinical opportunities are saturated. You can't scale if you can't ensure that your students can do those clinical hours. We're certainly trying to build out simulations where we can, but as everyone has said today, you've heard it before, it's also got to be hands-on. Faculty, qualified faculty can be a challenge. What else do you want to add?
I would say also the either lack of information or misconception about the health careers out there. We see that on a regular basis when we host partners from, different areas, different entities, school districts, and they tell us, like, we did not know that these, a community college would have these health career options. Or even, our University of Michigan partners talked about the EMT to paramedic track, and we offer very similar to what they indicated. And there is a big misconception, and even in the data, in the labor market data, there is not good differentiation between the EMT basic careers, their salary, and a paramedic or an advanced EMT. I was emailing Pam Lauer earlier. I need to get with her so we can look at this more closely. So the public, knowledge of these careers, we hear nursing, right? We hear nursing all the time, and it is the biggest health profession, but there are so many other careers that they may simply not know about.
I'll just add into it. I think it is really powerful there's so much opportunity to do more work educating in the high schools and the middle schools that you can be a surge tech, you can be a cardiovascular, and also with adult learners that you can retool and be successful.
I was going to add, some of these are extremely capital expensive, right? You have to buy the right kind of equipment. It needs to be equipment that your graduates are going to use in the healthcare setting, not equipment that's 10 years old. So it can be difficult for providers of these educational pathways sometimes to expand and offer additional pathways. Accreditations are not a barrier, but they are part of the package that require a whole lot of intentional effort and focus to maintain your accreditation and to, be responsive to the accrediting body.
Do you find that the clinical opportunities are spread throughout the providers in the community, or do you end up relying on, one or two?
We have dozens and dozens of clinical partners. We are always looking for new clinical partnerships and looking for creative ways. Should we offer an overnight clinical opportunity, right? I mean, we're trying to think as creatively as possible to ensure that we have explored every option to provide clinicals.
If I may add one point, Dr. Benton, earlier we talked about the long-term care, for example, setting as an option that often is not utilized, let's say for an RN program. We have tried, believe me, every site that could potentially host our students. It requires kind of a greater partnership with our long-term care settings because of the models that they have. I mean, the way the system is set up, right? For example, use of a certified med aid. So our students have to hands-on give meds with the faculty or, along with the nurse, but their model is different, and that kind of creates a challenge for our students to be able to do that kind of hands-on. So that was one of the kind of issues that we saw, that kind of we had to pull back from some of the long-term care facilities because we weren't able to ensure that the students meet those clinical objectives for RN students in a long-term care setting. So there's just a slew of different kind of,
And I will say, in Central Texas, there are a lot of providers of these opportunities to go into a healthcare field. I think we work fairly well to be collaborative, even when it comes to clinicals. It's not a knockdown, drag out. It's just it takes a lot of effort and intentionality and scheduling and working with other educational programs and all the healthcare partners to make it work for everyone.
That's a great point. I just need to put a quick plug for Central Texas Healthcare Partnership. I think that is a great model to look at. That is a consortium in this region that is kind of really facilitated by the Workforce Solution Capital area. Ashley King is the director of it, and it includes all the area academic partners, all the nursing schools, our major healthcare partners. And through that consortium, that partnership, we actually have a central system of clinical scheduling that we all take part in. So we do really, we're partners. We don't look at each other as competition. That's the only way that we can serve the community is really collaborate to maximize the use of clinical sites. And I want to say CTHP does that really well.
It's a good tool.
that regional scheduling tool was actually something that one of the other regions pointed out that they desperately want to have there as well. So it could be an aspect of support that a smaller, less dynamic region might need. So thank you all very much for being here today. Really appreciate it.
Thank you.
All right, our next panel is going to focus on apprenticeships. So we're going to have Rick Cochran with the Texas Healthcare Association, Mary Rivard with Vernon College, and the Texas Association of Community Health Centers, Preston Poole. And so if y'all will all come up, we can do this, our second to the last panel. After a long day, we very much appreciate everybody hanging in there with us.
Guess I'm the only one sitting here today. This is automatically on? Okay, good deal. Well, thank you very much. Appreciate the opportunity to share what we're doing. I was asked to share what we're doing with our employees. Every single one of our employees, 4,000 plus of those individuals, are in 40 facilities in the state of Texas. We're serving about 3,500 to 3,800 individuals. Long-term care, skilled nursing. Okay, so when we talk about allied health, you talk about the nursing. Probably 45 to maybe 55% of our population is CNAs and LVNs. Right? And so that's very, very important to us. So what I'd like to do today, I've listened to all the presentations. I've taken a lot of notes of some people we need to be talking about, specifically with Texas Workforce Commission on some additional funds, because everything I'm going to talk about, we're funding ourselves. And I can tell you the results. So what I'm going to do here is I'm going to go through some of these presentations, these slides. We've heard a lot, what I had already put together, so I'm just going to cut to just a couple of points on each slide. You should have my presentation, and then you should have a narrative. So you're going to get everything that you need if you just read that, so I don't need to tell you this, okay? But a couple things I want to point out. I kept hearing today the hard work that's going in to make sure that the education is matching the needs of organizations. 3 years ago, we decided we were having huge attrition issues. People that were coming out of school, they were not educated for geriatric and the type of business that we deal in. It just wasn't working. So we were having to send them back to school, or we tried to train them within the organization. And that wasn't working very well. So one of the things I'm going to get to here at the end is one of the solutions that we came up with is we started a nonprofit LLC called HMG University. And it's registered in the state of Texas, and it is to drive CNAs to LVNs, LVNs to RNs, both associate and bachelors. We've just opened up a new program, which is for all of our administrators. We have a lot of administrators that come out of come out of school. They're young, they've had the education, but they don't have the practical experience, and that's difficult for us. So we all know the current state. So when I look at 3 years ago, as we were having, we just getting into COVID, it was creating a big issue for us. And when we began to look at the marketplace, there's about 4 million people within the state of Texas that are 65 and older. And that's scheduled to double in 2050. So whatever issues we had 3 years ago and what we're having today, it's going to be magnified moving forward. The increase in chronic conditions and cognitive impairments is a big issue for us. And they're not trained or educated in school to handle those. And so we need individuals that understand geriatric care. When I look at the curriculum from my perspective, and I'm going to ask you to look at it as an employer from our lens, my general statement and the overall, I think there's always exceptions, but the overall statement I want to make is that the curriculum and the training when they came out didn't meet our needs, and that was an issue for us. And that was the reason why we decided to build our own organization. Now, we have a group within our company and within each one of our facilities that does some training and so on. But what we needed to put in place was a specific, be very intentional in what we do, be very specific in what we're doing, and then begin to develop relationships with educational institutions on the outside to move this forward. So when I look at proposed changes in the nursing curriculum, I'm looking at not just the nursing, but I'm also looking at CNA and LVN within our organization. We do our own CNA training within our organization. Some of the things that we saw, and this is our lens that we saw, we thought we could bring more simulated learning environments, bring technology into this, have more of a curriculum focused on long-term care. Some of the incentives on this would be scholarships. We saw that scholarships, one of the big impediments for our students going back to school or being retrained was cost. It's just that simple, pure cost. And when we began to take that away, we had a number of people start flooding in and saying, yes, we want to continue. I'm a CNA, I want to be an LVN, I want to be a nurse, or I want to be an administrator. And the biggest inhibitor on that was dollars. It was just pure dollars. Know that everybody in our educational program internally is an adult learner. Every single one of them. Every single one of them are working full time. So they have family, they have work, and they have education, and that's difficult. So that's one of the things that we had to do is when we looked at this is get rid of the number one inhibitor, which is cost, help them with that, create clear pathways. One of the things that we saw is when people came into, and typically across skilled nursing or long-term care, is they come in and they're looking at, as a CNA or an LVN, that particular job. And one of the things that we found within the first 60 to 90 days, those new individuals that came in, 40 to 50% of them attrited. They left because they had no idea what their path was, and they had really no idea how hard this job was. So we found that if we spent time with them to put together their career pathways, create in their mind's eye that trajectory of what life will be and the compensation associated with that, we drastically began to reduce attrition from CNA and LVN perspective. The other thing that we needed to do and we saw was people would come in and they were thrown right in the middle of the fire. So one of the things that we needed to do is create career counseling within our organization. Not academic, but career counseling. And that's creating that pathway, working with each one of these individuals to understand their personal needs, the direction that they want to go, get rid of these inhibitors, which is dollars, reallocate the dollars we're doing within our organization to educate these individuals, which we found at the end of the day, it was cheaper to put people through education than go try to rehire individuals. So we just reallocated dollars within the organization. So on preparing, preparing for the future of nursing education, one of the things we began to look at is emphasize continuing education. Create certificate programs that are specific to what we need in long-term care or skilled nursing, and create adaptive learning models. Make sure that what we're doing is relevant in today's world in our situations. Now, those are all the things that we began to see 3 years ago, and we began putting these things in place. We first started putting things in place that would be, well, let's do training. And what is training? And let's work with the individuals. And that's where HMGU came into play 3 years ago. And we said, okay, let's put scholarship programs in place. When you come on board, and there's a criteria for that, I will pay for your education, full education. When I began to look at that, we started to go down the path and say, let's create a real educational entity. Well, in my world, and from a business perspective, these problems need to be solved yesterday. I don't have time to spend 2 to 3 years to build up an educational entity. So what we did is we put criteria in place and we went to the marketplace to partner with educational entities. We do all the hand-holding, all the counseling, all the finances. We work directly with the schools. Our first partner was Lone Star College, and when we worked with them, I said, I will give you students, 4,000 people in my company. I will give you students. What I want to do is I want to work with you, with our nurses, on the front end of your curriculum, during your curriculum, and then when they come out, I want to create a curriculum that we will instill within the organization. That same mentality, we're working with 14 schools across the state of Texas to do that with them. Now, why 14 schools? One of the things that I found and why we overlooked this is I had some students that were traveling 90 minutes to go to school. We worked 7 by 24. That didn't work out. So we began to develop relationships with schools that were in the general vicinity of where our employees lived. That reduced attrition. So today, if I look at our organization, we provide education and we provide the tools for that, and it looks something like this. We have HMGU that provides full scholarships. Today we have 100 students in that program. It took us a year to get this ginned up. 100 students in that program. 97 are still with our company. Where'd the other 2 go? One had some hardships. She decided that she just put it on hold. And the other one, it just didn't work out. So right now, that's a pretty good retention rate, right? So we've been playing with that now for about 2.5, 3 years. We are now going to put it on full throttle. The other piece is we've had 2,700 individuals apply for these scholarships within our organization. I cannot afford that. Can't afford it. But when we began to work with the schools, they came forward with grants and aids and so on, and we began putting these students through school. Now, some of those don't want to be an LVN. Some of those individuals don't want to be a nurse. They just don't want to do that. They're very happy in what they're doing. So what we do with those individuals, we launched last year called HMGU Learning Portal. It's for all soft skills. We develop it ourselves. We partner with some of the schools. We own that content, and it's conflict resolution. It's time management. It's those types of systems where people can log on, all 4,000 employees. It's competency-based, and they can log on to this program, and they feel that we as a company in general care about their welfare and building their plan in building their plan to succeed and move to that next level from a compensation perspective. That began to drop our attrition as well. Okay? And so I can't tell you that we were really, really smart about figuring all of this out, but one of the things we have figured out is you need to iterate very quickly. And everything that we do on the portal, every single page when you go onto that portal, you have the ability to comment, I like it, I don't like it, add it. So we have an incredible feedback mechanism that makes it relate to our students/employees. Okay. And I'll pause there if you have any questions. We did have the commissioner from Texas Workforce Commission come out and gave a substantial check to Lone Star College for the partnership of our 2 organizations working together. The schools like us because they need people in seats. We like it because we get customized education to handle our 3,500 people that are in our facilities. The ultimate, it helps our attrition. We see in our feedback that it's positive, but ultimately what we want to measure, and the other part that I'm leading here is our data analytics, is to be able to measure the outcome. If I'm doing this and I'm paying for this, what am I getting on the backside of that? We're not there yet. I think we need another 2 years before we'll be able to do that. I was just informed when I walked out into the hallway that we have another 15 people that are graduating from one of the local schools, which is really good. So we really try to, and they are, our majority of our population, very candidly, are single mothers with two kids. And this is tough. This is very tough. But when we say we come forward with our own dollars, a lot of this is we're reallocating what we're doing and putting it in things that matter, which is the human element. And the gray piece of this, which is working with them after hours, before hours, is the hard part. And my feeling, people ask me, why don't more people do this? Well, we all know what we need to do. We all know the problem. We know what we need to do. But the problem is in the implementation of this and staying with it. That's the difficult piece. Now, clinicals, we actually literally, I'd love to do clinicals for the schools, because what happens is they come in and I recruit them. And then they become full-time employees. Everybody that comes through our program is guaranteed a job if we're recruiting out of high school. And so we're engaged. So you think about a spoke and hub, each one of our 40 facilities typically has 3 high schools within a certain geographical area. So we've created this awareness campaign. One of the things that I heard here is, if somebody asked me, what do we need to do more of? We need to educate people on what skilled nursing and long-term care is. It's not what it used to be. It's not. There's 15 different positions in our company that when I go in and we talk to high school and we begin to talk about med aid, CNAs, LVNs, that type of stuff, and we begin to go through a list, administrative, then we get people knocking on our door and say, we want to be part of that. Now, anybody that goes through our program, one of the commitments is you need to be here for 2 years. I don't want to pay for it, and then they go someplace else. Yeah.
How much of the training happens in your facilities, and how are you able to manage that, since I'm hearing that that's a big challenge for a lot of the long-term care facilities?
Yeah, so all of the classroom education as it relates to if somebody wants to be an LVN or RN, I outsource that to the school. But I'm engaged in the creation of that curriculum. I want it taught our way with their disciplines. Now, after that, when they come back in, that's when we work with them to create a curriculum for ongoing lifelong learning.
Are they doing the clinicals in your places?
Yes.
And why do you have any insight into why that's such a challenge for people to find long-term care partnerships, and you're able to do it?
Here's what I found kind of interesting is I'm having to go to the schools, the 15 schools, and let them know I've got opportunities for clinical. I don't understand. I would think that they would be aggressively going after this. Now, there's exceptions to it, but for the most part, I've got a team that goes out and just socializes this with the schools. And then we work. Now, our clinicals, if you come do a clinical with us, you can work anytime you want. We run 3 to 4 shifts, 24 hours a day, right? A lot of the kids, they don't want to do the evening, right? And this is really tough work too. It's not sexy work, especially if it's, a CNA and LVN. And a lot of the kids, when they begin to come through from the high school perspective, they're looking at what they've seen on TV in the hospital and emergency room. And that's the educational process we give up front as well.
We have included the nursing industry, nursing home industry, or facility industry in work group 3 next week. And in work group 1, they were there as well. And we ask them to stay for the whole day and participate in the full proceeding. So it's a big focus of mine, is to make sure that we try to expand. That's why the federally qualified health centers are here and have been so prevalent in participating in the process as well. Because I think that they both present really great opportunities for new and different approaches to clinical. Yeah.
I think the other reason it needs, in order to be successful, is in a business environment, it has to be endorsed and believed from top down and bottom up. If not, it just becomes kind of, look what we're doing, and it never takes off. Yep. Is that it?
Any other questions from the panel? Thank you very much for coming back, Craig.
Appreciate it.
Yep, and we have next Mary, who is going to be virtual up on the presentation from, she is the nursing director at Vernon College. Mary, are you speaking?
Can you hear me?
Turn it up just a little bit for us. Try again.
Hear me now?
Okay.
Better? Wow. Thank you for having me today. I'm here to talk a little bit about the practice partnership that we have with United Regional Healthcare Center. We have a Department of Labor registered apprenticeship. With that partnership, registered apprenticeships with the DOL do have some requirements that you may not have if it is not a DOL apprenticeship. The Department of Labor requires that the apprenticeship be industry-led, that it is a paid job, so this is an actual job. They do have to be paid. It also includes that they have structured on-the-job learning, supplemental education along with that learning. There has to be diversity that reflects the diversity of the community that they serve. There also has to be quality and safety considerations, and they have to provide a credential. That credential has to be a nationally recognized credential. And that is what we have with our apprenticeships. We do have an apprenticeship for our LVN program and for our ADN program. And a big part of that is our academic practice partnership. Without that partnership, we would never have gotten to this point. United Regional has been very proactive in helping to get this program started. The partnership between United Regional and Vernon College helps us to bridge the gap between theory and practice. That is our main purpose. Collaboration is key. You've got to understand each partner's needs and what each can provide where those needs are concerned. So why did we look at apprenticeships? The issue was that nurses or graduates are entering the workforce with very limited clinical experience. We have limitations on how much clinical time we can provide for our students. The apprenticeship helps us to increase that clinical time to provide them with more hands-on experience. So we're able to enhance their clinical skills and their critical thinking abilities because they get those additional clinical hours. We were lucky enough to have United Regional recognize the need to increase our hands-on clinical exposure so that we could improve the clinical skills and critical thinking. We've had many discussions over several years about this issue. Another major focus for a major factor in deciding to implement the apprenticeship for United Regional was include their issues with recruitment and retention. And by providing this opportunity for students, that we are seeing some better opportunities for recruitment and retention at United Regional. So why partner? Well, let's move on to enhance clinical learning. That's a big part of it. Resource sharing is also a big part of it. We are a small rural educational institution, so we don't have the resources that many of the larger colleges or universities might have to be able to procure funding to get different things started. So partnering allows us to seek funding that might not otherwise be possible. It also helps us to create programs that might not always also be possible. And the academic practice partnership also helps us to improve student outcomes. And ultimately, if we improve student outcomes, we expect that that will also improve our patient outcomes. So the process itself took almost a year from initial discussions to develop. We implemented the LVN apprenticeship program in January of 2023. At that time, RN was not considered an apprenticeable occupation, but the Department of Labor changed that, and about 7 months later, we were able to get an apprenticeship with our ADN program. Collaboration between United Regional and Vernon College and the Texas Workforce Commission was instrumental in making the conception of this program a reality. It took all three of us working together to make this happen. As far as funding is concerned, the Department of Labor provides $6,000 per apprentice for this program. We were able to provide a little bit of additional money for preceptor recruitment and retention, thanks to our NSRP grant. But what it all boils down to is that $6,000 is nice for United Regional. They receive those funds, but the vast majority of the cost of this program is on United Regional. So they have a very large financial investment in the students that are involved. This next slide shows a poster that Andrea Anderle created. She is our representative at United Regional, who really worked very, very hard, diligently to get this program started. She was the key to getting this process in place. And she added not just that recruitment and retention was an issue. You'll see on the poster that she, in the introduction, she said, we have had a steady decline in the number of graduate nurses entering our nursing residency program since 2019. That was a big issue. The decline was causing a great deal of concern. Of course, COVID started right about then, so we know that had something to do with it, but those numbers still have not gotten up to where they were pre-COVID. I'm going to focus more on the outcomes on this poster, just to kind of give you an idea of what they do. When they ask for applications for the apprenticeship program, they make the decision which ones to hire based on input from Vernon College, from the nursing program, from the instructors, to make sure that we get students involved who are a good fit. We don't want to bring in students who are possibly a reentry student or a readmission student, because their chances of success are not quite as good. We want those students to focus more on their didactic and not get bogged down by having to work extra hours. Once they are chosen as an apprentice, the United Regional takes them through what she calls a speed dating event, where they actually sit with managers from each department in the hospital. We do about 10 minutes with each department, and then the department managers get together afterwards and say, I want this one, I want this one, I want this one. And they make the decision where to start that student based on that speed dating process. Now, the apprentices are paid hourly wages for all their academic clinical rotations. They do their curriculum is no different from any other student in the program. They attend the same classes, they attend the same clinicals with all other students in the program. The difference is they have to complete additional clinical hours as an employee of the hospital in their institution on top of what they are required to do for clinical. They have to have a total of 36 hours a week in clinical. So if they do a 12-hour clinical that week, they need to do an additional 24 hours of work as an apprentice at the hospital with a preceptor/mentor guiding them along the way. If they do 18 hours of clinical in a week, then they need to do an additional 18 hours of apprenticeship with the hospital. And it doesn't matter whether those clinical hours are at United Regional or at North Texas State Hospital or at a long-term care facility. United Regional pays for all of those. All their clinical hours are paid. The apprentices do work side by side with a dedicated preceptor. They do everything they can as a student. So if they are checked off, if they have had the didactic content to be able to start IVs or to give injections, they are allowed to do that as an apprentice, as long as their preceptor is with them supervising. So it works out very well and gives them a lot of really good experience that they would not otherwise get. Yeah, this next slide, I don't know if you'll be able to read it really well. This is our RN nursing apprenticeship model, and the following slide has the LVN. I'm just going to kind of outline the differences between the two because they are basically the same except for a few things. For an RN apprentice, it has to be a 2-year program and must include at least 496 hours of related classroom training and 4,150 hours of paid on the job learning work / hands-on clinical training, and that includes their clinical hours. One nice thing about this, our RN students do not enter the apprenticeship until their 3rd semester in the program, but any hours they have had, either didactic or clinical, before entering the apprenticeship count towards those apprenticeship hours. So that helps a little bit. Students must receive at least 1 wage increase during their first year during the 1-year time frame that they're in the program. And they have to have one-to-one support. Again, 50% of their credit 50% of credit or time earned previous to entry into the program can be counted for their apprenticeship hours. The main difference between the ADN and the LVN is that the LVN must be a 1-year program. They are only required to have 144 hours of related classroom training and 2,000 hours of paid on-the-job learning. So, because of course it's a shorter program, they aren't required to have quite as much, but the vast majority of the rest of their requirements are the same. So our story, apprentices to date, we have had 6 LVN apprentices complete the program. We started with 7, 1 was not successful. She dropped out of the program completely, including the LVN program, not just the apprenticeship. They could choose to drop out of the apprenticeship and continue in the LVN program. She chose to drop from both. She did return the next semester and is doing well. We started with 7 ADN students also. One of those was not successful, and she is actually coming back this fall. So we expect to see her next week. Currently, we have 7 LVNs and 7 ADNs in the apprenticeship program. So these are new apprentices for the program. As far as our educational outcomes, grades, successful apprenticeship participants also on almost also on improvement in grades following program entry. We saw improvements ranging in their GPA ranging from 0, because that student already had a 4.0 GPA, to 0.34 points. To date, all apprenticeship participants, that's LVN and ADN, have tested and passed their NCLEX on their first attempt. We're very proud of that. We have seen an increase in confidence and critical thinking in all our apprenticeship participants. The apprentices and faculty report that they have an increase in confidence, critical thinking, not only in the participants' clinical abilities, but also in their course studies. So it's across the board. That experience that they're getting in the clinical is helping them in their didactic, in their classroom courses also. Some concerns that we generally hear from the students include that it's just too much time. Too much time spent in the clinical, too much time having to work extra hours on top of that to be in the apprenticeship program. So they're worried about the stress, they're worried about balancing work, balancing study time, and whether they can handle it. So what we tell them is that it does require some good time management skills. If you don't have good time management skills, you're going to struggle here. But many students don't apply for the apprenticeship program because they have such concerns about the time to study and other obligations. So it's not for everyone. They have to take that into consideration. They've got to weigh their personal, their educational, their employment commitments before they apply to the program. We do tell students that, and this is something we have found, that prior to implementation of the apprenticeship program, we had a lot of students who would do their clinical hours and then work another 24 to 36 hours on the weekends so they'd be able to maintain their lifestyle. And when we did the math, we found that, especially for students who were having to work a number of additional hours, doing the apprenticeship plus the required hours to meet that 36-hour requirement from United Regional was not a stretch. As a matter of fact, a lot of these students would actually be working less and still be maintaining full-time employment with United Regional. So it actually worked out pretty good for those students. As far as employer outcomes go, one of the really big boons to this program is that training time is significantly reduced with our apprentices. Up to 50% less training time required after graduation, which has been a huge help to United Regional. Another advantage is that these students as graduates have already been encultured into the unit that they plan to work on once they graduate. They've already worked on that unit. They're familiar with their fellow employees. They know everybody. They go to the baby showers. They go to the birthday parties with this group of nurses because they've gotten to know them and they've become part of that unit's culture. And that is huge for those students or for those graduates. There's also, we have found a huge amount of reduction in stress after they graduate from the program. What Andrea likes to tell the story about when we had externs who would come into the hospital after graduation, they would cry daily on their way to work because they were so stressed out. They were so worried. They, so much going on. None of the apprentices have that. She says none of the apprentices have cried on their way to work, cried in the car when they got there, cried in the car on their way home, which is also a pretty good indication that this program works. We really love to hear that. And then critical thinking as graduates, as new nurses, as novice nurses, has been much improved in this group of students. Our lessons learned, communication. That's the biggest issue we've come across. We learned early on that communication is key. Trial and error can be a great teacher. I'm sure we all know that. We've got to have open discussion between the clinical site and faculty when choosing students for the apprenticeship. We have to make sure we're sharing grades and providing consistent feedback and evaluation for all of our students. We did not have a specific a faculty member assigned to the apprenticeship students to keep up with the evaluation process. After the first 6 to 8 months of the program, we found that it really was necessary. So we have a faculty member assigned specifically to the LVN apprentices and one specifically to the ADN apprentices. And that person is responsible for talking with the preceptors, talking with the unit managers, talking with the students, getting evaluation information, asking how things are going. And that has proved to be very helpful. So having a process in place is essential to making this program work. Resources are very important. We've got to make sure that we are sharing resources because we are a partnership. We want to make sure that the majority of the work isn't being put on one of the partners. It's got to be shared. Learning curve. Sustainability. It's important to ensure that support, funding, all resources are shared. Responsibility for grants, programs, and people cannot be carried by one organization. Again, it's all about that partnership and making sure that we work together. Learning curve, as with any new endeavor, especially one this big, there is a huge learning curve. Keeping communication lines open and supporting each other and willing to compromise are key. I always tell people who ask questions, if you know somebody at that clinical institution, if you have somebody that thinks the way you do, that believes the things that you do as a nursing program, that's the person to talk to. They're going to understand what you're trying to do and what you need to understand their needs. They need to understand what your capabilities are to make this program work. So Vernon College United Regional, we're both very happy with the outcomes thus far and plan to continue the apprenticeship program. United Regional has this year budgeted for up to 23 additional spots. Right now, I know that when we started the program, they had almost 50 RN openings. Right now, today, they have 14, which is great to see. So that may decrease the number of apprentices that they need over the next year. But they do plan to continue the work, continue to provide this opportunity to our students. And we are very appreciative of that. There's just some contact information. Andrea Anderley, again, she's our representative at United Regional. And then my contact information. There's some registered apprenticeship information available on apprenticeship.gov if anybody is looking for additional information. Thank you.
Thank you so much, Mary, for being with us today and describing for us this apprenticeship program. It's a really unique model that does show us that a Department of Labor apprenticeship program can partner with an institution for moving forward and creating opportunities. So that's a positive aspect to this. So thank you very much. Next up, we have any questions from the panel? Okay, great. Texas Association's Community Health Centers, Preston Poole, will talk to us about their very innovative approach to apprenticeships across the state.
Hi, thank you very much. Yes, I'm Preston Poole. I'm from the Texas Association of Community Health Centers. I'm a policy research coordinator. And I guess we'll be coming to you with a little bit different point of view as we are in the very early stages of setting up our apprenticeship program. Really, I can talk to you about how we kind of got to the point where we decided to establish one and kind of where we are headed and why we think that this might be a really great solution for us moving forward. So I'm going to start to give you with the spiel about what FQHCs are again, just to remind everybody. So we're very unique in that we are located in our health centers are located in underserved areas. We are community-based and community-focused organizations. So we have boards where the majority of the board needs to be made up of patients. We are open to everyone, uninsured, Medicaid, Medicare, private insurance. It does not matter what your income level is, you will be able to receive care and not be refused care at our clinics. And we provide, full primary care, including many provide dental and vision. There are community health workers, nutritionists, whatever you need, we will find, and refer you to the services that you need. I have to give you we just got our new data for 2023, came out last week. So we are now at 75 health centers across the state, serving in over 127 counties, which I was told I get to add Trinity County back onto the map in a couple weeks, where we served 1.8 million patients across the state. So that's 1 in every 17 Texans through 6.7 million visits. So as the association, we are looking to always provide our member clinics with the resources that they need. And so in the past couple of years, there's been we have heard loud and clear from our members that workforce is something that needs to be focused on more by our organization, and to provide them more support, both on, what programs and resources currently exist within the state of Texas, as well as how can we help them as individual organizations move forward so that they can better serve their communities. So just wanted to provide, just a sense of the different areas that we are helping them in. Once again, partnerships. Our health centers are always looking to make partners, whether it's in direct care referrals to lab work or screenings or to specialists in their communities. Also with educational entities. So whether or not they're formal partnerships, memorandum of understanding with residency rotations, nursing clinical hours or mental health provider hours, or there might just be, a handshake agreement on, hey, when your students are looking for a place to perform their hours, send them, make sure they're giving us a call, and we'll see what we can do in our community. So as I said, we've been talking with our health centers for a while now, created a committee within our board that expressed to us the different needs that they've had. Providing all the services that we do, we have everything from physicians to nurses to LCSWs to MAs, right? So every provider type, and while every provider type is needed, I would say the loudest one that we've heard is the need for MAs. We were given stories about the issues of actually being able to operate clinics with because they don't have enough MAs, they were not going to be able to keep their doors open for the number of hours that they would like. They had the physician, they had the doctor, but they did not have the MAs necessary to actually take in the patients and keep things moving along. So not only are they not finding enough MAs or participants who are wanting to become MAs, because once again, in the state of Texas, you don't have to be a certified MA to work in a clinic. I know a lot of employers might require certification, but you can hire somebody, train them on your own, and they can be called a medical assistant and provide certain services. And so they were doing a lot of off-the-street hiring, friend of a friend, that kind of work. But there's still competition in that, right? So you're as a nonprofit entity that's trying to make costs as low as possible for the patients, you might not be able to compete salary-wise with the hospital down the street. You might not be able to compete with Walmart down the street that's paying $20 an hour for certain positions. So, so we're trying to find, what we're, at this point, a year and a half ago, we're saying, what could we possibly find that's going to help bring in new MAs into our clinics? There is also, an issue of when we bring in new professionals into our clinics, there's a mission about what an FQHC does and what they are trying to provide to their community. And that doesn't always mesh well with maybe someone who's not from that community. They don't understand the struggles or understand what that neighborhood might need. And so it might just be another job for them. But that's not what works best in our facilities. We want people to have buy-in, to feel part of the system, to feel part of the solution for their community. We then, did a lot of research on what solutions we could find. We found that our colleagues in other states, so other associations for FQHCs, in states like Michigan, Minnesota, North Carolina, Alaska, and Washington, where have been major resources for us, had already invested a lot into creating apprenticeship programs for their FQHCs. And ones, in fact, that their states had invested in directly into their association as the sponsor of their apprenticeship program. And they told us about their success in becoming and having both medical assistant apprenticeships, dental assistant, pharmacy tech, a lot of the baseline allied health professionals that they needed to operate their clinics. So a lot of the information they provided was very helpful. And so just, once again, a lot of the benefits of, right, these are workers hiring straight from the community, so hopefully they understand the needs. Maybe they've been a patient of a health center. They also talked about, people who already worked at the health centers, but maybe were the janitor or just a front desk staffer, but saw this as a way to move their career forward while working for an organization that they already cared deeply about. And so we saw this, as that meshed with our mission of what type of workers we were looking for. And then we also liked the idea of the adjustable, curriculum that an apprenticeship allows for each organization to have. While you might set up an apprenticeship one way it's not just all one apprenticeship type for for MAs. Each organization can say, well, maybe we need some more apprentices that focus on, the front desk staff type of information. So billing, coding, administrative work, or other ones that we want them to focus more on in the patient's room, patient care. So you're able to move that around as well as add additional coursework, right, beyond whatever curriculum you establish. That might be more about your organization's needs and culture and kind of really feeding into that concept. There are different types of apprenticeships. There are competency-based apprenticeships, ones that are able to be accomplished in a shorter period of time, versus I believe the last speaker, theirs was more based on hours. And so those health centers are, able to adjust on what might make the most sense for them. And so that kind of led us to where we are right now, which is we have established a program with 3 health centers that we hope to kick off in October. There will be 3 different health centers in 3 different completely parts of the state, with a total of 12 apprentices, just to kind of get our feet wet. But I wanted to provide this image to give you a sense of kind of what it's kind of taken and who we are having to work with in order to try to piece all of this together. I know the previous speakers are all kind of maybe like one organization doing it all, but we have had to work with a number of different partners to both get our own knowledge and competency up so that we can help run the program, but also to get our health centers knowledgeable, and have everything run as smoothly as we can when it's all kicked off. So we did work with the Texas Workforce Commission at first, mainly because we did see that Department of Labor funding that came through the state, and we saw that as a great opportunity to help us kick off. So we are registering with the Department of Labor. I believe our paperwork is about to be sent in officially, or might have been this week. they did a really great job of helping us understand what it was going to take. And then as we looked to find a curriculum provider, because once again, we are trying to create an apprenticeship program that all of our health centers can partake in. So that's not one community college, right? So we would have to create a different partnership with every community college if we wanted to do classroom, in-person classroom that way. So instead, we have set up an online learning curriculum that each health center could then, decide, do they want their apprentices to maybe do it all at the front end of when they get hired before they start doing their clinic work, or maybe they ask them to do it at night, or maybe they ask them to do it at the beginning of every day. But it kind of gives them, once again, that flexibility of deciding of when they're doing the knowledge-based learning versus when they're doing the clinical learning. So we partner with CareerStep, who is providing that online curriculum. We also found an organization, in that search, we found an organization that for short is HCAP up there, but represents Healthcare Career Advancement Program, which they are a partner of the Department of Labor, and they provide free technical assistance, including partnership building, navigating regulatory requirements, incentive funding guidance, so helping you to find funding availability, as well as hosting events, right? So that, once again, that knowledge sharing. So they've been on a webinar for us already. They're going to present at our annual conference this year, once again, trying to build that knowledge within our health centers about this type of opportunity and what it might mean for them. So that's been a very invaluable resource. Just kind of the state has, like I said, Workforce Commission, very helpful, but we enjoyed HCAP kind of really being able to hold our hand through this process as we fill out the paperwork and as we kind of choose what type of curriculum we want and moving forward. So we'll continue to move forward. Our hope is that as the others have LVN apprenticeships, that's the dream and the goal as we kind of move forward. We'll kick off in October. Ours is a competency-based program, so about 6 months is our hope, and then they'll be certified. And we really hope that this will, once again, improve retention with the employees, seeing that the investment is being made in their career path, as well as the buy-in into having earned this certification while employed, reducing costs for those employees, not having to pay for school, because the curriculum will be paid for by the FQHC, hopefully through the Department of Labor grants, and hopefully part of that grow your own mentality that our health centers have. Our latest report shows that health centers provided some type of training to a total of over 4,000 provider healthcare professional types in 2023, whether that's pre-graduate or postgraduate. There was some type of training. Could have been an internship, a rotation, a couple clinical hours here and there. But health centers are very interested in trying to make sure that as many health professionals get an experience in our communities as possible, especially in those rural areas where a lot of our health centers are located. Thank you very much.
Any questions from the panel? Thank you so much. And I appreciate you being here. I know that this was not originally your deal, but give Roxanne our best.
She will be there next Friday.
All right.
I promise she'll be at Worker 3.
All right. Thank you so much. Okay, so our last official panelist is Jack Dwyer, with one of our task force members with Dwyer Workforce Development. And their organization also has done a significant amount of work in the allied space and supporting the allied professions. He will be a virtual speaker. So, Jack, I'm turning it over to you.
Hi, everybody. Thank you for letting me do a presentation at our task force meeting. I don't know about you, but I've listened to a lot of intelligent, smart people that, have some great things to say, have some great ideas, but it's been a long day. So I promise I'm going to be quick. So I have no PowerPoint, but I believe that our handouts were distributed to everybody. And so what I'd like to do is, before I go into, I'm the founder of Jack and Nancy Dwyer Workforce. And before I go into all the great things that we're doing at the workforce, I really need you to understand a little bit about me and my companies. So most of my companies are located in Baltimore, with the exception of one company, and that's my nursing home operating company, management company, and that's in Victoria, Texas. So I'll give you a little background about the companies in Baltimore so you understand why I'm doing what I'm doing. So I own the largest bank headquartered in Baltimore. It's a $5 billion bank called CFG Bank. But the unique thing about CFG Bank is that 60 to 70% of the loans that we've made are done in the nursing home and the assisted living space. So I've been doing this for about 45 years. And, that's the total focus is in that space. So I have another company called CFG Credit Fund One, and that also lends in the nursing home and assisted living space. So I created that company at the beginning of the pandemic, and we did about $6 billion worth of loans in the nursing home and the assisted living space. I own another company called Capital Senior Care Ventures. It owns, leases, or manages about 100 nursing homes throughout the country. I have another company called Capital Health Group that owns, leases, or manages about 50 assisted living buildings throughout the country. So needless to say, so familiar with the workforce problem that we've had. And it's been going on for 15 or 20 years. So COVID just exasperated the issue and the problem that we have. And so, for years, I'm listening to people complain about the workforce problem, but nobody ever does anything about it. So, and I commend the governor for setting up the committee and, doing something about it. But about 2.5, 3 years ago, I said, look, I'm going to do this. If I have to do it on my own, I'm going to do it on my own. So I came up with this idea. I took a couple $1 million from the bank, seeded the Jack and Nancy Dwyer Workforce Company. And the whole mission of the company is to solve systemic poverty and to solve the workforce problem in the healthcare industry. And so basically what I decided I would do is I had a partner. I've been operating 65 nursing homes in Texas for probably 10 and a half years now. 2.5 years ago, my partner said he wanted to be bought out. So the idea I had was I'll buy the 65 nursing homes in the Jack and Nancy Dwyer Workforce Company. And so that's what I did. We spent, $750 million. I left a bunch of equity. My partner left some of the equity to capitalize the Dwyer Workforce Company, in addition to the couple of $1 million that I put in from the bank. And the whole goal is to execute on that mission of solving systemic poverty and the workforce problem. So basically what we do is, and we're open in Texas, Florida, and Maryland. And so we've probably trained about 4,000, we've created 4,000 jobs by, partnering with community colleges. We'll pay for all the training. And what we do is we go into poorer neighborhoods, either through ministers or pastors, and we try to convince people, in the neighborhood that there's this fantastic career path in the nursing home and the assisted living industry. And a lot of them don't even know anything about that. So we try to seek them out. And a lot of times when you go into the poorer neighborhoods, there's issues with childcare, transportation, housing. So the company, the profits that come in to the nonprofit Jack and Nancy Dwyer Workforce Company, They're spent towards paying for their childcare, paying for their transportation, paying for their CNA training, and then paying for housing if they need it. And so after we train them, we'll place them at jobs with basically any nursing home in Texas. I have clients because I lend all throughout the country in the nursing home industry. So my clients, I probably have 5 other clients in Texas that have 150 nursing homes. So I have plenty of opportunity to train people and put them at jobs at, my clients' facilities, my facilities, or anybody's facilities for that matter. So, and the key to the success, well, first of all, the company, I still manage the nursing homes. And if I do my management job properly, which I've been doing for 12 years, they make somewhere between $40 to $60 million a year. So I'm spending $40 to $60 million to execute on that mission of, going into poor neighborhoods and show them this great career path that they can, follow. So if they stay at the company where I place them for more than a year, then I'll pay for their college education to become an RN through the profits of the Jack and Nancy Dwyer Workforce Company. So, I heard somebody else talk about retention rates. So the fact that one of the main things that we do at the company is we have a case managers that follow each person that we train, and they talk to the employer, because there's situations that happen, with people that are newly employed. They could have an issue with their child, and, a lot of times they just wouldn't show up for work and they'd wind up getting fired. Well, now everybody communicates through our case managers. And as a result of that, our retention rate has been it's been about 86%. And we've been doing it for about 2.5 years, like I said, and we've already trained over 4,000 people and placed them at jobs. So it's an amazing thing that we're doing, and we want to do it on a national basis. But the fact that I have the Dwyer Workforce, it's now called, the branding of the nursing homes are Well Central. But the fact that we have 65 rooms of Texas is we want to spend a bunch of money in Texas. That's what we're all about doing. And we're all about continuing to grow Dwyer Workforce. And we will ultimately do it all throughout the country. But right now we're focused, mainly in Texas and Florida and in Maryland. So my idea is, we have a lot of money to spend, and I think we can make it go further through partnerships, with the, government in Texas or different community colleges. And, like, for example, SB 25. I mean, I'm paying for college education through, my Dwyer Workforce Company. But if we could combine or figure out how to utilize both programs, it's just that many more people that we can train to, help alleviate the issue. I mean, so as far as I'm concerned, I'd love for the workforce panel to, try to figure out ways where they can spend the Dwyer Workforce money, and, we could do some more good for creating more jobs and solving the workforce problem that we have. That's it.
All right. Well, thank you very much. Okay, everybody. Any questions of the okay. We have 2 folks who have signed up for public input. So, Maureen, do you want to?
I do.
Okay. Yeah. So you could go first. Jessica, you can go after Maureen. And is there anybody else? Okay, cool. Yeah, that'll be great. So this is Maureen Milligan with Teaching Hospitals of Texas. Dr. Milligan, if you want to be specific. And then Jessica Boston will be with the Texas Association for Home Care and Hospice.
Hi, thanks for having public input, and thanks you guys for the work you're doing on this work group and this task force. It's really impressive, just being here today and hearing all this. So, lots of stuff. So, congratulations. Please let us know how we can help, if at all, in the work you're doing.
Just make sure you're there next week.
Yes, ma'am. So we did want to talk to the full task force, just kind of to tell you a little bit about where we're coming from, our perspective from Teaching Hospitals of Texas. And so I do have a handout. I'm going to go through it really quickly because I know you want to go really fast, and I can do that. So Teaching Hospitals of Texas, you can see our mission on that second page after you see who I am. And so you can see who we are, but one of the key parts of our mission, 3 parts, one part of that mission is training, workforce training. And so our members do a lot of it. We referenced the study that we did a couple years ago, a little picture of it. But for example, Harris Health trains over 5,000 students, clinical training. That's not the physicians, that's other students. You got 3,500 or so from Parkland University Health, 4,000 and more from UTMB. So lots and lots of training of all kinds of health providers go through these teaching hospitals. We got involved in this really during the pandemic, going on to the next page, because so much was going on for the nurses, and we wanted to know how they were doing it, what was going on, and was there any way that we could help them? What we heard from them is, yes, what you could do is get us support for preceptor funding. And, that was new concept to us. We had no idea, so we really had to learn, and they educated us what that meant. So preceptor, as you guys know, is 1-to-1, usually at maximum 1-to-2 training. And these are nurses in the clinical setting that are doing their full load of work, as you know. And so what they said is, oh my gosh, with everything going on during the pandemic and the shortage of nurses, and now we have to precept, it's really a strain. So any kind of support you can give, a pay differential like $2 an hour, they said that would make a big difference to getting more nurses. Historically, our understanding is, and we talked to our chief nurse executives, that historically this was part of a nursing mission. So it wasn't something funded. They did it because of that's who they were. And again, you guys can speak to that better than I can, but we did ask folks and say, is that right? And they said, that's right. And so what they said is all these things that happened recently, though, there's a lot of stress on being a preceptor. So please, how you can help us is kind of socialize this idea and see if we can get some support for preceptors. The other thing they said that was important was clinical innovation grants. So lots of ideas. And you heard so many ideas today in innovation. Lots of those things are working. And so funding to go to clinical sites to do innovative things. And we'll talk a little bit more about where funding is today and why we're asking for a little bit of a shift in that funding. But they said, please do that for us. And then also some ideas about faculty and clinical site coordination and support. You heard from that, like the Board of Nursing, their 2024 study now is picking up on the 2020 stuff that they did and others about the importance of that integration, as well as workforce stuff where you talk about the schools and the actual site, the work sites, and how you blend those. Next slide has a couple of pictures. I'm going to go through them real quickly, but why are we talking about clinical innovation and why did we pick up this idea from our chief nurse executives? What's the issue in terms of workforce? What's one issue? And again, this is our little narrow perspective on your broad world of what to do about workforce. But our little narrow perspective from them was, please support clinical training and preceptors. And so we kind of looked at the data, and thanks to Pam and her team at DSHS, you've heard from her, we said, what's the data? And we were looking more broadly at allied health, but little data in the way that they do it. So we said, let's focus on nursing. So when you look at the nursing data, that first chart there, what's the primary obstacle to accepting qualified nursing students into nursing schools? Lack of clinical space. It's been that way since 2010. So we're like, okay, that's the issue. It supports what the nurse executives were telling us is like a component there is having preceptors to do that clinical training. When you look at clinical training, lots of conversation today, but you look at this little U-shaped kind of curve here. This is didactic training. It's median hours in a didactic setting, and then you get into the simulation and stuff. Again, this is data from Pam. But if you go off to the right, that's the median clinical training hours. So about a third of the time in general is clinical patient care facing hours. And so again, the focus really important to go to the clinical site. But if you look at where lots of the innovation investments are, lots of the investments in nurse workforce are at schools of nursing. That's great. We don't think that's problematic, but we think it has to expand when we see the issues on the clinical side, and that's really the pinch point, in terms of a lot of these issues today. So I know you're big on accountability, so we want to say, okay, well, what about accountability? Clearly, you can put that into the programs, but look at the next chart. Schools of medicine, graduate medical education. Texas had this similar problem with residencies about 10 years ago. Remember, where we were losing losing docs because they couldn't find a place in Texas to do their residency. So the state set a goal of, hey, let's have 1.1 residencies for every one medical school graduate. So not only can we keep them, they're not going to California after we've paid for their school and all their investments in them, but let's grab those ones from California. So let's set a goal of 1.1 residencies to one medical school grad. So they started an investment, I think it's $16 million in the 2014-15 biennium, increased that by 14,000%. And so in 24-25, they've got almost $250 million going into residency support in Texas. And you can see the data. This is from the Texas Medical Association. It's been successful. So this goes to the accountability and proof of concept generally in terms of investing in the clinical side of education. You can see from their data that not only did they achieve that 1 to 1.1 long ago in 2018, but now they're at 1 to 1.23. And some people are saying, hey, let's do 1 to 1.4 and just really get a lot of the other investments that other states have made. So we would offer that, Victoria, as kind of proof of concept about doing the investment. And you can really, we think, support increased clinical site investment. Just want to point to the clinical grants that we talked about. That's one of the things that the nurses also said, hey, put these in clinical sites. By the way, clinical sites would be anything that the Board of Nursing says is a preceptor site. So hospitals, long-term care facilities, SNFs, and so forth. Anywhere you could have a preceptor is where we want to have those funds go. Urban, rural, we think that's really important. So don't see me as just a hospital for purposes of this. But the other thing about those clinical site grants is that you can address more broadly than just the preceptor issue. And so here's some data from the American Nurse Association. If you wanted to think about, we've heard about these first-year nurses. They go in, they finish their nurse training, they go into a clinical site. Their data shows that nearly 20% of those first-year nurses leave the profession. So think about that for a minute. That means all the investment in the funds and the programming you put, you're losing nearly 20% of that. That's a national data set. Pam may have, I'm looking over Pam, may have data about that in Texas, but still it's a huge loss of funds. So if you put money into clinical innovations, residency programs, for example, to keep those nurses, get them comfortable with what they're going to be facing once they get in there and support that. So you can, with clinical innovation, address this retention issue first year. Retention issue on the other end, you've got new students coming in and leaving, but you have nurses who are getting towards retirement age, find innovative ways to keep them engaged, right, and stay in the profession a little bit longer. The other point I want to make, you've heard a little bit about this, but there's a term for it I learned from the advisory board, which is the experience complexity gap. And we've heard about this. You've got a lot of newer nurses coming in with less experience, especially post-pandemic, maybe less clinical experience, at the same time that the nursing job is getting more and more acute, more technical, and you're losing your experienced nurses. So you've got a shift in the workforce where you have less experienced nurses at the same time that the actual work is getting more complex. Why am I talking about this? Because we think that the clinical innovation grants could also support that kind of situation. How can we deal with that as clinical sites to not only train the students, but retain them and then address this clinical, this gap difference between the education of the students coming in and the needs and the loss of your retired, your could-be retiring nurses. So So our recommendations, next page, just high level. Basically, our recommendations fund Senate Bill 25. That included these kinds of clinical recommendations, but it didn't include any funding. We also want to make a pitch to invest in data analytics. Texas Center for Nursing Workforce Studies, I think, was created in 2000. You said it was a little later. I might be wrong on this one, but 2003. All right, that's what this says. Good, a little data check. So 2003 by Rep. Vicki Truitt and Senator Kyle Janik invested in it, and you can see the fruit of that kind of investment in data and analytics and workforce. And so we think that kind of investment more broadly would generate more broad impacts and actionable data for folks like you to make decisions about how to improve workforce. I just separately want to throw out there's also an unfunded program at HB 400, which is behavioral health. The big program, Behavioral Health Innovation Grant, another great program that was socialized through the legislature and passed, but again, not funded. So we think that supporting these kinds of programs would be really helpful. I think I went a little bit longer than I wanted, so I apologize, but I think I talked really fast.
You did great. Thank you. Jessica, go ahead.
All right. Thank you so much. My name is Jessica Boston with the Texas Association for Home Care and Hospice. Thank you to you all for this invitation for public testimony. We're very grateful to participate in some of the work groups, but just wanted an opportunity to visit with you today about some of the things that are top of mind for the continuum of healthcare that is home care, specifically thinking about private duty nursing. This is a critical part of the healthcare continuum and relieving the pressure on hospital resources and providing that crucial care for medically fragile children right in the comfort of their own homes. This not only enhances their quality of life, but certainly streamlines healthcare delivery. But unfortunately, as we continue to hear from our providers, they continue to struggle to compete with other settings in order to bring nurses to this field, and leading to a critical shortage that has continued session after session. So we really wanted to join you today to advocate for continued support for increased funding. We've talked a lot about that today, creating programs and opportunities that support nurses across all settings, but really wanting to emphasize that you consider the specialized nature of PDN education to help address some of these unique shortages. With an emphasis on PDN, we really feel that this will enhance the quality of life for those in need, but also promote accessibility and sustainability to our communities. Financial incentives also play a crucial role in attracting these individuals to the nursing profession. Again, talked today about offering scholarships, loan forgiveness, and other financial incentives to reduce these barriers to entering the field. But again, wanted to offer, thinking about how to offer this for the specialized area of PDN. To include PDN ensures that nurse training programs are part of a broader strategy to address workforce shortages and can prioritize these incentives to not only attract individuals to the nursing profession, but also ensure that they're adequately trained to meet the complex needs of these patients and exposed to the specific PDN patients. Additionally, we encourage you to include PDN nursing training programs to expose future nurses to the critical skills and care essential for ensuring this vulnerable population receives the support they require. Certainly expanding opportunities to PDN exposure and education not only addresses the pressing need, but continues access for this valuable service. And certainly, as we build the more robust nursing workforce, we also want to foster strong partnerships between healthcare providers and educational institutions. These partnerships are essential for creating effective training pipelines that equip nurses with skills and knowledge needed to succeed in this field. This collaborative approach will ensure that not only we're training more nurses, but also preparing them to excel in specialized areas. And then finally, I think this did come up once before earlier today, but in addition to the need for nurses in the home care setting, we also just wanted to touch on really thinking about the individuals who are providing those ancillary services that are also in critical shortage. As we see it, this part of the healthcare workforce in Texas has experienced the least investment and could prove to be quite an oversight as our population ages. These workers not only could help mitigate the nursing shortage by providing delegated services, but through proper investment could become a meaningful part of the pipeline for the nursing profession. So thank you so much. I know y'all have had a long day, but we really appreciate the opportunity to speak with you today.
Any questions from the panel? Okay, thank you so much, Jessica. And that is it for our presentations today. I want to thank everyone on the task force. All of the presentations and handouts will be in the Dropbox. So you will have access to review those. Our next workshop is next Thursday, where we will be covering topic 3, which is the clinical training. So that'll be a very meaty, full day again. And then our last task force meeting will be September 3rd. Today was the heaviest public, meeting that we were going to have with this task force. So it was jam-packed. I think we'll learn a lot at our next one, but I hope it won't be this intensive. But but it might be. So thank you all for being here today, and we appreciate everybody's input.